Hi guys, good evening, good evening, good evening. Right, so yeah, sorry for the small delay that we had. थोड़ा inevitable था, technical challenge था, so we had to. But we are here. ठीक है. Good evening guys, good evening, good evening. Right, so yeah, हमने जो session plan किया है, I am going to walk through you to the entire surgery, all the important. You don't need to worry. यार डर के क्या करोगे यार, कुछ नहीं है. ठीक है. देखो, for about the surgery part, no, one thing I can assure you, we are going to spend next 4 hours, 5 hours, 6 hours or whatever it is, and we'll try to go and walk you through the entire component. ठीक है. At the end of the session, I can assure you कि general surgery को लेके you will be much more than confident and you will be able to sail through. I'm not going to make any huge claims कि ये हो जाएगा वो हो जाएगा, लेकिन बेटा if you go through the entire session, आप जब अपना नीट पीजी का एग्जाम दे रहे होगे, you will not feel कि जनरल सर्जरी में से ऐसा कोई क्वेश्चन या टॉपिक है which you have not heard about. ठीक है. That is my guarantee for you from this session. अच्छा, हाउ टू यूटिलाइज दिस सेशन, कैसे करेंगे, क्या करेंगे, हाउ आर यू गोइंग टू टेक इट फॉरवर्ड. बड़ा सिंपल सा लॉजिक है. आई वांट यू टू सिट, रिलैक्स, listen to every single point that I'm going to tell you. I will tell you the logic, I will tell you the concepts, I'll tell you every single point that is for you to understand. I just want you to be there. How do you use it in an interactive way? हम एक काम करेंगे, जब भी मैं आपको कुछ भी दिखाऊंगा या फिर सिखाऊंगा, before I tell you something, you should be able to guess that answer, and that is why we're going to revise it so that you stay on spot. ठीक है. तो every single topic, अगर मैं कुछ डिस्प्ले कर रहा हूं, before I ask you anything, I tell you anything, you have to recite the answer. अपने अंदर बोलना है. If the chat box is there with you, type it. अगर आपको लग रहा है आप नहीं टाइप कर पाओगे, कोई दिक्कत नहीं है. Just make sure you know or you are able to recite the answers as well. ठीक है. Beta, for BLS, I will start. Don't worry about it. We've been getting constant queries. We will do it, but let's concentrate on NEET PG right now. ठीक है. तो the first topic that I'm going to talk about in the general surgery is going to be an image-based component, which have been asked again and again, right? So they'll ask you, they'll show you an image like this, and they'll ask you, what is this image of? We all know it's a drain. ठीक है. Now, whenever you talk about drains, first of all, you should know what is the material of the drain. Now, I'll give you a trick. ठीक है. The trick is, अगर if you see this drain, कोई भी ऐसा ड्रेन आपको दिख रहा है, उसका कलर देख लो. अगर वो ऑरेंज या येलो इन कलर है, द मटेरियल इटसेल्फ इज ऑरेंज और येलो, इट इज बेसिकली लेटेक्स. ठीक है. अच्छा, क्योंकि ये लेटेक्स का बना है, इट इज गोइंग टू बी रबर एंड लेटेक्स आर सेम. ठीक है. बेटा सिस्टमिक का बाद में. नाउ यू नो द मटेरियल इज रबर और लेटेक्स, यू नो इट इज ओपन कंपोनेंट. यहां पे कोई बैग अटैच नहीं, तो ये ओपन ड्रेन है. तो पहले तो आप देख लोगे मटेरियल क्या है, देन यू विल से दैट वेदर इट इज एन ओपन और अ क्लोज सिस्टम ड्रेन. क्लोज सिस्टम ड्रेन विल बी कलेक्टिंग इन अ बैग और इन अ बॉक्स और इन अ डब्बा. यहां पे कुछ है ही नहीं, तो ये ओपन ड्रेन हो गया. फिर आप देखोगे, इज एनीबडी सकिंग और एनीबडी पुलिंग दी secretions out, or is it draining because of gravity? यहां पे कुछ लगा ही नहीं है. Nobody is pulling it, nobody is attached, nothing is attached. It's a passive drain. So first material, it is going to be latex. Second, you'll talk about whether it is an open or a closed system drain. It's an open drain. Is somebody pulling? Nobody pulling. It's a passive drain. तो पहले आप देखोगे material क्या है. So this entire drain that I've displayed in front of you, this is a corrugated drain. Now this, because it is latex, it is going to be yellow or orange in color. It's an open drain. It's a passive drain. Same way, you'll see image number 2. Now this image number 2 was your previous exam question. तो क्या है ये? You see there's a tube. Again, it is yellow in color. It is made up of latex. ये rubber का है. ठीक है. Now because it is rubber, I know it's a tube. It's a drain. Nothing else is there. No fenestration. Nothing. It's a simple tube. ऐसा कौन सा drain है जो सिर्फ tube की तरह आता है? Now this is your Penrose drain. Now Penrose drain, again it's a latex drain. If you want to add, I can say this is an open drain. ठीक है. If I have to add points, this is going to be an open drain. This is going to be an open drain, and this is also going to be a passive drain. ठीक है. Right? This is the baseline that it exists in terms of Penrose drain also. फिर एग्जाम में they can ask you a drain like this. This is again, you can see it is transparent in color. Transparent is basically silicon. Silicon is biologically inert, so hence we prefer using silicon. Then you see there is a line that is right in the center. अब ये जो line है ना, ये radio opaque line है. This line can be green in color, it can be orange in color, it can be red in color. लेकिन whenever you get this line, it basically tells you that it is a radio opaque line. तो ये pleats or a sheet of drain. It is also a corrugated drain. लेकिन this time because it is transparent, I will say it is a silicon based drain. ठीक है? तो it's a corrugated drain, it's a silicon drain. It is preferred over latex based drain. और ये हमारा star performer. This is been asked multiple times. बार बार पूछा गया है क्या है ये drain? This is your Romovac drain. अभी रोमोवैक ड्रेन क्या है? क्योंकि पूरा कलेक्शन एक डब्बे में आके अंदर कलेक्ट हो रहा है, बिकॉज इट्स इन विद इन द बॉक्स एंड द कलेक्शन इज हैपनिंग इन अ क्लोज सिस्टम, इट्स अ क्लोज्ड ड्रेन. फिर आपसे पूछ लेगा इसको कोई पुल कर रहा है कि नहीं कर रहा. व्हेन यू प्रेस दिस, नो दैट प्रेस इटसेल्फ व्हेन यू ट्राई टू रीइन्फ्लेट इट बैक, इट इज एक्सर्टिंग नेगेटिव प्रेशर, सो इट्स एन एक्टिव ड्रेन. ठीक है, इट्स अ रोमोवैक ड्रेन, इट्स अ क्लोज्ड ड्रेन, इट्स एन एक्टिव ड्रेन. इतना ही पढ़ना है, नथिंग मोर देन दैट. ठीक है, नाउ दिस everybody knows it's a Foley's catheter. Foley's catheter के parts देख लेना. There is a balloon inflating channel, there is a urine collecting channel, there is a balloon that is present and the eye is present. The usual question is, what are you going to use to inflate the balloon of the Foley's catheter? I will be using distilled water. I cannot use air because it will float up. I need the bulb to be at the neck of the bladder. Second, I cannot use any crystalline fluids because if you use crystalline fluids, they will crystallize and they will block the eye of the Foley's catheter. You will not be able to deflate it. Okay? Now the question to you is, if you are unable to deflate a Foley's catheter, how would you go about it? क्या करोगे? What would you do? Come on guys, quick. If you are unable to deflate a Foley's catheter, how do you approach that? Would you overinflate it until it bursted, or would you like to go with USG guided puncture of the balloon? यही दो ऑप्शंस हैं. ठीक है, तो ये क्वेश्चन ऑलरेडी हमारे INICET में एक बार आ चुका है, नीट पीजी में भी पूछा हुआ है. तो आंसर इसका क्या है? USG guided balloon deflation and then removal of the Foley's catheter. फिर आपसे कलर कोड के Foley's catheter पे पूछ लेगा कि क्या कलर कोड्स है, हाउ डू यू रिमेंबर इट. ठीक है, इन व्हाट कॉन्टेक्स्ट. सो Foley's catheter का जो कलर कोड है इसके लिए अब वेरी सिंपल निमोनिक, वी हैव समथिंग कॉल्ड एज गोरी इज वेरी ब्यूटीफुल. ना हर गोरी वेरी ब्यूटीफुल नहीं होती है, लेकिन निमोनिक के लिए याद रख लेते हैं गोरी इज वेरी ब्यूटीफुल, राइट. ओके, पॉइंट टेकन. आई ट्राई टू कीप द क्लास. सी ऑल दोज लिसनर्स हु आर वाचिंग मी, every single point that I tell, I'll be telling in English. The same point I'll also repeat in Hindi. I will not say anything in Hindi which I've not said in English. Okay? So trying to cater both end of the crowds. So let's be a little bit cordial about it, but I'll try to maintain most of it in English. Okay? So this gory, very beautiful is the mnemonic. G is your green. Green is 14 French. Orange is 16. Red is 18. Yellow is 20. Violet is 22. Blue is 24 French. What is this French? Right? Now the French basically means the outer diameter of the Foley's catheter. French is the outer diameter of the catheter, right? What is the French? It is the outer diameter of catheter. Now question is, how much is 1 French? 1 French is equal to 0.3 millimeters, right? 1 French is equal to 0.3 millimeters, right? That's the conversion that you should be remembering. Clear? Romovac also used as a non-negative drain. Beta, principle of Romovac is to create a negative pressure. Once it loses the entire pressure, you can use it as a passive collecting drain. But the original purpose of a Romovac design is to create a negative suction. Okay? We do a lot of things in wards, and they are not going to ask you in exam because they are not bothered what you're doing in wards. They are bothered what, how do you want to take it about it. Okay? So this is about your Foley's catheter. Do remember it. Very, very important. Next comes is this. Now this is a very, very important concept that you have. Now this is because the shape itself is tube. There is T-shaped tube. Hence it is called as T-tube. It is silicon drain. It is usually used in CBD surgeries or drains, and T-tube is removed after 10 to 14 days. My simple question is, why can't you remove a T-tube before 14 days? Okay? I'm saying the minimum time period, if you have put a T-tube drain, it has to be wait for 14 days. Okay? Why can't you remove a T-tube drain within 14 days? Any idea? But this session is more than enough for the upcoming NEET PG exam. It will be your confidence booster. It will give you an approach for the exam. That is for sure. Okay? Right. Why can't you remove a T-tube? Yeah. Why can't you remove T-tube within 14 days? Now, the concept is very simple. Give me 2 minutes. Okay? Now, take this as a representation of the abdominal wall. Okay? Now, this is the abdominal wall that you have. For the sake of understanding, I'm just going to depict, let's say this is the peritoneum that you have. This is the peritoneum that you have. And let's say this is where the liver bed is present, just for the sake of understanding. Let's say this is where the liver is present, and this is the right and the left hepatic duct, and the CBD was injured, I can say repair was done, and I put a T-tube. So I'm going to pull the T-tube towards this area, and this is how the bile duct is going to be there. Needless to tell you, it is going to go into the duodenum. If you just be more keen about it, you see the esophagus will be here, the stomach will be here, and the duodenum will continue across here. You will see the duodenum is going to be here. So this is going to go behind the duodenum and then open. There was a CBD injury, so I have put a T-tube. Okay. Now the T-tube will be put into the bile duct and it will be brought out of the abdominal wall. Okay. This is the placement of the T-tube that we have. Right. And this T-tube will now be connected to a bag, and this bag will connect, or it will collect whatever bile that has to come. Okay. That's the basic objective of how you're placing a T-tube. Now my question was, why are you not removing a T-tube before the 14 days, right? What is so important about it? Now, as you have put the T-tube and you have pulled it out, okay, how do you remove a T-tube? If you have ever attended a ward, you will know. In order to remove the T-tube, all that you have to do is you have to pull the T-tube out, okay? Because there is a hole in the bile duct, okay? I'm not going to go and repair it after I pull it off. So what do you expect? I am waiting for 14 days for a fibrous tract to be formed between the peritoneum and the bile duct, right? So there's a fibrous tract that is formed between the bile duct and the peritoneum. Once I pull this T-tube out, this fibrous tract will collapse. And the collapse of the fibrous tract with respect to peritoneum will create a sealing mechanism, and that seal won't allow the bile to leak out. So very common sense, okay? And that is why you're going to use T-tube and you'll keep it for minimum of 14 days. As simple as that, okay? So the reason why I'm keeping the T-tube for 14 days is when I pull it off, I should give the time for the body to create this fibrous tract, and that occurs within 10 to 14 days. And after that, you can pull out without any problem. Clear? Now, this is the carry-home message. Now, I'll give you a very basic question. There was a question that was asked in your INICET only. Which material of T-tube is preferred? Would you like to go with silicon or would you like to go with latex? Now, before you answer this question, you need to understand latex is biologically, silicon is biologically inert. Latex is biologically reactive. Okay? Now, my point is when I'm removing the T-tube, I need the fibrous layer to be formed. Okay? This, the tract has to be formed. Tract will only form when there is more inflammation, when there is more irritation. Who will cause more irritation? Who will going to create more irritation? It is going to be latex. So T-tube, no, preferably it is better on a latex when compared to your silicon material. Okay? So there are two questions on T-tube. Which is preferred? The answer is latex. Second, after how many days would you like to remove it? 10 to 14 days. Everybody got the concept right? Very good. Great. Okay? Chalo. Rushil, we have every topic being described. I will walk you through. Just stay tight, stick tight. We'll revise every single point there is. Okay? Now, another image that you can get is something of like this. This is called as three-ways Foley's catheter. Okay? In a three-ways Foley's catheter, what are the three different ways that you have? एक जो आपका है balloon inflating channel, the first one is balloon inflating channel, the second is urine collecting, the third is irrigation channel. So three-ways Foley's catheter is basically put for bladder irrigation, right? Again, if you want to have a pictorial representation, the concept is very simple. This is the bladder, okay? And this is the urethra that you have. When I put a three-ways Foley's catheter, now this three-ways Foley's catheter, when it goes inside, it will have two different channels that you have, right? And obviously here you have three common components. One is going to be for the balloon, one is going to be for urine, another one is going to be for irrigation. So what irrigation channel does is, when you flush the irrigation channel, the fluid goes in, it rinses the bladder. As it rinses the bladder, the fluid goes in, it rinses the bladder, it now goes into the urine collecting channel, and from here you can see the urine is going to come out. Okay, so this is used for bladder irrigation. The concept is very, very simple. It is used for bladder irrigation. Okay, now the question is, how do you localize among the three which is a urine collecting channel? देखो, जिस पे आपका color code है, that is balloon inflating channel. You will never confuse it. The question will be always, out of these two, which is a urine collecting channel and which is a irrigating channel? The concept is very simple. Out of the three tube, whichever is the largest luminal diameter, जो सबसे बड़ा मोटा diameter होगा, that is going to be for urine collection. The rest of them is going to be, छोटा one is going to be for irrigation. Is that clear? ठीक है, तो कल को एग्जाम में अगर पूछ लेगा, the number is 1, 2, 3. Out of these three, which is a irrigating channel? You know absolutely that. ठीक है, so you know where to pick your answers from. Now, another image that you can get is going to be an image something like this. ठीक है, you know there is, the component is there, you have a stillet inside, you pull it, it coils like this. Now it's like a pigtail, so obviously it's a pigtail catheter. Now question is not pigtail, the question is, if you get something like a pigtail but they are twisted in both ends, this is what we call it as DJ stent or double J stent. Okay? Now DJ stent or double J stent is usually used after doing a ureteric surgery or after doing a ureteric stone retrieval. My question to you is, your previous exam question, when do you remove the DJ stent? The removal of DJ stent is done after how many days? The removal of DJ stent is done after how many days? The answer is after 2 weeks. That is why our urologist friends makes a lot of money. 1, to put the stent, 2, to remove the stent. ठीक है, तो एक तो stent डालने के भी और निकालने के भी, एक ही पेशेंट के दो प्रोसीजर हैं. ठीक है, so hence it is going to be, yes, please do not make mistakes, DJ stent removal is after 2 weeks बेटा. ठीक है, चलो. Next comes is a tube like this. You cannot afford to miss on this. This is your nasogastric tube, also called as Ryle's tube. Now, what are the questions that they'll ask you in nasogastric or Ryle's tube? They'll ask you what is the length of it. It is 100 centimeters. Okay, it is 100 centimeters. Now, what is the purpose of nasogastric tube? There are two purposes. One is to decompress the stomach whenever you're doing any surgery, or let's say patient is having any small bowel obstruction. You don't want the vomitus or the aspiration to occur, so hence you're putting a Ryle's tube. Another one is for feeding purposes. Okay, as simple as that. Now they'll ask you, there's a previous exam question, how do you measure the adequate length of the nasogastric tube to be pushed inside the stomach? And the answer is your next rule. What is this next rule? Take the Ryle's tube from nose to earlobe, from earlobe to Xiphus sternum. Okay? Nose to earlobe, earlobe to Xiphus sternum. Whatever is the length, that length you have to push it in, and that is the adequate length of the nasogastric tube to be pushed. Okay? So all the important questions that are required to be answered from this image is right in front of you. Again, an important question that you have. Next comes a very famous catheter. Okay? Now this has been asked multiple times. It is what we call as the SBT tube, the great SBT, which is called as the Sangaskian-Blakemore tube. Now the question is, what is the primary purpose? What is the primary purpose of SBT tube? Okay? Why do you want to put SBT tube? What is the purpose? If you see a tube like this and they say, what is the point for it? Okay? Quick feedback. Why do you want to put the SBT tube? The answer is very simple. The S, absolutely correct. It is for bleeding esophageal varices to have an immediate control by creating a tamponade effect. Okay? Yes, that is the correct answer. Okay? Now, sorry guys. Sorry. So they'll ask you in the SBT tube, there are two balloons that you have. Sangaskian-Blakemore tube. One is a gastric balloon, another is the esophageal balloon. Simple, they'll ask you how much air has to be pushed. So both the balloon will be inflated with air. Remember, Foley's catheter ka jo balloon hai, that will be inflated by distilled water. Here it is going to be inflated with air. How much pressure in esophageal balloon? 40 millimeters of mercury. How much volume of air that you're going to push it in? That is going to be 300 ml of air. Okay? Beta, see again, I don't want you to overburden you with other components like Minnesota tube. There is SP, there is Sangaskin Blakemore tube. There's another tube. No need. Just remember SPT tube. Minnesota में 4 channels होंगे, यहाँ पे 3 channels हैं. Otherwise no need. वहाँ पे आपका gastric aspirating channel भी है, आपका esophageal aspirating channel भी है. ठीक है? So don't overshoot about it. SPT tube याद रखेंगे. That is more than enough. ठीक है? This was your previous exam question. They have given you in your NEET PG. They have given you INICET. This is your भोपू वाला drain which is called as Jackson Pratt drain. ठीक है? Now Jackson Pratt drain की speciality क्या है? How do you identify it? ठीक है? Now the Jackson Pratt drain is very simple for you to identify. There will be a balloon at the end. There's a tube and at the end there's a flattened surface with fenestration. This was a negative suction drain for abdomen, designed for abdomen. I cannot put Romovac in abdomen because it is tubed. So it can, because of negative pressure, it can suck the bowel. The bowel can go into the tube, hence causing the problem. To prevent that, they have created this flattened sheet, and this is what we call it as a fenestrated flat sheet, and this is safe in abdomen. It's a negative suction drain. Okay? Now, it's a closed drain. It's an active drain. Everybody knows it. No points for guessing. Okay? This was your first 11 images and their important points. Moving down to the next one. Now, this is something which they'll ask you again and again, they'll trouble you, but you should be prepared. It is the cannula's color code, the flow rate, both of them are equally important. How do you remember it? So before we move into the complete discussion, how do I remember it? By remembering a small mnemonic that you have. The core of the earth is made up of lava. The lava is going to be orange in color. Then you have the soil, which is going to be gray in color. On top of the soil, you have this beautiful green trees that is going to be present. On top of these green trees, you have this pink flower that is going to be present, right? On top of this pink flower, you have Nila Nila Asman, that is blue sky is present. Okay? There's a nice blue sky. So there's a nice blue sky that is present here. In this blue sky, you have the yellow sun, right? Now sun shines, and then beyond sun, you have universe. If you're not getting the feel of the universe, what I can do is, I can make few stars for you. Okay. Now, orange colored cannula is the largest cannula that you have. So, this is going to be 14 gauge. Gray is 16 gauge. Green is 18 gauge. Pink is 20 gauge. Blue sky is 22 gauge. Sun is 24/7, so it's 24 gauge. And violet is 26 gauge. Okay? So, this is the easiest way to remember the color codes of your cannula. As simple as that. Okay? Now, when you put across here, look at the same component here. So, I'll just quickly list it down for you. The first one is your orange colored cannula. The flow rate of the orange colored cannula is 240 ml per minute. Then you have gray colored cannula. The flow rate of gray color is 180 ml per minute. Then you have green colored cannula. Green is going to be 90 ml per minute. Then you have a pink colored cannula. Pink is going to be 60 to 65 ml per minute. Then you have blue colored cannula. The blue colored cannula is going to be 30 to 35 ml per minute. Then you have the yellow colored cannula. It is going to be 20 ml per minute. The last one that you have is violet. Violet is going to be 12 ml per minute. So these are your cannulas, their color codes and their flow rate. All of them are important. Okay? So these are the various color codes that you have. Okay. Okay. Guys, that is not my wife, that is my daughter. So if she is commenting something good about me, then it is going to be my daughter. Okay? Chalo. Put it across here. Now, the question that they ask you is, there are 3 questions that you need to understand. In trauma, What is the preferred one? Preferred will always be largest, that is going to be oranged. What is the most commonly used? The answer is gray. What is the minimum size that you should use? The answer is green. Okay? So preferred in trauma, most common in trauma, and minimum size that you're going to put. Okay? So do not goof up on these. Right? Preferred size of the cannula. The preferred size of the cannula will be your orange colored. Okay? Most common. Hi Adya, don't disturb. Most common is gray and minimum is going to be green in color. Okay? Chal. Now this is about the color codes and the cannulas that you have to remember. Coming back to now the spotters that you have. Now many a times they will come up with the instruments and they'll ask you a simple instrument and they'll basically give you just the images to identify. The first one, it is a needle holder. The name of this instrument is called as the Mayo-Hagar's needle holder. Now, how do you identify the needle holder? You see, this is your finger rings that you have, also called as your finger piece. Then you have this locking mechanism called as ratchet. This long is what we call as shank. This is what we call as joint, and this is what we call as mouth. The mouth of the needle holder is going to be small and it is going to be grooved. As simple as that. So, ye pehla. Another question, if they want you to go a little bit higher up, where exactly would you like to hold the needle with a needle holder? The junction is between the 2/3 and the 1/3. So 1/3 from the thread and 2/3 from the tip. Okay? The junction between the 2/3 from the tip and 1/3 from the thread is the site where I would like to lock my needle holder. Okay? That's another question that they can ask you. Then they can ask you another image like this. Now this is a fancy needle holder. Whenever you're using smaller suturing or smaller anastomosis, like a vascular anastomosis, or you're using a nerve anastomosis or a nerve repair or a small vessel repair, you will use this needle holder. This is called as the Castrovigi needle holder. Same, it has got a small mouth, but the Castrovigi is going to be on the work of pressure. So when you exert pressure, it locks. And when you leave, it opens. Okay? This is what we call it as the Castrovigi needle holder. Right? Now, after the Castrovigi needle holder, the next image is going to be this. Now, these are going to be a couple of confusing images that I'm going to show you, but very, very important. This is what we call it as the Adson's tissue holding forceps. Okay? Yeah, but after any microsurgeries, you can use Castrovigi. Okay? I told my use of Castrovigi because I do vascular component of it. So hence I use the word vascular or neural anastomosis. Okay? Now look at here. This is your Adson's tissue holding forceps. This is going to be your Gillies holder forceps, and this is your Brown Adson's, and this is going to be DeBakey's. Okay? Everything looks same. Okay? अगर आप देखोगे चारों के चारों images जो है ना, they look very, very, very similar. आप देखोगे कि Adson's tissue holding forceps, you see Gillies forceps, you see Brown Adson's, and you see DeBakey's. All of them are looking very similar. How do you differentiate with this? Okay? Now the two common ones are the Adson's and the Brown Adson's. How do you differentiate? Now very, very simple. Adson's tissue holding forceps will have only one tooth. Okay? There is one tooth and it locks like this. Okay? It is like a one tooth. It is basically like this. It just locks like this. Okay? This is your Adson's tissue holding forceps. Brown Adson's do not have any tooth. It has got serrations. It is like serrations. It just holds like this. Like it is like serrations. It is going to hold just like that. Okay? So Brown Adson's and your Adson's में फर्क क्या है? Adson's will have a single tooth. Brown Adson's will have multiple serrations. फिर आता है Gillies forceps और DeBakey's. दोनों लंबे हैं. Gillies में you will see tooth, whereas DeBakey is atraumatic. They will have no tooth. Fine serrations will be there. आई बात समझ में? तो I'll make it very simple for you. Adson's और Brown Adson's में फर्क क्या है? Adson's will have a single tooth. Brown Adson's is going to be having multiple serrations at the end, which are going to be smoother. Gillies में tooth होगा, whereas your DeBakey will not have any tooth. ठीक है? So Brown Adson's is atraumatic. Adson's is traumatic. Got it? Gillies is going to be traumatic. DeBakey's is atraumatic. Is that clear? Clear? Absolutely correct, beta. Now, next is your curved artery forceps. Remember the entire name. It's an Adson's curved artery forceps. If you do not have ratchet, If you have similar looking instrument but no ratchet, this is your sinus forceps. Okay? This is going to be your sinus forceps. Then you have something looking like a sinus forceps, but then there is a ratchet, and at the tip end it is going to have an interlocking mechanism. This is your Alice forceps. This is your Alice forceps. लेकिन Alice में ऐसे की जगह अगर मैंने ऐसे कप बना दिया, right? Rather than having like this, if I make a cup, this is your Babcock's. Okay? Babcock's is used to hold appendix. Now, rather than having जो आपका एलिस का था उसको निकाल के I made triangulated end. If it is triangulated end, it is simply called as, it is the lung holding forceps. This lung holding forceps is also called as the dual forceps. ठीक है? Now, if you have same end, लेकिन end पे there are openings like this, छेद के साथ ऐसे है, इसको आप बोलते हो sponge holding forceps. इसी को अगर आप curved करोगे तो ovum holding forceps. ठीक है? Straight it is going to be your sponge holding, curved is going to be ovum holding. ठीक है? Now, retractors, this is a very common one. If you have ever been an intern and you have assisted at least one open cholecystectomy, you have a position called as a chief retractor, where an intern is given a Devas retractor on the undersurface of the liver and then you pull it. Okay? So this is your Devas retractor. Now, if you have a retractor which is going to be two 90-degree turn, one 90 degrees here, another 90 degrees here. Okay? If you look at the two right angles, the first right angle is here and the second right angle is here. Okay? Two right angle turns, it is your Langenbach retractor. It is your Langenbach retractor. Same type Langenbach, but if it is wider, it is called as Morris retractor. This is again a very important potential exam question. It is on one end, it looks like Langenbach. On the other end, there are tooths. Okay? So if you have a retractor which has two types of holdings, right? On one end, you have Langenbach, the other one, it is going to be hooked one or a tooth one. This is what we call it as Zernes retractor. It's spelled with a C. It is called as a Zernes retractor. Now, a slightly curved, see, all your Langenbachs or Morris are going to be straight. If you have curved, this is what we call it as Doyne's retractor. Okay? This repeatedly asked, they've asked you a couple of times in our exam. No point for guessing it. This is what we call it as the Joll's self-retaining thyroid retractor. Okay? This is used for thyroid surgery. Same if you're using for parotid surgeries or any other site. If you're using for hand, you need another self-retaining retractor, you will use this. This is what we call as mastoid retractor. Okay? It's a mastoid self-retaining retractor. Same thing if you're using in the abdomen. This is what we call it as. Now, there's a difference between the Gallagher and Balfour. Okay? So, Gallagher जो है, it is going to be solid plate. Balfour, if there's a hollow plate, अगर छेद है, तो Balfour हो जाएगा. अगर straight, if the complete plate is there, it is Gallagher. Same setup, अगर यहाँ पे छेद मिलेगा, if there is a hole here, if there are holes here, then it will become Balfour. ठीक है? If it is a solid plate, it is your Gallagher. सॉलिड प्लेट होगा तो गॉलिगर हो जाएगा, अगर छेद मिलेगा तो बेलफोर हो जाएगा. क्लियर है? ठीक है? या बेटा वन ऑन ईच साइड. सो एक यहां पे लगेगा, एक यहां पे लगेगा. सो दे रिक्वायर टू डिफरेंट जॉल्स रिट्रैक्टर. एक से नहीं होगा, रिक्वायर टू जॉल रिट्रैक्टर. ठीक है? Zernes retractor, see, Zernes can be used in abdominal surgeries, it can be used in thoracic surgeries whenever you're doing a thoracotomy. So you want the, see, the tooth end is going to lift the skin and the if your Langenbach end is going to retract the muscle. So one is going to muscle retractor, another is skin lifting. ठीक है? Clear? चलो. Now if you have the curved scissors, these are your Mayo's curved scissors. ठीक है? चलो. रुशिल बेटा जितना मैं कवर कर रहा हूं, these are the important ones. ठीक है? तो इस पे हम ज्यादा दिमाग नहीं लगाएंगे. जितना पढ़ाएंगे उतना ही पढ़ेंगे. एक और बात, do not try to overcook yourself. ठीक है? Optimal cooking is most important. तो जितना आपको मैं आज बता रहा हूं, this is the important component that you have to retain. ठीक है? If you are able to retain other ones, absolutely good, but this is the minimum that we need to be prepared for our exam. So these are about your various instruments. Now the common swellings. ठीक है? Spotters in the exam, they have come multiple times. So I'm going to run you through in the same spotters. If you have an image like this, okay, there's a swelling and on the tip of the swelling you see there's a black dot. This is called as punctum. Presence of punctum with the swelling is what we call it as sebaceous cyst. That is going to be a spotter. Okay, this is going to be a spotter. Another very important thing, how do you differentiate between a sebaceous cyst and a lipoma? What if there is a nevus on top of a swelling. Now you are confused whether it is a punctum or a lipoma. How do you differentiate that? The concept is very simple. Whenever there will be a sebaceous cyst, the hair over the swelling will be lost. The skin hair which is present, is the skin hair, अगर यहाँ पे sebaceous develop होगा ना, यहाँ का hair भी गिर जाएगा. So there is only going to be swelling left. Lipoma में hair will remain intact. ठीक है? That's a very very important concept. Clinically how do you differentiate? Sebaceous cyst के swelling के ऊपर आपको hair नहीं मिलेगा, लाइपोमा वाले स्वेलिंग के ऊपर आपको हेयर मिलेगा. ठीक है. अनदर इंपॉर्टेंट क्लिनिकल पॉइंट, द स्किन ऑफ द when you talk about your sebaceous cyst is non-pinchable. Skin over the lipoma is pinchable. Clinically lipoma में एक साइन मिलेगा, उसको क्या बोलते हैं? Slip sign positive. Whereas there will be no slip sign positive in sebaceous cyst. So this is how your lipoma is there. It's going to be swelling, which is going to be that. I've said everything that is important. They can ask you if there is multiple lipoma in the body associated with pain, what is that called as? Multiple lipoma in the body associated with pain is what we call it as the Dercum's disease. This is what we call it as the Dercum's disease. Clear? Okay? Chalo. Next you have this. If you have a swelling at the bony plate juncture, ठीक है, कहीं पे भी suture line पे अगर कोई swelling मिल रहा है, especially childhood, it is going to be a dermoid cyst. This is what we call it as angular dermoid. If you see a swelling at the posterior triangle of the neck, usually at birth, this is your cystic hygroma. ठीक है. Now, the most common site for cystic hygroma is the posterior triangle of the neck. It is due to the sequestration of the jugular sac. There will be a positive transillumination which is also seen in your hydrocele as well as your componental. You can't call it as teratoma, na beta. It is your jugular sac sequestration. Okay? The management is basically sclerotherapy. Now, another childhood swelling or a neonatal swelling that you can see is a baby born with the abdominal content outside but covered with a membrane, and this is what we call it as omphalocoele. Same thing if it is not covered by a membrane, if the bowel is freely floating outside, this is called as gastrocysis. These are spotters that they can ask you difference between omphalocoele as well as gastrocysis. Okay? Next is this. Again, a very famous Bailey image also it is given, and this is how you'll see. This is a sebaceous horn. Okay? It's just a pickup point to be remembered. Now, there's an ulcer image usually will be given. This is your venous ulcer. How do you know it's a venous ulcer? Now, a couple of important things. Number one, you will see some amount of varicose vein. That's one spotter. But more importantly, it is present in the gaiters area, that is around the ankle, usually seen above the level of medial malleus. When you look at the ulcer per se, it is going to be shallow. It is going to have sloping edge, pale, scanty, unhealthy granulation tissue. If you see these words put together, the answer is going to be your venous ulcer. As simple as that. Okay? Chalo. Now, next one is this. If you have a tuft of hair at the back, it is going to be spina bifida occulta. Now, if you have an image like this, this indicates a brilliant transillumination in the scrotal sac indicating hydrocele. Hydrocele की दो surgeries हैं, दोनों important है. One is going to be your jabulars, another one is Lodge. Lodge is sac plication, whereas jabulars is sac eversion, which is preferred. Jabulars is preferred over Lodge procedure. ठीक है? So that is all in all with respect to image spotters which are going to be clinical images. ठीक है? So far, any doubts, any questions, quick feedback? Quick feedback. ठीक है? चलो. Can we move on? चलो. Next, we talk about the minimal invasive surgery. ठीक है? We'll try to run off them. ठीक है? Again, important components. Now, in the laparoscopy, what are the important images or the concepts that you should know? You'll have images like this. If it is hollow, it is called as port. If it is solid cylinder, it is called as trocar. Port bahar hai, trocar andar hai. As simple as that. Usually the trocars will have a pointy tip. There are two sizes of trocar that are available, 10 millimeters and 5 millimeters. 10 is a bigger one, 5 is a smaller one. Okay? Now the question that they ask you in the exam is, while inserting the port or while placing the port or a trocar, if there is a vascular injury, what should you do? The concept is very simple. Keep the needle in situ, do not withdraw it back, and convert open surgery into laparotomy and then explore the area. As simple as that. Okay? But varicose ulcers specify the venous ulcers because of varicosity. Okay? Venous ulcers basically tell you that it can be because of other venous insufficiency components also. Okay? Nothing grossly different per se. Now, this is with respect to port as well as trocar. Next comes is this. This is what we call it as a lens, or also commonly called as the telescope. Now, telescope usually attaches to the camera's head. So we have camera head and to head of, so let's say this, if you take this as the telescope, this is the camera head. It attaches to the camera head. Camera head is it, this is the telescope. The question that they usually ask you is, what is the most common angle that is used on telescope? The answer is 30 degrees. As simple as that. Okay. Next comes, this was a previous exam question. This was asked in INICET, is the ergonomics of your laparoscopy. Okay. They've asked you, what is an azimuth angle? I'll explain you very simply. Now, when you take this as an abdomen, you will create pneumoperitoneum. After creating the pneumoperitoneum, you will put the camera first, okay, or the lens or the telescope first. Now, the instrument, or I can say the port through which you have put the camera, is called as optical port. Now, you have two hands, so you need two working instruments. So, you'll put one instrument on one side, another on another side, and these working ports are called as working port number 1, working port number 2. Okay, as simple as that. Now the question is, what is an elevating angle? It is an angle between the body and any of these instruments. It can be between the optical axis and the body, working port number 2 and body, working port number 1 and body. So the angle between the port and the body itself is called as elevating angle. Now the angle between an optical port and a working port, it could be on either side. This is what we call as azimuth angle. The angle between two working ports is what we call as manipulating angle. फिर से बोलता हूँ, angle between any of the port in the body is called as elevating angle. Angle between the camera, that is optical port, and the working port is called as azimuth angle. The angle between the two working ports is what we call as manipulating angle. Okay. Now the question is, they usually in the exam they'll ask you, what is the angle? Remember, all of them are 60 degrees. Elevating angle is 60, manipulating is 60. Azimuth, two azimuth angle put together is manipulating angle. Common sense. एक manipulating angle क्या है? दो azimuth angle को मिला के तो एक azimuth angle कितना होगा? 30 degrees. As simple as that. ठीक है. So this is what is the coefficient of your components. ठीक है. Clear है? Sorted? Great. Now, as I told you, when you put the ports, you can cause injury to the vessels because the trocar is sharp. Then we came up with an idea. In order to prevent that, I can use a blunt trocar. Now, that blunt trocar driven port, if you have a blunt trocar driven port, what is it called as? It is called as the Hansen's atraumatic port. As simple as that. Now, the star performer of your laparoscopy is your Veress needle. How do you identify it? You look at this and there's a long needle, and at the tip you will see the eye and there's a spring action to it. Okay? Now, what are the functions of your Veress needle? It helps to create pneumoperitoneum. The most common gas used in pneumoperitoneum is carbon dioxide. What is the initial flow of the carbon dioxide? Is 1 to 4 liters per minute. How much maximum can you put? It is 20 liters per minute. How much intra-abdominal pressure should be maintained during laparoscopy? The answer is 12 to 15 millimeters of mercury. And when you're putting the Veress needle, one, you're going to hold it like a dart. In which direction would you insert it? Would you insert it towards the pelvis or towards the xiphisternum? Remember, you are taking a safety measure. When you overshoot, you don't want to cause major injury. So while inserting towards the pelvis, if you overshoot, you will cause bladder injury. But if you overshoot while going towards the xiphisternum, you will pierce the diaphragm and then go into the heart, and you don't want to puncture the heart. So hence, I would go always towards the pelvis. Okay? Now, another question that I can add you is, what is the angle between the Veress needle and skin? Another one, what is the angle between the Veress needle and body? Two different questions. What are the answers, right? The angle between the needle and the skin will be 90 degrees, but between the body and the skin, it is going to be 45 degrees. ठीक है? तो needle और skin के बीच का angle 90 degrees है. ठीक है? Whereas the needle and body के बीच का angle is 45 degrees. Is that clear? Is that clear? ठीक है? Now, because every time you're going to insert the Veress needle, you're going to pinch the skin, pull it up, and the needle goes like this. So, angle between the skin and the needle is 90, but the body is here. Okay? So, the angle between the body and the needle is going to be 45 degrees. Is that clear? Is the point clear? Quick feedback. समझ में आया? नहीं समझ में आया तो समझा देते हैं. देखो, this is how the patient is going to lie down. This is how the patient is going to lie down. Okay? And this is the abdomen that you have. This is the umbilicus. I want to insert the Veress needle. So I will pinch the skin and I lift it up. Now when I pinch the skin and lift it up, how is it going to look like? So the patient remains the same. Okay. Now this is where the abdomen, and I've pinched the skin up, and this is how I've pinched the skin up. Now after pinching the skin up, or let's say to make it more precise, I would actually pinch it at the level of umbilicus. Okay. So let's say I have pinched at the level of umbilicus, which is going to be up. Okay. I've pulled it up, and this is where the umbilicus is there. Now I am going to insert the needle like this, right? Now when you look at the angle, now this is between the skin and the needle, it is 90 degrees. But you look at the body is here. The angle between the body and the needle is 45 degrees. Okay? And that is how you tell you the angle between the varus needle and the skin is going to be 90 degrees. The angle between the body and the varus needle is going to be 45 degrees. Okay? As simple as that. Got it? Sorted? Chalo. Can you move on? So, going on to the next one. Energy devices. Okay? Now, nothing spectacular about it. A quick recap on the energy devices. The standard 4 energy devices: single pole, monopolar, double pole, bipolar. If this is harmonic, this is thunderbeat. How to differentiate? Thunderbeat में 2 बटन मिलेंगे, हार्मोनिक में कोई बटन नहीं मिलेगा. ठीक है? अगर आपको डिफरेंशिएट करना है, हार्मोनिक नो बटन्स, थंडरबीट में 2 बटन होगा, एक कट का होगा, एक कट और सील का होगा. ठीक है? So you'll have one button to seal the structures, another one is to cut and seal. Now the question that they usually ask you is, in the harmonic scalpel, what is the vibrating frequency? Remember, it's 20,000 to 50,000 hertz. Okay? That's a vibrating frequency. Now remember, it is the safest energy device in pacemaker because it does not generate any electrical impulses. So if there is no electrical impulses, it will not cause any interference with the setting of the pacemaker. So the safest energy device with a patient with a pacemaker, answer is going to be your harmonic scalpel. ठीक है? फिर सवाल आ जाएगा, कट और coagulating current में differentiate कैसे करते हो? In a cut current, it is going to be low voltage, high frequency. In a coagulating current, it is high voltage but low frequency. That is your exam question, nothing more than this. Next comes your suturing rule. ठीक है? Now these are your questions that they usually ask you. Now the important is, how do you determine the length of the suture material? It is going to be 4 times the length of the wound. What is the importance of depth of the wound? It determines the entry and exit and the distance between the 2 sutures lines. What is the angle between the needle and the skin at the entry? It is 90 degrees. Distance between the 2 sutures should be twice the depth of the wound, and the length of the suture here that should be left behind is going to be 1 to 2 millimeters. All these are your previous exam points to be remembered. Then they'll ask you an images like this and they'll tell you, identify the technique of suturing. If the thread starts from here and goes zzz and ends here, okay? There's no interruption. This is called a simple continuous running sutures. Now, if you take one, cut one, take one, cut one, take one, cut one, then it's called a simple interrupted sutures. On the other end, the 2 bites on one end, 2 bites on the other end, then are not. But the wound and the sutures, they're perpendicular to each other. It is vertical matters. If they're parallel to each other, it is horizontal matters. If the skin, the suture is not on the surface of the skin, it is in the dermo-epidermal junction. It is called subcuticular. The best cosmetic outcome for a suturing technique is going to be subcuticular. As simple as that. Next comes your knotting. Okay? These are 4 different types of knots that are going to be present. If you have a single loop like this is called as half hitch. Now, if you do a double hitch, this is what we call as grannies, and this is what we call as square knot or a reef knot. How do you differentiate? बड़ा प्यारा सा concept है. ठीक है? Grannies में देखो, if this is the red green loop that you have, red thread is going under and this is going over. तो एक thread नीचे से, एक thread ऊपर से. यहाँ पे भी देखो, if you see on the other end also, this is the green red loop, एक green thread नीचे से, एक green thread ऊपर से. So एक नीचे, एक ऊपर. It is grannies. Reef knot या square knot में देखो, दोनों नीचे से या दोनों ऊपर से. ठीक है? Either both the threads are going under the loop or both the threads are going over the loop. This is what we call it as the square or the reef knot. Scourgeon's knot is the most stable knot. It is the most easy one to identify. You cannot goof up on that. Okay? Now the question is, which are stable, which are unstable? Half hitch, grannies, unstable. Your reef square knot and the surgeon's knot are stable. Which is the most stable? It is the surgeon's knot, which is the most stable one. Okay? Sapna, if you did not understand, please explain again. Okay, beta. Granny's knot. I'll try to explain it with a thread. Excellent. Okay. Wait. Now see here. All those who did not understand about the knot, I'll show you very simple. There are 2 ends of the thread. Flip it one. What is this? ये कौन सा knot है? ये कौन सा knot है? Come on, quick, quick, quick. कौन सा knot है? Single loop. What knot is this? दिस इज योर हाफ हिच, इस हाफ हिच के ऊपर आपने एक और हिच की मारी, ठीक है। नाउ दिस इज व्हाट वी कॉल इट एज आर ग्रैनीज नॉट। आप बोलोगे कैसे? नाउ यू सी इट हियर, ठीक है। यू कैन सी दैट इफ दिस इज द थ्रेड, ठीक है, ये थ्रेड है, वन थ्रेड इज गोइंग अंडर और एक जा रही है इसके ऊपर से, एक लूप के ऊपर से जा रही है और एक लूप के नीचे से जा रही है, ठीक है। वन इज गोइंग ओवर द लूप, अनदर वन इज गोइंग अंडर द लूप। यू कैन सी इट हियर, इफ यू सी हियर, वन थ्रेड इज गोइंग ओवर, ठीक है, दिस इज गोइंग over the loop and one thread is going under the loop, so loop is here, ठीक है। Now on the other hand, if I reverse this and keep it, ठीक है, now this is what we call it as the reef knot. You can see here, you can see here, ठीक है। both the threads are either they are over the loop, ठीक है, or they are both of them are under the loop, ठीक है। या तो दोनों ऊपर से जा रही है, दोनों नीचे से जा रही है। It's easy to slide, no? This is what we call it as reef knot or the square knot, ठीक है। इसी को अगर I hope I didn't make some sense out of it. If you did not understand it, I'll keep it again, ठीक है। मान लो कि ये थ्रेड का लूप है, एक थ्रेड ऊपर से जा रही है, एक थ्रेड नीचे से जा रही है, ठीक है। वन थ्रेड इज गोइंग ओवर, अनदर वन इज गोइंग अंडर, दिस इज गोइंग टू बी योर ग्रैनीज नॉट, ठीक है। ऑन द अदर हैंड, इफ दिस इज द लूप ऑफ द थ्रेड, if both the threads are going over or if both the threads are going under, this is called as the square knot or the reef knot, ठीक है। Sorted? Clear है? This is how you identify knots. सपना क्लियर? देखो ऐसा आज कोई कॉन्सेप्ट नहीं होगा जो आपको समझ में ना आए और मैं समझा ना पाऊं, ठीक है। I will attempt in the best possible way to give you a concept behind it, but this is what is important, ठीक है। क्या? चल, ग्रानी नीचे, आई डोंट नो, ठीक है। सूचर रिमूवल पीरियड क्विकली याद रख लेना बेटा। हॉरिजॉन्टल मैट्रेस और वर्टिकल मैट्रेस में हाउ डू डिफरेंशिएट इज विचएवर डायरेक्शन द वुंड इज प्रेजेंट, अगर सूचर उसके परपेंडिकुलर है, it is going to be vertical mattress. If the line of the wound and the line of the suture they are running parallel to each other, it is going to be your horizontal mattress. इतना ही है, इसके beyond नहीं है, ठीक है। So don't worry about it. Now the suture removal period is important. For face, the most vascular area of your body, 3 to 5 days is enough. For scalp as well as arms, it is going to be 7 to 10 days. For trunk, legs, hand and feet is 10 to 14 days. सबसे ज्यादा palms and soles में that is 14 to 21 days. These are your suture removal period that you should be aware of, ठीक है। Now moving on to the next one, again a very very important topic repeatedly asked in our exam. It is about the pressure source or the bed source. The basic criteria of developing a pressure sore is if the pressure exerted over an area is more than the capillary occlusive pressure. How much is the capillary occlusive pressure? That is going to be 30 millimeters of mercury. If you're exerting a pressure which is more than 30 for a sustained period of time, that area will be devoid of blood, causing hypoxia, then ischemia, resulting in necrosis and ulceration. यही concept आपका pressure ulcer का. Then they'll ask you what are the important risk factors: prolonged bedridden status, prolonged immobilization, quadriplegia, wheelchair bound status. Any of that is going to be considered. What are the most common side? The most common is ischium followed by great interguinal followed by sacrum. They'll ask you how do you identify the grades? It is very simple. Grade 1, there is erythema which does not blanch on pressure. Non-blanching erythema is grade 1. If there is partial thickness skin loss, grade 2. Full thickness skin loss, subcutaneous fat is exposed, grade 3. Underlying structure is involved, it is called as grade 4. And if there is ulcer covered in slough or necrosis, if an ulcer is covered in slough or necrosis, it is called as unstageable. As simple as that. Okay. Now the question is, how do you manage? For grade 1, grade 2, it is going to be conservative management. Conservative management का protocol क्या है? If a patient is going to be bedridden or wheelchair bound status, remember, always give water or an air bed to decrease the pressure. Second, frequent change in position. How frequent? If the patient is bedridden every second hourly, but if a patient is wheelchair bound, every 10 minutes. Okay. On the other hand, if there is grade 3, grade 4 or unstageable, do a cleaning and debridement and put a VAC. VAC is what? Vacuum assisted closure. And this was your this year's exam question. VAC का full form क्या है? Vacuum assisted closure. But this term does not exist. What is the new term? It is negative pressure wound closure system. Okay. How much is the pressure? Minus 125 millimeters of mercury. How will you apply it? It is going to be an intermittent basis. What is the advantage? It clears the secretion, keeps the wound dry, and increases the granulation tissue proliferation. Okay. And also continue with conservative management protocol. As simple as that. Images are important. The trick part, if there is an ulcer which is covered in slough, what is the stage of that pressure ulcer? The answer is unstageable, because until unless I don't remove the slough, I don't know the true depth of the ulcer. If I don't know the true depth of the ulcer, I cannot say whether it is stage 2, stage 3 or stage 4. Is that clear? Sorted hai? ठीक है? Clear? So far, any questions? कोई सवाल, कोई शक? Okay, moving on to the next point. Now, this is your highly anticipated exam question. Okay? Now, the definition. What is a daycare surgery? It is admission to discharge within 12 hours. Beta, of all those people who are in love with Bailey and Love, I am also in love with Bailey and Love series. I've been telling in every single session that we will continue Bailey and Love, but after our exam season is done. Currently, we are concentrating on your FMGE exam and NEET PG exam, which is going to be next month. And once we are done, we will swing back to our Bailey and Love, right? Ischium is more common than sacrum, beta. Okay? Chalo. So the definition is important. What is a daycare surgery? Admission to discharge within 12 hours. What is an overnight stay? Admission to discharge within 23 hours. What is short stay? If you discharge within 3 days, that is 72 hours. Most common complication of a post daycare surgery is nausea and vomiting. But most common complication which requires readmission, it is going to be your hemorrhage. Okay? Most common complication overall is going to be nausea and vomiting. But most common cause for readmission after daycare surgery, it is going to be your hemorrhage. Okay? Clear? So daycare surgery ka full form hai admission to discharge within 12 hours. It is overnight stay which is within 23 hours. Okay? Now, what is the criteria for discharge in a patient of daycare surgery? Beta, this PDF, I will share it right after the class in front of you. I will put it on our MedEd Telegram channel. I will put it on my own Telegram channel, which is called as the Surgery Guy. If you are not able to find it, please do a DM or send me a text on my Instagram channel, which is by Surgery Guy. I will make sure I'll share it to you tonight itself. Okay? So let's not worry about it. Thank you, Ghanshyam. I mean, yeah. Since I've started Bailey and Love, it's been an amazing journey. A lot of people have been messaging all across, not only from India, elsewhere also. So I'm grateful for it. Thank you. Thank you so much. Let's continue in our current series that you have. Now, the question which is asked is, what is the criteria for discharge in a daycare surgery? Number one, the vitals must be stable for at least 1 hour and patient must be oriented to time, place and person. This is enough for them to send home. Other one, adequate analgesia, pain control on oral medication, should not require an IV medication. Patient should have taken orally and tolerated. That means once you take it, patient has been fed, patient should not have any nausea, vomiting. Okay? Another one that you have, patient must have passed urine, no bleeding, minimal discharge or soakage on the wound site. Patient should be able to dress, walk, and responsible person should be available to take the patient home. Okay? These are the points to be remembered for discharge. Now this actually precisely it is more important when it comes down to INICET, but now who knows, they can ask you in our NEET PG exam also. Next comes is ERAS. I've been telling in many of my sessions that ERAS is something which is an integral part of your day-to-day surgery recovery. It is an anticipated exam question. It is called as enhanced recovery after surgery. There are 3 parts of the ERAS. You have the preoperative assessment, intraoperative and the postoperative. In a preoperative, you will counsel the patient, avoid any mechanical bowel preparation, oral intake. This is your exam question. Until what point? Solids are allowed until 6 hours. Liquids are allowed until 2 hours. And carbohydrate rich liquid diet is what we are going to give. Clear carbohydrate rich diets. Intraoperatively, minimally invasive surgery is preferred. Bupivacaine infiltration is preferred again. Keep the patient warm. Nausea and vomiting prophylaxis, at least 2 classes of medications that is going to be for antiemetic should be used. Post-operative, use NSAIDs over opioids, discontinue within 24 hours, that is discontinue IV fluids, start liquids followed by solids within the first 24 hours, early ambulation within the first 24 hours, avoid drains, plan for, if you are put, then plan for early removal. These are the criteria for ERAS that you have to remember. Okay. Okay. Right. So this is the protocol for ERAS, that is your preoperative, intraoperative and the postoperative assessment. Okay. Now, preparation for the surgical sites, again something that is going to be asked as one important question. Will this be enough for NEET PG? Beta, this will be enough for any exam that you're going to take in your life which is going to include surgery. Okay. NEET PG, INICET, FMGE exam, even if you're writing any other exam, this material is more than enough. It's the gold standard for revision. I have put this with a lot of effort. I am saying with absolute humble attitude. It is not the arrogance which is speaking. It is the amount of work that has went behind to compile this material and to bring it for you. ठीक है, तो अगर मैं यहाँ खड़े होके आई एम ट्राइंग टू एक्सप्लेन यू एवरी सिंगल पॉइंट एंड आई एम ट्राइंग टू गिव यू दैट कि बेटा ये हाई यील्ड है, इसका मतलब ये हाई यील्ड है. ठीक है, देयर इज नो इफ, देयर इज नो बट, वी डोंट डू हाफ मेजर्स. ठीक है. नाउ प्रिपरेशन फॉर सर्जिकल साइट, रिमेंबर removal of metals and other foreign bodies are absolutely important for pre-operative. ठीक है, because they act as needles for infection. They can conduct thermal injuries and post-operative edema, especially if you're wearing rings and all that. ठीक है. Hair removal, it is optional, but if you're doing it, you do it clippers and that too just before the surgery. Antisepsis, alcohol-based, that is chlorhexidine is used. Concentric method. So there are different methods that you can use it. पहले बोलते थे कौन सा better, nothing. Concentric method, horizontal, vertical, use it any form, it is all same. ठीक है. Draping, always periphery first and then you move down in the context. 1 arm distance from the table is important. Avoid crossing over the table. That means if you're passing an instrument, don't give cross. It should always be from the same side, which is held by your sisters. Blunt tip clips to be fixing the drapes, not the sharp tip one. These are the precautions that have been told about you. ठीक है, चलो. Incisions, again important exam question they can ask you. Now they will ask you incision के लिए कौन सा better है, scalpel या dithermy? बेटा technically talking both of them are equally well. But if you talk about which is there in terms of surgical site infection, blood loss and operating time, it is same for scalpel as well as dithermy. But when you talk about dithermy will cause post-operative analgesia requirement is less. ठीक है, तो स्कैल्पल से डाइथर्मी थोड़ा बेटर, मतलब अगर आप इंसेशन कॉटरी से दोगे या फिर स्कैल्पल से दोगे, है ना. इफ यू आर गिविंग विद स्कैल्पल, we used to think it is better, but now it is proven it is equal for both of them. If at all you have to add, remember the advantage of using dithermy is post-operative analgesia requirement is less. ठीक है. Now, the incisions can be transverse as well as longitudinal. Transverse will have less pain, so it is more preferred. Whenever you have any scar and you want to create, this was your exam question. Previous laparotomy scar incision कैसे लोगे? You will take an elliptical incision covering, you are excising the entire scar. तो पूरा scar उसके साथ निकलेगा. That is an important point. Various named incisions, again your exam question. If you have a parotid surgery, this is what the incision give, which is called as lazy S incision or also called as modified Blair's incision. अगर thyroid के लिए है, ये neck का incision, इसको बोलते हैं Cocker's incision. How do you know where to put Cocker's? It is 1 centimeter below the cricoid cartilage, 4 to 5 centimeters above the suprasternal notch is your Cocker's incision. Then all the named incisions that you can think about. The vertical midline incision chest is median sternostomy. If you open the chest in a transverse manner, this is called as clamshell thoracotomy. If you are using an incision to go from from the lateral surface to posterior, it is called as the posterolateral thoracotomy. If you have an incision from the xiphisternum to the pubic symphysis, that is in the midline, this is called as laparotomy incision. If you have an incision which is going on top, like from one subcostal region to another, this is what we call as rooftop incision. If you have an incision which is going like a hockey stick here, on the right side, this is called as Makuchi's incision for liver surgeries. Now, if you have an incision which is going to between the lateral 1/3 and medial 2/3, that is what we call it as grid iron incision. If you extend it, it is what we call it as the Rutherford-Morrison's incision. If you give it below it in a transverse, this is what we call as Lanz incision. All these are important. And if you give a curvilinear incision at the pelvis, this is what we call as Pfannenstiel incision. All the incisions have been asked in your exam. Just remember this one particular image. You will not go wrong. Is that clear? So far, so good. So far, so good. Alright guys. So, next is the surgical blades and their importance. Okay? Now, when you have a blade number 15, it is for precise incision. Blade number 11, it is for IND, for stab incisions and arteriotomy. Blade number 12 is for suture removal. This is your exam question. For suture removal, what is size of blade? That's blade number 12. And the blade number 22 is for laparotomy and thoracotomy. Now, blades के दो parts होते हैं. The sharp edge is what we call as belly. Always use the belly for incision. It should be perpendicular to the skin, not at an angle. It should always, belly should lie perpendicular to skin and then cut it. Okay, that is what it is important in your blades. Okay, chalo. So that is all about your wounds as well. Clear? Now, let's go into the next topic. It is about the wounds. We'll talk about collagen synthesis in the wound healing process. Okay? Now, how is the collagen is synthesized? There are two important amino acids, proline and lysine. They undergo a process called as hydroxylation to become hydroxyproline, hydroxylysine, and they result in collagen synthesis. The cofactor required for them is vitamin C, iron, and alpha-ketogluteric acid. So, simple concept. Whenever there is vitamin C deficiency, iron deficiency, or alpha-ketogluteric acid deficiency, there will be poor wound healing because they cannot synthesize collagen. Now, in the granulation tissue, which collagen is predominant? Type 3. In early scar, which is predominant? It is again type 3. In initial scar, it is going to be both type 1 and type 3 in a ratio 1:1. Final scar, you will have more of type 1 when compared to type 3, which is 4:1. Again, when they ask you about the scar strength, it is the strength compared to the normal skin. At 1 week of wound healing, it is 3% of the normal skin. At 3 weeks of the normal At the 3 weeks of healing, it is 20% of the normal skin. At the 12 weeks, it is 80%. The maximum scar strength that can be achieved is going to be 80%. That is going to be practical. Theoretically, you can talk 90, but 100% is never possible. As simple as this. Okay? Now, causes of post-operative fever. Quick, remember day 1 is wind, that is going to be lung atelectasis. Day 2, day 3 is water, that is UTI or thrombophlebitis. Day 4, day 5, it is going to be wound, that is surgical site infection. And day 5 and beyond, it is going to be DVT. Day 6 is going to be burst abdomen. Day 7 is going to be intra-abdominal collection or abscess. The factors that result in burst abdomen, very, very important. Achha, how do you know there's a burst abdomen? Remember, burst abdomen mein there will be salmon colored fluid. There is salmon colored fluid from wound site. There will be salmon colored fluid from the wound site, right? So, what are the patient factors? What are the surgical factors? Patient, soon after the surgery, there is chronic cough, constipation, obesity, immunocompromise, or poor nutritional status. There will be poor wound healing. From a surgical side, if there is more, burst abdomen is more common with midline incision when compared to transverse. It is more common in emergency surgeries when compared to elective. It will be more common if you have taken a continuous suture when compared to interrupted. And if there's a poor choice of suture material, you should use non-absorbable, and let's say you have used absorbable, example like catgut or Vicryl, which will dissolve or it will have poor strength and hence resulting in wound dehiscence. Okay? So burst abdomen, these are the important factors to be considered. Clear? Clear? Chalo. Now, surgical site infection, again an important exam topic to be remembered. Now, when you talk about the surgical site infection, give me a second guys. In a surgical site infection, we say the definition of a surgical site infection is any wound infection within 30 days of surgery. But if there is an implant, it is considered to be within 1 year of surgery. Okay? Post implant, the definition of surgical site infection is the infection within 1 year. But in general, it is within 30 days of your surgery. Now, there are two scoring systems that we are going to follow. One is your asepsis wound score. Another one is Southampton wound grading system. Asepsis, the mnemonic itself is asepsis. A stands for additional treatment required for wound healing. S stands for serious discharge. E stands for erythema. P stands for purulent discharge. Another S stands for, it is going to be separation of deep tissue. I is isolation of organism, that is positive cultures, that is in a post-operative wound. And another S is stay in inpatient for wound related complications for more than or equal to 14 days. In a Southampton wound grading system, grade 0, it is a normal healing wound. Grade 1, normal healing with mild inflammatory or mild erythema. Grade 2 is erythema with other signs of inflammation. Grade 3 is serious discharge. 4 is purulent discharge. 5, there is separation of deeper tissue or infection into deeper tissue with or without tissue loss. Or if there is a hematoma requiring aspiration, that will also become grade 4 with respect to Southampton wound grading system. ठीक है. So these are all the important points with respect to wounds that you should be aware of. The most important is going to be this particular table. Just give me a second, guys. Just watch up to the table. One second, guys. Okay, sorry. All right, so moving on. Now, as I told you, this is one of the most important tables in the wound. It's a classification of surgical wounds. Okay? They're divided into 4 categories. All of us know it. They're divided into clean, clean contaminated, contaminated, dirty. I'm not going to tell you about all the examples that you need to remember. I'll give you a basic concept. Okay? Clean wounds का जो concept है, it should be non-traumatic, it should be an elective surgery, and you should not enter into the natural cavity. Think about all those you will consider it to be as a clean surgeries. One point to be remembered is all your brain surgeries and heart surgeries are also considered to be clean surgeries and joint surgeries. Okay? Brain, heart, joint surgeries are considered to be clean surgeries. Then comes to clean contaminated. Everything remains the same as clean. It should be non-traumatic, it should be elective, but this time you're entering into natural cavity under a controlled environment. For example, uncomplicated appendicectomy, uncomplicated cholecystectomy, elective gastrectomy, okay, elective hysterectomy. All these are considered to be as your clean contaminated. Contaminated are the one which are traumatic, emergency, enter into natural cavity in an emergency setting, okay, or any re-exploration. Okay. There was a question that was asked in your exam where a patient has underwent a cardiac surgery and because of XYZ reasons, the patient has to be re-explored for cardiac massage. What class of wound it is? When it becomes re-exploration, it will directly become contaminated wounds. Okay. All re-explorations are contaminated. If there is pus, fecal material, it is dirty. As simple as that. You don't need to put your head against it. बड़ा simple सा logic है. अगर आप ये 4 चीजें, if you are able to remember it the way I said it. Clean wounds का जो criteria है, it is very simple. What is the criteria for clean wounds? It should be non-traumatic. It should be elective. No entry into natural cavity. Non-traumatic, no entry into natural cavity. It should be elective. Same thing. Non-traumatic, elective, but this time entry into natural cavity under control, it will become clean contaminated. Contaminated में all emergency and re-exploration will come along with trauma. Dirty में क्या होगा? Pus या fecal matter मिल जाएगा, dirty हो जाएगा. इससे simple explanation possible ही नहीं है. I've given you a lot of examples. On the other hand, you can just go revise it. For example, thyroid, brain, joint, mastectomy, uncomplicated inguinal hernia, CABG, everything is going to be a clean surgeries. Clean contaminated, elective appendicectomy, elective cholecystectomy, urinary stones, LSCS, abdominal hysterectomy, elective bowel surgery. All these are considered to be your clean contaminated, emergency appendicectomy, cholecystectomy, open cardiac massage, re-exploration, bowel spillage during surgery. All these are considered to be your contaminated. Dirty में क्या हो जाएगा? If there is abscess, peritonitis, fecal material, intracutaneous fistula, all these are going to be your dirty wounds. The only thing is about the surgical site infection, needless to tell you, the maximum is going to be your contaminated one. So prophylactic antibiotic is going to be given in your clean contaminated and contaminated and dirty wounds. Okay? That is absolutely important. Clear? So now ulcers are being asked again and again based upon what are the when you talk about the edge of the ulcer, based upon that. Sloping edge is seen in healing ulcer, venous ulcer. Undermined edge is seen in tubercular and necrotizing fasciitis. Punched out ulcers are going to be seen in syphilitic and trophic ulcers. If you have raised and everted, it is going to be squamous cell carcinoma. If it is raised and beaded, it is going to be your basal cell carcinoma, which is called as the keratin pulse. As simple as that. Clear? Chalo. So that's in conclusion with that of your ulcers as well. Okay. So this concludes the first part of your general surgery. Okay. So far, any doubts? कोई सवाल, कोई शक? ठीक है, चलो. We'll take a short break at 9 o'clock. We'll take 15 minutes break. We'll resume back again. We'll hit another 2 hours. and then we'll take another 15 minutes and then we'll hit back again. Okay, don't worry about it. Now, the next topic that we'll talk about is burns. Now, in burns, the question that is asked is, what is the most common rule used for the burn wound assessment? The answer is going to be Wallace rule, also called as rule of 9. Best is going to be Lund and Broder's chart. Now, when you look at the comparison between the adult and the child, the concept is very, very simple. In adult, the head and neck is going to be 9%. If they're using the word only face is anterior half of the head, which will become 4.5%. The head and neck together is 9%. The upper limb is 9, lower limb is 18, 1% is perineum. The trunk, anterior is 18, posterior is 18. What is trunk? Chest and abdomen. Thorax and abdomen together is what we call as trunk. Anterior trunk is 18, posterior trunk is going to be 18%. Look at the wordplay that they're going to use. बच्चों में क्या change है? बच्चों में दो ही चीजें change है. If you look at the comparison between these two, everything remains the same. The head and the lower limb changes. Head in adult is 9%, in children it is 18%. Lower limb in adults is 18%, in child it is going to be 14%. There is no perineum in child. That is the point to be remembered. Now, based upon the burn wound depth, this table is very, very important. So, based upon the extent of the burn, you have the first degree, second degree superficial, second degree deep, and the third degree and the fourth degree burn. How do you know? First degree, only epidermis. If there is involvement of papillary dermis, it is secondary superficial. Secondary deep is reticular dermis. Entire thickness of skin is third degree. And if underlying structure is involved, it is fourth degree. How do you know? These are the parameters on which we are going to assess. That is going to pain, blister, color, which is very good. Whether it is going to heal or not. Is there a scar formation or is there resulting in eschar or not? Okay. Now, wherever you have skin, there will be pain. First degree, second degree superficial, you'll have skin, so they are extremely painful. Secondary deep, there is no pain, but there's something called as pin prick sensation. You take the pin, prick it, the patient will say, ouch, dard ho raha hai. He will feel the stinge, but in general, there is no pain. Third degree, fourth degree, no skin, no pain. Blisters again works on the same principle. That is why in the first degree, second degree superficial, secondary deep, there's a possibility of blister, mostly in the second degree superficial. Third, fourth degree, no skin, no blisters. Color, first degree erythema, second degree superficial, bright red. Second degree deep, it is important, pale, waxy white or mottled pink in color. Third degree is going to be leathery. Fourth is like a burnt coal, that is called as charcoal appearance or charred appearance, that is going to be present. Then which is going to heal? The first, second degrees are going to heal. Third and fourth degree, they will not heal. You have to cause an intervention. Scars are formed from the secondary deep onwards. The scar is also seen from the secondary deep onwards. What are the what are the fluids that are going to use? Remember, the most common fluid used for fluid resuscitation in burns is ringer lactate. बोल के थक गए, इससे simple सवाल हो ही नहीं सकता. How do you calculate it? Now, Parkland is obsolete. We will use ATLS. ATLS का simple सा concept याद रखना. ATLS is based upon the depth of the wound. Second degree, third degree burns. Remember, for an adult, it is 2 ml per kg per percent of total body surface area burnt. For child, it is 3 ml per kg per total body surface area burnt. For a neonate, it is 3 ml per kg plus maintenance. That is going to be important. Fourth degree or electrical burn, let it be adult or a child, it is 4 ml per kg per percentage of total body surface area burnt. That is most important in terms of Parkland formula. Okay? Now, this is again your anticipated exam questions. With respect to colloid, what is the most common colloid used for resuscitation? The answer is going to be HAS, human albumin solution. Now, what is the ideal time to administer after 24 hours of burn? How do you calculate this Muir and Barclay formula? What is Muir and Barclay? 0.5 into weight in kilograms into percentage of total body surface area burnt. How do you administer the protocol for your colloids? First 24 hours, it is only crystalloids. After 24 hours of crystalloids, if the fluid requirement is still there, you will go with colloids. How do you do it? For the first 12 hours, I'll give every 4th hourly. After that, another 12 hours, I'll give every 6th hourly. And from there onwards, every 12th hourly, I'll give one portion. What is one portion? Whatever you calculate with Muir and Barclay formula, whatever is the value you get, it is called as one portion of colloid to be administered. Okay? Clear? Chalo. Now, how do you manage for the burn wound? There is topical ointment that are important. You'll see all of them, silver sulfadiazine, then you have silver nitrate, then you have mefenamic acetate, silver sulfadiazine with cerium nitrate. The comparison is between, is it its effectiveness against Pseudomonas gram-negative, can it penetrate the eschar or not? Is there any specific side effect? The only point to be remembered is there is blackening of skin with respect to silver nitrate. Mefenamic acetate causes extreme pain on application and also causes metabolic acidosis. Silver sulfadiazine with cerium nitrate is the best because it can penetrate the eschar. It is effective against Pseudomonas and gram-negative, whereas your silver sulfadiazine cannot penetrate the eschar. Most commonly used is silver sulfadiazine, but the best is going to be silver sulfadiazine with cerium nitrate. Okay? So that is with respect to that of your burns as well. Okay? Clear? So, So far so good. So far so good. Any questions? If you have any questions, you can ask. Abhi tak koi sawal, koi shak, any problem, any context, any questions that you want to ask? Chalo. Now we'll go into each individual topic or each individual. But a paraffin wax is a coat that is put on the burn surface to prevent it from exposing to the external environment directly. Okay? It is an temporary component, but it is not something that is used as a regular management. Is that clear? Chalo. Now we'll start system wise. We'll start with the endocrine. We'll start with thyroid. Then we'll go into breast. Then you have parathyroids and all that. Then we'll go into GIT. Then you go into your HPB. Then into urology. And probably then we'll finish it off. Okay, as simple as that. Now, we'll start with the first one. In the thyroid, there's a previous exam question. What is an optimum cytology criteria? What is an optimum cytology basically means is if a patient comes to you with thyroid swelling and you have to do an FNSE, how can you get the best yield or result from it? Number one, choose a needle correct. What is the ideal size of the needle? You can use anywhere between 22 to 26 gauge. Single best answer is going to 23 gauge needle. Now, if you want to get a better yield, that means if you want to get better sample, you need to aspirate multiple times. Not too many times also, not too less also. What is the ideal aspirate? That is 2. So minimum of 2 aspirates should be taken. Now, when you collect that aspirate, I expect there should be minimum 6 follicles per aspirate. In that follicle, I should have at least 12 to 15 or 10 to 15 is the number. 12 to 15 is given in few textbooks, 10 to 15 in few textbooks. We'll say ideally it should be between 10 to 15 cells per follicle. So what is the ideal or optimum cytology criteria? Use 23 gauge needle, take 2 aspirate, 6 follicles per aspirate, 10 to 15 cells per follicle is the criteria that you should know. Is that clear? ये आपका optimum cytology है. अच्छा, फिर हमारे पास एक important topic है. In the thyroids, it's about inflammatory thyroid swellings. ठीक है? So we'll have a comparative data so that you can revise everything in a quick go. Okay. Now, I will be revising it or I will be comparing it, the Hashimoto's thyroiditis with decurvins as well as your Riedel's thyroiditis. Now, when you look at this, the first is what type of inflammation? Hashimoto's, when we talk about the Hashimoto's, you have the decurvins and Riedel's. Hashimoto's is going to be chronic, decurvins is subacute, Riedel's is also an example of chronic inflammation. What is the etiology? Hashimoto's is autoimmune, Riedel's is going to be your idiopathic or autoimmune. What is decurvin? Is post-viral cross-reacting antibodies which recognize follicles as foreign. That is the basic objective there. What is the pathophysiology? Hashimoto's is autoimmune disorder. So they will have an antibody. The antibody is anti-TPO antibody. What do? They will cause activation of CD4 cells. They cause activation of CD8 cells which recruit T cells which are cytotoxic. They go and damage the thyroid follicles. As simple as that. Whereas your decurvins, it is cross-reacting antibodies which are formed and they are going to irritate the thyroid follicles. Riedel's, it is usually unknown, but if it is autoimmune, they are associated with the antibody which is called as IgG4 class of antibodies. IgG4 class of antibodies are also associated with Ormond's disease. What is Ormond's disease? Quick feedback. What is Ormond's disease? क्या है ये Ormond's disease? What is your Ormond's disease? What is your Ormond's disease? Quick feedback. What is Ormond's disease? Very good. It's a retroperitoneal fibrosis. If it is an autoimmune Ormond's disease or autoimmune retroperitoneal fibrosis, that is also caused by IgG4 class of antibodies. ठीक है. Sir, in cardiac tamponade, I remember you told thoracotomy as the first line of intervention, but still some faculty were telling their pericardiocentesis. Okay, but needle pericardiocentesis is an obsolete answer for cardiac tamponade. The answer is going to be your pericardiotomy, that is by doing a thoracotomy. As simple as that. ठीक है. No if, no but. ठीक है. चलो. Now coming back here, what are the HLAs associated with Hashimoto's? It is B8, DR3, DR5. अगर सिर्फ HLA B8, DR3 होगा, that is going to be in Graves' disease. ठीक है. Whereas when it comes down to your decurvins, it is HLA B35. In your Riedel's, there is no specific HLA that is associated. Age of presentation, Hashimoto's is 30 to 40, decurvence any Riedl's is usually seen in age above 50. All of them are more common in females, no spectacular point about it. Now this is very important. How do you pick it up? If you're a patient with a thyroid swelling with features of hypothyroidism, it is Hashimoto's. If there's neck fullness, no swelling, if there's neck fullness, painful swallowing, and the patient initially presents to you with hyperthyroid-like features, the answer is going to be your decurvence. If the patient has a massive thyroid swelling with severe pressure symptoms and hypothyroid status, answer is Riedl's thyroiditis. Now, initial thyroid status, Hashimoto will be hyper, decurvence will be hyper, Riedl's will always remain hypo. There's no intermediate for Hashimoto's. There will be intermediate for your decurvence, which is hypo. There's no intermediate for Riedl's because it will throughout its journey it will remain hypo only. Whereas in Hashimoto's, eventually it becomes hypo. Decurvence, it becomes euthyroid. It's a self-limiting condition. When the viral infection subsides, it subsides by itself. And at the end, when you have Riedl's thyroiditis, it will remain hypo because Riedl's is an autofibrosis of its own follicles. From day one, they remain hypo only. Investigation for all of them is going to be ultrasound, TFT, and FNSC. There's no need for FNSC in your Riedl's in your decurvence because it's an inflammatory component which is acute. Management for Hashimoto's lifelong thyroid, Riedl's lifelong thyroid, decurvence is self-limiting. If a patient is suffering from severe pressure symptoms, all patients who are suffering from severe pressure symptoms, okay, with an inflammatory thyroid swelling, the surgery of choice is hysterectomy. You will not do a thyroidectomy. It will cause more damage. Okay, it is going to be more damage. Is that clear? Sure. Beta Gayatri, that answer I have given multiple references. आज के date पे, it is pericardiotomy is better when compared to needle pericardiocentesis. Even in the updated version of Washington Manual of Surgery, it is given in the same thing. Hi Shekhar, thank you. Okay, chalo. So this table is important. It's a quick revision for your inflammatory thyroid swelling. Just go a quick recap of it. Every single point that has been in your previous exam, I have laid it out for you. Just revise it once. Okay? Clear? Okay? So this is all in all with respect to your first table in the thyroid. Okay? I'll take a short break here, 15 minutes, and then we'll resume back. Take a short break for 15 minutes and we're going to resume back. बंद नहीं करना All right, guys, let's start. Can we start? Can we start? All right, guys, chalo. So the next topic I'll be discussing on the thyroid cancers. I'll be comparing the four components: the papillary, follicular, anaplastic, and medullary. Okay. Now, with respect to origin, all of them are follicular except for your medullary, which is parafollicular C cells in origin. The most common thyroid cancer is going to be papillary cancer thyroid. The most common thyroid cancer in ectopic thyroid gland is follicular cancer. One which is associated with the worst prognosis is anaplastic, and one associated with Men's syndrome is going to be a medullary cancer thyroid. Okay. Now, when you talk about age of presentation, most of the cancers will be seen at a later age, but papillary is seen between 30 to 40 years. That's one point to be remembered. Medullary cancer thyroid, if it is sporadic, age about 50, but if it is associated with Men's syndrome, it is seen in age below 20 years of age. Okay? All of them are more common in females. With respect to gene, remember, for papillary, it is your BRAF gene mutation. For follicular, it is P10. And the most important is your medullary cancer thyroid, that is your RET gene mutation. Important risk factors for papillary cancer thyroid, it is going to be associated with history of ionizing radiation to the neck. Patient who had Hodgkin's lymphoma at the childhood, got an RT, then in future develops a thyroid cancer, that is going to be a papillary cancer thyroid. Then history of thyroid duct cyst and Hashimoto's thyroiditis. Okay? Whereas with respect to follicular, it is long-standing untreated goiter, and for medullary cancer thyroid, it is associated with Men's syndrome. Now, this is a very important point. Clinically, when you see a question, how do you know that you're dealing with a papillary cancer thyroid? Are you dealing with your follicular, anaplastic, or medullary cancer? For papillary, solitary thyroid nodule like presentation with cervical lymphadenopathy or isolated cervical lymphadenopathy called as lateral aberrant thyroid. Follicular cancer, it will be goiter like presentation with pulsatile forehead bony swelling. Anaplastic, massive swelling which is occupying the neck, rapidly growing, causing pressure symptoms. Medullary cancer, they also produce a compound called as serotonin which is going to stimulate the GI mucosa, resulting in diarrhea. So a thyroid swelling with diarrhea, it is medullary cancer thyroid. These are the important pickup points that you need to remember. Okay. Now, the mode of spreads are important. The most common route of spread for your papillary is lymphatics. For your follicular is hematogenous. For your anaplastic is direct, and when it comes to medullary, it is lymphatics as well as hematogenous. What is the most common site for secondaries? For papillary, it is lungs. For follicular, it is bones. Usually, it is going to go down to the flat bones. It usually results in osteolytic secondaries. Then you have lungs for anaplastic, and it is liver for medullary, followed by bones. The bony secondaries caused by medullary cancer thyroid is usually blastic. Master blaster is what you remember it. Okay? Clear? Chalo. Investigations, all of them are going to be the same context, but what is, remember, in follicular cancer thyroid, FNSC is useless. FNSC cannot differentiate between follicular adenoma and follicular carcinoma. Why? Because the only way you can differentiate follicular adenoma from follicular carcinoma is by looking at capsular and the vascular breach, which is present in malignancy, absent in adenoma. That can only be done when you do a lobectomy with frozen section. Remember, your pathologist will give you a report on FNSC called as Thai3, which is called as follicular origin. So for that to conclude as diagnosis, you have to do your lobectomy with frozen section. Tumor marker for all three of them, which are follicular origin, is your thyroglobulin, whereas for your medullary cancer thyroid, it is going to be CE and calcitonin. What are the HPE findings? You will see orphanania and nuclei, Samoa bodies in papillary cancer thyroid. Samoa bodies are also seen in other condition called as PSM, papillary variant of RCC, serous adenoma of your ovaries, meningiomas. Whereas you can see Ashkenazi cells or oxyphilic cells, which indicates what? Which indicates that the patient is having Hurthle cell cancer, which is an aggressive variant of follicular cancer thyroid. Whereas when you see these bands, these muscular band like streaks, these are amyloid in stroma, which is conclusive for medullary cancer thyroid. As simple as that. Okay? Now, as I told you about Men's syndromes, they are going to be very, very important. Men is your multiple endocrine neoplasia. Men 1 is Werner syndrome. Werner is going to be your progeria. This is going to be Werner syndrome. All three P, pituitary adenoma, parasitic adenoma, pancreatic adenoma. Men 2A is called as sickle syndrome, parasitic adenoma, medullary cancer, pheochromocytoma. Men 2B is now called as Men 3, which is associated with mucosal neuroma, medullary cancer, pheochromocytoma, and Marfan hepatitis. Men 4 is Men 1 with reproductive organ tumors. As simple as that. Right? If I take another important components, you have to remember all these components with respect to your Men syndrome. Okay? Now, in the breast, what are important? Okay? The first one is BIRADS, breast imaging reporting data system. In BIRADS, what will they ask you? What they ask you is category 3 of BIRADS. Category 3 basically means probably benign. If it is probably benign, how are you going to deal with it? You are going to call the patient for follow-up after 6 months, and that is your exam question. In a BIRADS 3 category, when will you call the patient for follow-up? It is going to be after 6 months. As simple as that. Okay? Rest of them is going to be pretty straightforward. Now, you cannot go to the exam without knowing about your TNM of breast cancer, your staging of breast cancer, and the management of breast cancer. Now, as we all know, T is going to be size, N is the lymph node status, M is metastasis. How do you remember it? Now, for T staging, I've given you a small diagram. Breast, pectoralis fascia, pectoralis major, pectoralis minor, ribs, intercostal muscles, serratus anterior group of muscles. This is the entire set. If a tumor is less than 2 centimeters confined to breast, T1 disease, 2 to 5 centimeters within the breast is T2 disease, more than 5 still in the breast is T3 disease. What is T4A? Any size that is going to involve the chest wall. Okay? Now, chest wall is made up of what? It is made up of ribs, intercostal muscle, serratus anterior group of muscle. 4B is involvement of the skin. How do you know the skin is involved? 3 findings that the skin is involved. Number 1, ulceration. Number 2 is going to be POD orange. Number 3, satellite nodules. Remember 3 important words to tell you there is involvement of skin in breast cancer. What are the 3 important words? Ulceration, POD orange, and satellite nodules. That is T4A. T4B is both. Sorry, T4C is going to be both. That is involvement of chest wall as well as skin. And if there's an inflammatory breast cancer involving more than 1/3 of the breast skin is what we call it as T4D variety. Lymph nodes, same-sided axillary mobile T1. Same-sided axillary fixed T2A. If there is internal mammary group of lymph nodes involvement, that is going to be T2B. Now, T3A is going to be a apical group of lymph nodes, that is your, we call it as the infraclavicular ones, right? 3B is going to be A plus B. Okay? That is going to be internal mammary as well as the axillary group of lymph nodes. 3C is going to be supraclavicular. M0, M1, no state of metastasis. Now, in terms of staging, how do you know it is an early invasive, locally advanced, or it is going to be advanced breast cancer? The easiest way to remember is about your locally advanced. How do you remember locally advanced? 3A, 3B, 3C. Just remember N2 disease is 3A, T4 disease is 3B, N3 disease is 3C. That's it. If you remember this, you are sorted. You don't need to worry about it. Okay? Clear? Just give me 1 second, guys. Sorry. Right? So you have 3A is going to be N2, 3B is T4, and 3C is N3. If you remember this, this is more than enough. Okay? Now, how do you manage it? For early invasive breast cancer, either you can go with simple mastectomy or breast conservative surgery. What is the current indication of breast conservative surgery? Size less than 4 centimeters, limited to 1 quart, and no evidence of lymphovascular spread, and patient should be non-pregnant because radiotherapy is contraindicated in breast conservative surgery, in your pregnancy. Then you see node status, node positive, node negative. Node positive, axillary dissection. Node negative, do a sentinel lymph node biopsy. For 3A, 3B, 3C, that is locally advanced. It is a very simple thing. First step is neoadjuvant chemotherapy, followed by modified radical mastectomy and postoperative radio and chemotherapy. The most common route of spread for breast cancer is lymphatic, followed by blood, followed by direct. The most common site for secondaries via blood is going to be bones, via basis plexus. The most common bone involved is lumbar vertebra, followed by femur, followed by thoracic vertebra. What type of bony secondaries? It has both osteolytic as well as osteoblastic, but more common with osteolytic when compared to osteoblastic secondaries. Okay? So that is with respect to breast cancer and its management. Then comes your breast surgeries. What is simple mastectomy? You remove glandular, stromal tissue, nipple areola complex. What is radical mastectomy, also called as Halstead's? You do a simple mastectomy, remove level 1, level 2, level 3 group of lymph nodes, also remove pectoralis major, pectoralis minor muscle. What is modified radical mastectomy? What did you modify in modified radical mastectomy? I did not remove the muscle, I removed only the pectoralis fascia. The 3 varieties, patties, cannulas and auchincloss. The most common is auchincloss. In Auchincloss, you retract the pectoralis minor is what you have to remember. What are the structures preserved in modified radical mastectomy? Remember, the structures preserved is A, B, C, D. A is axillary vein, B is Bell's nerve, C is cephalic vein, D is your nerve to latissimus dorsi. What are the complications associated with modified radical mastectomy? Immediate postoperative complication can be remembered as swab. Number 1, S stands for seroma, which is the overall most common complication. W is winging of scapula because of damage to long thoracic nerve. Okay. Then you have A is the arm edema. B is going to be blackening or necrosis of the flap necrosis. Remember, the most common secondary cause for upper limb edema. Most common secondary lymphedema. The most common cause for secondary lymphedema of the upper limb is your post-MRM status. Overall, for secondary lymphedema is filariasis, लेकिन upper limb के लिए specifically it is MRM. Delayed complication में post MRM 5 to 10 years later, if there's an upper limb edema with bluish discoloration, it is a lymphangiosarcoma of the upper limb, and that is what we call it as. What do we call it as? Stewart-Travis syndrome. That is what we call it as Stewart-Travis syndrome. ठीक है? Clear है? चलो. Now, in the Stewart-Travis syndrome, what surgery do you do? Quick feedback. What is the surgery? What is the surgery for your Stewart-Travis syndrome? Surgery that you do for Stewart-Travis syndrome. The surgery that you do it for Stewart-Travis syndrome is your 4-quarter amputation. You remove the arm, you remove the scapula and the clavicle of the same side. Okay? And that is what we call it as the 4-quarter amputation. Prognosis is very, very poor. Okay? Next, going to vascular surgery. I have 2 common conditions that we are going to compare with. One is going to be Burgess, another one is atherosclerosis. Burgess is also called as thromboangiitis obliterans. Okay? Now, we'll have a comparative data. As we go on, we'll talk about it. There's something called as Burgess triad also. What is Burgess triad? Quick feedback. Burgess triad क्या होता है? Burgess triad is intermittent claudication, migratory superficial thrombophlebitis, and Raynaud's phenomena. Put together is what we call as Burgess triad. Now, the comparison between Burgess and atherosclerosis is very important. The age of presentation for Burgess is age less than 40. Atherosclerosis will be age above 50. Risk factors: Burgess, smoking; atherosclerosis, obesity. Most common limb Burgess, all 4 limbs are equally involved. Atherosclerosis, only the lower limb is involved. Usually upper limb is very, very, very uncommon. Size of the vessels: Burgess small to medium, atherosclerosis large to medium sized blood vessels. Pattern of involvement: Burgess is skip lesion, atherosclerosis is continuous. How is the progression? For Burgess, it is going to be your distal to proximal. Atherosclerosis proximal to distal. Structures involved in Burgess: artery, vein as well as nerve. In atherosclerosis, only the artery is going to be involved. Now, whenever you look for it, see, the investigation of choice is going to be duplex. Okay? The best is going to be your angiography. But when I talk about it in terms of prognosis or to assess the severity, we do something called as ABPI index. What is ABPI? Ankle brachial pressure index. How do you measure systolic blood pressure to the ankle with respect to brachial artery? Normal systolic blood pressure in the body is 120 by 120. The ratio is 1. Okay. So what is the normal ABPI? 1 to 1.3. How much is your calcified blood vessels? More than 1.3. How much is the intermittent claudication? Less than 0.9. How much is going to be a rest pain? Less than 0.5. What is your critical limb ischemia? Less than 0.3. What is critical limb ischemia? It is an impending gangrene. So if you have an ABPI index of less than 0.3, you know the patient is going to land up with gangrene. So you have to act fast and act as early as possible. Is that clear? Okay. So sort this out with respect to us. Now when you have an atherosclerosis, now this is going to be the most important image. Okay. Many a times they've asked you in the exam, they've asked you multiple questions. I'll try to summarize it. So when you talk about the obstruction, that is in terms of atherosclerosis, I can have ioto-iliac, I can have iliac and femoropopliteal, 3 different sites. If it is an ioto-iliac, the blood flow to both the limbs are going to get less. So hence the patient will have bilateral intermittent claudication. Now that bilateral intermittent claudication will involve gluteus, thigh and calf muscles. Okay. If the patient is male, the internal iliac supplies to male gonads. There will be male impotency. So bilateral intermittent claudication with male impotency is what we call as Leydig syndrome. How do you overcome it? Do a bypass. How do you do a bypass? Ioto-bifemoral bypass. What will you use? Dacron material. And that's your exam question. Now, if you have an iliac occlusion, blood flow to the contralateral side is fine. Only the obstructed side is going to get affected. So there will be unilateral intermittent claudication. Gluteal muscle sparing will happen. So here involvement of thigh and calf will be there. What will you do? Bypass. How would you bypass? Ioto-iliac bypass. How would you do it? With Dacron graft. Simple. Now, if I have a femoropopliteal occlusion, only the calf muscles are going to get involved in unilateral intermittent claudication. How would you do? I do a bypass from iliopopliteal bypass. What will you use? autologous reverse great stiffness vein. Why reverse? Because the valve has to be upside down, otherwise the flow of the blood will not happen. As simple as that. Did you all understand this particular diagram? This is going to be the most important diagram for your vascular surgery questions. Most of the questions will come from this particular point. If you know this, you know the answer. Is that clear? Quick feedback. Guys, the more you interact, the more info I can give you and the more precise answers that you're going to get. Can you move on? Can we move on? Can we move on? यार आखिरी बार मैंने ये क्वेश्चन पूछा था ना, कैन वी मूव ऑन, वो मेरी एक्स थी, ठीक है. अब उसका फिर मैं बच्चों से ही पूछता हूँ, कैन वी मूव ऑन, कैन वी मूव ऑन, ठीक है. आई मीन यू ऑल शुड मूव ऑन, आई मीन वी ऑल शुड मूव ऑन. Okay, next is going to be your varicose vein. ठीक है. So in varicose vein, the most important, it is the newfound love of your NEET PG people. They love so much कि यार हर बार एक सवाल पूछ ही लेते, क्योंकि हमारे NEET PG वाले भी बहुत सीप है, तो उनको सीप, आई होप यू नो, से बहुत प्यार है. ठीक है. इंडियंस हैं तो सस्ता बनता ही है ना अपना, ठीक है, तो हमको सस्ती चीजें अच्छी लगती हैं. तो सीप क्लासिफिकेशन हमने मिस इंटरप्रेट किया कि सस्ती है. It is not सस्ती, it is expensive. ठीक है. Let's try to understand. सीप में C is your clinical, E is your etiological, A is anatomical, P is going to be your pathophysiology. ठीक है. Now C0, no evidence of any venous disorder. C1, there is going to be telangiectasia reticular vein. ठीक है. Telangiectasia का size क्या है? Less than 1 millimeter in diameter. Reticular vein is going to be 1 to 3 millimeters in diameter. Then you have C2, which is varicose vein, which is going to be more than 3 millimeters in diameter. बेटा मैम को सब पता है यार, वहां से मूव ऑन हुए तभी तो मैम के पास आए हैं, वरना वहीं ना रह जाते. ठीक है. तो इट्स ओके. चलो. C2 is varicose vein, which is more than 3 millimeters in diameter. C2R is your recurrent varicose vein. C3 is edema. C4A is pigmentation. Pigmentation is because of hemosidrosis. What is hemosidrosis? It is hemosidrin, which combines with melanin of the skin, gets imparted. Now this pigmentation is considered to be foreign, so hence there will be repeated inflammation causing lipodermatosclerosis, which will present to you as woody limb and inverted champagne bottle appearance. C4C is coronophlebectatica. Coronophlebectatica is going to be your mallular flare. You will see all the veins around the malleus, which is going to be present. C5 is heated venous ulcer. C6 is active venous ulcer. C6R is recurrent venous ulcer. We've already decided and discussed how a venous ulcer looks like it, so don't worry about it. Etiology, EP is primary, that means within the wall. ES is outside the vein wall, that is secondary. EN, no etiology found. PR is reflux of blood flow. O is obstruction to the blood flow. PRO is reflux and obstruction to the blood flow. And PN is no pathophysiology found. ठीक है. Based upon the anatomical location, AS is superficial, AD is deep, AP is perforator, AN no anatomical site found. Now, investigation is duplex. If there is an SFJ incompetency, you see Mickey Mouse sign. Mickey Mouse में जो बड़ा face है, that is going to be common femoral vein. One of the ear is going to be great stiffness vein. Other one is your common femoral artery. Now, how do you manage it? I've given you a quick succession. You can go with open surgeries for SFJ. That is going to be great stiffness vein and short stiffness vein. Varicosities, you can go with Trendelenburg surgery, flush ligate and strip. Stripping is optional. You can use an endovenous laser ablation. The laser uses 1470 nanometers. You can use a radiofrequent ablation, and the temperature generated is 120 degrees Celsius at a 20 seconds per cycle. On a perforator incompetency, you can do SEPS, that is sufficient endoscopic perforator surgery, or you can do a sclerotherapy, which is used. The most common agent used in sclerotherapy is sodium tetradecyl sulfate. How do you do it? By creating foam. How do you create foam? You mix air and sclerosing agent in a ratio of 4:1, and this is what we call as foam sclerotherapy. The creating foam by combining with air is what we call it as the Saris method. That was your previous exam question. Do not forget about it. Now, if the patient has a venous ulcer, then you will use something called as Bisgard's regime. What is Bisgard's regime? 3E. What are 3E? It is educate, elevate, and usage of elastic compression stockings. Okay, all of them are important. How much should be the limb to be elevated? The level of the heel should be above the level of the heart. As simple as that. Okay, clear? How will they ask the question based upon ADAP? Acha. But see, normally they will say the varicosity is because, let's say patient is having a deep venous system and then develop a varicose vein. ठीक है. अच्छा, इसमें primary cause is it, when you look at it in terms of, let's say varicose vein ही है, तो I will say it is a C2 disease. Now it is secondary to DVT, so etiology will become ES. Now it is because of obstruction to the blood flow. So it will become PO. Okay. Then it will come to which site it is basically produced. Okay. It is because of deep venous system getting blocked. It is AD. Okay. So this is how you are going to talk about post DVT. If a patient develops varicose vein, this is how you have to give your SEEP classification. I hope I made sense out of it. Clear? Hai? Sorted. Can we move on? Can we move on? Chalo. Moving to the plastic surgery. Okay? Chalo. In the plastic surgery, skin graftings are important. So we'll be talking quickly about the difference between a partial thickness skin graft and a full thickness skin graft. The partial thickness skin graft is also called as a Thierch graft or also known as split skin grafting. The full thickness is what we call as Wolfie's graft. Okay? What do you take in a partial thickness skin graft? Partial thickness, it is going to be epidermis and a part of dermis. Full thickness mein epidermis and the entire dermis. Okay? I will give you this PDF beta. This PDF is for you only. Okay? So I'll share it right after our lecture is done. It will be shared on the Telegram group, which is on the Meded channel. It is going to be your Meded. It will also be shared on my personal Telegram channel. It is called as The Surgery Guy. It is also shared on the Instagram. I'll share the link. It is the Instagram channel that you need to follow is also The Surgery Guy. My name is Dr. Sandeep Sriram Reddy. Just in case you don't know it, go follow across there. Okay? Now you'll get all the PDF from there. Asha. Now, what are the devices used to extract the skin grafts? If you're using a mechanical device, it is called as Hembe's knife. If you're fancy, you will use an electric dermatome, as simple as that. But how do you know that you've taken the correct thickness? For a partial thickness skin graft, you see a punctate shaped hemorrhages, whereas in full thickness, you will see a subcutaneous fat is being exposed. Presence of punctate hemorrhage indicates partial thickness. Exposure of subcutaneous fat indicates full thickness skin grafting. Now, when you look at the comparison between the donor sites, okay, partial thickness skin graft is going to cause a temporary defect. It will regrow back. So the defect here is temporary, whereas in full thickness it is permanent. There is no scar in partial thickness. It will leave a scar in full thickness. You can take any size because regrafting, it will regrow again, whereas it leaves a permanent defect in full thickness. You will take a smaller graft. The repeat grafting from the same donor site is possible in partial thickness. It is not possible in full thickness. The most common site for partial thickness skin graft is going to be thigh, whereas for the full thickness is going to be retroauricular. When you look at graft survival, it is good in partial because it requires less nutrition, whereas full thickness requires more. When you talk about contracture, secondary contracture is more in your partial thickness, whereas in full thickness, primary contracture overpowers it. And that is why cosmetically partial thickness is poor, whereas full thickness is good cosmetically, because in full thickness, secondary contraction is less. See? Now, what are the causes for graft failure? It is hematoma, seroma, repeated movement, infection in periosteum. Most common is going to be hematoma. How do you prevent the hematoma and seroma collection? By doing a technique called as pie crusting. The advantage of pie crusting, it also increases the surface area of the graft by 1.5 to 6 times. If there is a repeated movement, you immobilize the joint. If there is infection, do a preoperative wound site culture, and remember, presence of beta hemolytic streptococci is an absolute contraindication for skin grafting. Absence of periosteum, there is no vascularity on the bone, hence the graft will not take up, so it is not good to put the graft down there. See? Next, they'll ask you the repair criteria for cleft lip and the cleft palate. I'll give you very simple. If there's a unilateral cleft lip, repair between 5 to 6 months, bilateral 4 to 5 months, soft palate is 6 months, hard palate is 15 to 18 months. This is the data you need to know. If they ask you combination, you can go ahead. For example, if they ask you, if you have a patient with both cleft palate, which is soft and hard, how will you repair it? I will do 2 surgeries. First, I will repair soft palate at 6 months, and then 15 to 18 months, I'll do hard palate. Now, if you add lip to it, if there's unilateral, I will do 5 to 6 months lip and soft palate and 15 to 18 months hard palate. If bilateral cleft lip is there, I will use that 4 to 5 months period to repair the lip and the soft palate in the same surgery, but second surgery will be after 15 to 18 months for hard palate. That's how simple it is. Okay? Nothing more than that. Now, flaps has been your exam question. So there's something called a 5C classification of flaps, which you all should know. What is 5C basically means? It is circulation, composition, contiguity, contour, and conditioning. Okay. Now, what they are most likely to ask is, with respect to your rhomboid flap and Z-plasty, which is also called as Limburg flap. I hope rhomboid flap, everybody knows it is used for your pilonidal sinus defects. What type of flap it is? This is a previous exam question. The type of flap it is a transposition flap. It is what? It is a transposition flap. That is what you have to remember. Nothing more than that. Okay? Now, Matthews and Ace classification is again your potential exam question. It is basically on the muscle supply. It's a muscular flaps that you're going to take. It's a free flap that you can take, or you can take also as, a distant flap also. Type 1, what is a type 1 Matthews and Ace? I would say the flap that you can take. Type 1, the muscle will have only one dominant blood supply. Example is tensor fascia lata. Type 2, you have one dominant but two axillary supplies. Example is gracilis. Type 3, the two dominant blood supplies, gluteus maximus. Type 4, you have multiple smaller supplies, no dominant one. This is sartorius. Type 5, one dominant, multiple smaller ones. The answer is going to be latissimus dorsi. Okay? It is going to be a latissimus dorsi muscle flap. Clear? Okay? This is your latissimus dorsi muscle flap. Clear? Okay. So this is all in all with respect to plastic surgery. So far, any doubts, any questions, quick feedback? Koi sawal, koi shak, anything that you want to ask? So, next going on to nutrition. Right? What is the current indication for total parenteral nutrition? First is short bowel syndrome. Okay. Now, what is the definition of a short bowel syndrome? If the total length of the small intestine is less than 200 centimeters. If the total length of the small bowel, which is left behind, is less than 200 centimeters, it is your short bowel syndrome. Then you have high output enterocutaneous fistula. If you have an intracutaneous fistula and the output is more than 500 ml in 24 hours, it is high output enterocutaneous fistula. Acute active inflammatory bowel disease, initial phase of acute pancreatitis, and prolonged ileus beyond 72 hours. Okay? What is the composition of TPN? This is your previous exam. They've asked you how much energy is being delivered. That's also important. Carbohydrate is the maximum one, that is 40 to 50%. Energy released by carbohydrate is 3.5 kilocalories per gram. Fat is 30 to 40%, 9 kilocalories per gram. Proteins are going to be 10 to 20%, 4 kilocalories per gram. Vitamins and trace elements do not contribute to volume or energy per se, but they're essential. Okay? So this is with respect to total parenteral nutrition. So that concludes another set of your discussion. Okay? Now going into another important topic, that is going to be trauma. Okay? Chalo. So the discussion on the trauma topic, hit your questions, we'll address and answer it then and there itself. Now in the trauma, the first one is triage. Okay? Triage is a color coding system, everybody knows it. The question that was asked is, it is done on the basis of, it is done on the basis of outcome when compared to severity. Now they have given you various color codes. The highest priority is for red, least is for black. Black is dead, red is your emergency or immediate attention, yellow is urgent, green is delayed, blue is going to be moribund. So the sequence has to be red is more important, then you take yellow, then you take green, then you take blue, last is black. Okay? Now, shock has been our repeat exam question. I cannot move without discussing shock. Now, one of the important ones is going to be your hemorrhagic shocks. Now, based upon how much amount of blood volume is lost, you have divided them into 4 different classes. Class 1 less than 15%, class 2 is going to be 15 to 30%, class 3 is 30 to 40%, class 4 is more than 40%. Okay? Now, if you have a doubt, if you ever play tennis, tennis ke points kya hota hai? 15, 30, 45. Okay? That's how you do it. Okay? So, it is going to be the same. 15, less than 15%, 15 to 30%, 30 to 40%, more than 40%. So class 1, class 2, class 3, class 4. Right? In class 1, everything is normal. Just give oral fluids. Class 2, you will see heart rate increases, systolic blood pressure remains normal, pulse pressure drop, urine output drops. It is not becoming oliguria, it is just dropping. And here you start with patient with IV fluids. Okay? Now on the other hand, class 3, you will see everything going to get deranged. There will be oliguria, GCS patient becomes confused. Here you start the patient IV fluids and also give blood transfusion if required. Class 4, everything is deranged. Patient become into anuric status and then becomes unconscious. Remember the protocol for massive blood transfusion initiated in class 4 hemorrhagic shock. What is the definition of massive blood transfusion? It is more than equal to 10 units of blood are transfused or 10 units of PRBC is transfused within 24 hours, and the ratio in which you have to transfuse is if 1 PRBC is there, 1 FFP and 1 platelet. So it is 1:1:1 to prevent coagulopathy. Okay? Okay. बेटा I've been telling you again and again, जो मैं आज पढ़ा रहा हूं, this is a combination of all the topics that you can think about that had come in last 5 years. ठीक है? So I've taken the topics which are essentially been on NEET PG, they've been on INICET, they've been on FMGE exam, they've been on CMC, that is your UPSC exam also, whatever is it's a bunch of topics which they love. They cannot look beyond it. ठीक है? So my objective, I've been telling you every single time, this exam, competitive exam per se, is about being smart. ठीक है? NEET PG का एग्जाम उसी कॉन्टेक्स्ट पे चलता है. 70% of your NEET PG topics are repeat. I'm not saying question, but topics are repeat. 30% are difficult. The topper is usually between 70 to 75% of score. ठीक है? If you do your previous year topics to the fullest of capabilities of all 19 subjects, you are assured to get that top rank that you desire. If I'm not being very cocky about it, you can get a triple digit rank if you're true to all 19 subjects. There is no big hidden truth about it. ठीक है, इसके beyond कोई सत्य है ही नहीं. सत्य इतना है कि we ignore the most simplest strategy and we want to adopt the most complex one. क्योंकि दिखना cool है, ठीक है, होना cool नहीं है. वो दिखने के चक्कर में बैंड लग जाती है. ठीक है, we'll stick to the plan and trust me, the simplest plan gives you the greatest results. I repeat, the simplest plan will give you the greatest result. Stick to it. ठीक है, चलो. Okay. This was a previous exam question. They asked you about, see, every time we talk about GCS, everybody knows about GCS. So I'm going to skip about it. But they have asked you head injury classification based upon the GCS score. Okay? So there's something called as minor, where our GCS is 15 by 15 with no loss of consciousness. Mild is 14 to 15 with loss of consciousness. Moderate is 9 to 13. And your severe is less than or equal to 8. What is the indication for prophylactic intubation or GCS of less than or equal to 8? ठीक है, when is the risk for coma or the increase is for coma in a patient of trauma when the GCS falls less than or equal to 8. So hence in these patients I will intubate, as simple as that. ठीक है. Now usually in trauma you cannot go to the exam without knowing difference between these two, that is EDH and SDH. Everyone knows what is SDH. It is a extradural hemorrhage, collection of blood between the dura and the skull bone. Subdural hemorrhage, subdura, under the dura. This is the collection of blood between dura and arachnoid membrane. So EDH में, when you talk about it, what is the mode of injury? It is going to be temporal fracture, especially on the pterion, which is a weaky bony point. There is a vessel that is running. It is a middle meningeal artery. When it bursts, it bleeds extensively, causing extradural hemorrhage. So it is temporal fracture, usually at the site of pterion. The most common source is middle meningeal artery. Clinical feature of raised ICT, but this is going to be sudden and severe. So the features of raised ICT, sudden, severe in EDH, same features will be there in SDH also. But there it will be gradually increasing. Another important finding that you will see in your EDH, that is extradural hemorrhage, is going to be your lucid interval. Period of consciousness between two unconscious episodes is called as lucid interval. Here you will see ipsilateral pupillary dilation with contralateral hemiparesis. That is your chronic SDH or long-standing SDH. Investigation choice in both is going to be NCCT. Here you can see the opacity is convex. दोनों side पे convex, it is called as lenticular opacity. Management is going to be craniotomy. Here one side is very convex, another is concave. It is concavo-convex opacity, also called as crescent opacity. Remember, for small SDH it is conservative. Large SDH it is going to be craniotomy. For chronic SDH where it is more than 21 days, there you will go with burr hole surgery. Do not forget about it. Okay. Now another condition, post trauma, when a patient comes to you with coma, on NCCT if it is normal, then it is an indication of diffuse axonal injury, where there is a complete disruption of axon between the white matter and the grey matter, causing the patient to go into coma, but no finding on NCCT. Get an MRI done. As soon as you get an MRI done, you will say presence of punctate hemorrhage between the white and the grey matter. That is an indication of diffuse axonal injury. Very, very poor prognosis. Okay. Now, what is a Cushing's triad? Cushing's triad will be seen in secondary brain injuries, a condition where you have raised ICT, you have hypertension, bradycardia, and irregular respiratory rate. What is lethal triad of trauma? Metabolic acidosis, coagulopathy, as well as hypothermia. How do you prevent your lethal triad of trauma in your trauma management? To prevent metabolic acidosis, I will give ringer lactate. To prevent hypothermia, that ringer lactate I will give warm so that it prevents hypothermia. To prevent coagulopathy, whenever I am doing a transfusion, I will maintain a ratio of PRBC, FFP as well as platelets in a ratio of 1:1:1. Okay. Now, previously in the exam, they've asked you about the stages of DCS, that is a damage control surgery. Now, what is a damage control surgery is? It is basically a salvaging component but not causing extensive damage in the patient. Okay? Stage 1 is patient selection to identify who requires damage control surgery and who require ETC. ETC stands for early total care. Now, those who are at risk of development of lethal triad of trauma, for them, you will go with damage control surgery. Stage 2, primary exploration. What is the goal? Control hemorrhage, prevent any further contamination, do a temporary closure of abdomen, come out. Stage 3, take the patient to ICU, keep them for 24 to 48 hours, stabilize the patient, prevent or treat hypothermia and coagulopathy, and then say it to stage 4. Stage 4 is secondary exploration. The goal for secondary exploration is to correct the anatomy but not close the abdomen because there's a lot of edema in the intra-abdominal organs. It will take some time for them to subside and then the abdomen can be closed. Imagine there's edema, there's a lot of pressure, under pressure you close the abdomen, it will give away, burst abdomen. To prevent that, you will wait. And then finally stage 5, definitive abdominal closure. You cannot goof up on this. This is multiple times I've asked you this question. Stick to it, remember it. These are the different stages of your damage control surgery. Same context with shock. Now this is something that they have been asking again and again and again. Okay? Now, I take great pride in explaining shock, so I'll quickly take across here and I'll try to explain each of these parameters so that you stick to the plan. There are 3 different types of shocks that we'll be talking about: the hypovolemic shock, the cardiogenic shock, and the septic shock. Septic shock is basically a type of distributive shock. Okay? Right. Now, in order to understand, the components that we'll be comparing is cardiac output, heart rate, systolic blood pressure, jugular venous pressure, pulmonary capillary wedge pressure, peripheral vascular resistance, and skin temperature, right? This is the circuit that I'm going to use. These are the heart 4 chambers. From the left ventricle, the blood goes into the aorta. That is going to, from the aorta, it goes into organs. From the various organs, your vital, non-vital organs, they connect back into vascular pool. From there, go into right side of the heart and the circulation continues. Okay? Now, the pressure of the right atria is measured by JVP. So, JVP is a fancy word to tell you that I'm measuring the pressure in right atria. The pressure of the left atria is measured by pulmonary capillary wedge pressure. Then there is something called as the baroreceptor, which are present at the arch of aorta. It basically is very sensitive to pressure inside the aorta. Whenever the pressure in the aorta falls, baroreceptors get activated. They cause activation of sympathetic system, which will release catecholamine, that is epinephrine, norepinephrine. They act on heart, increase the heart rate. Simple. Okay. Now, if the problem is in the vascular pool, if the blood leaks, it is hypovolemic shock. If the problem is in the heart, it is cardiogenic shock. If the problem is in the peripheral vascular resistance, it is going to be septic or distributive shock. What is peripheral vascular resistance? It is the resistance offered by the blood flow into the non-vital organ. That means more amount of blood is going to vital organs. ठीक है? I've given you a small analogy here. मान लो एक बड़ा सा टंकी है और 2 पाइप लगी हुई है. ठीक है? एक पाइप मोटा, एक पाइप छोटा है. तो किसमें ज्यादा पानी जाएगा? जो पाइप मोटा है. ठीक है? अब पानी ज्यादा मोटे पाइप में जा क्यों रहा है? मोटा पाइप खींच थोड़े नहीं रहा है. छोटे पाइप में जगह कम है, इसलिए ज्यादा मोटा पाइप में जा रहा है. तो ये छोटे मोटे का गेम है. आई बात समझ में? छोटा बोल रहा है कि भाई मेरा पाइप छोटा है तो मैं पानी ले ही नहीं सकता, तो टंकी तो बोलता है मुझे तो पानी देना ही देना है. अब जब वो पानी देगा तो छोटे पाइप में नहीं जाएगा, तो ऑब्वियसली इनडायरेक्टली बड़े पाइप में चला जाएगा. तो इट इज नॉट दैट द बिग पाइप इज पुलिंग द वाटर, इट इज ओनली बिकॉज द स्मॉल पाइप डू नॉट हैव इनफ स्पेस, hence more amount of pani is going into big pipe. Same thing is your peripheral vascular resistance. PVR is a fancy word to tell you कि छोटा पाइप और मोटा पाइप. ठीक है? छोटा पाइप बोलता है मेरे पास जगह कम है, तो ब्लड ऑटोमेटिकली मोटे पाइप में चला जाएगा. मोटा पाइप जाता ही वाइटल ऑर्गन्स में, इसलिए वाइटल ऑर्गन्स गेट मोर अमाउंट ऑफ ब्लड. सो द ब्लड फ्लो इन द वाइटल ऑर्गन इज मोर. It is not because the vital organs are sucking it. It is because the vessels caliber in vital organs are bigger when compared to non-vital organs. Is the concept clear? ठीक है? तो PVR is just describing this phenomena, nothing more than that. ठीक है? Clear? Is everybody sorted with this? ठीक है? चलो. Now let's try to understand that what happens in various components. In the hypovolemic shock, ठीक है? I want you to take my lead and understand. The blood is leaking from here. ठीक है? In the hypovolemic shock, I am saying the blood is going to leak from here. ठीक है? The blood is leaking from here. What will happen to the volume of blood in the vascular pool? It decreases. If the blood in the vascular pool is less, the blood going into the right atria will decrease. ठीक है? If the blood reaching the right atria is less, the right atrial pressure will fall, because the pressure in the right atria is purely by the volume of blood going into right atria. If the blood in the right atria is less, the right atrial pressure will drop. If the right atrial pressure will drop, what is right atrial pressure? JVP. You will see the JVP is going to drop. ठीक है? तो I know in hypovolemic shock JVP drops because of this particular region. Now if the blood in the right atria is less, the blood in the right ventricle will also be less. That means the blood going back into the left atria is less. By the same logic, the pressure in the left atria will also decrease. Pressure in the left atria is measured by pulmonary capillary wedge pressure. Obviously, pulmonary capillary wedge pressure and hypovolemic shock will drop. Okay, great. Now, if the blood in the left atria is less, the blood going into the left ventricle is also less. Okay, amount of blood reaching to the left ventricle before the contraction is what we call as preload. ठीक है, अगर प्रीलोड डिक्रीज कर जाएगा तो ऑब्वियसली द कार्डियक आउटपुट विल डिक्रीज. व्हाट इज कार्डियक आउटपुट? प्रीलोड माइनस आफ्टर लोड. ठीक है, अगर ब्लड लेफ्ट वेंट्रिकल में कम है तो ब्लड बाहर भी तो कम ही जाएगा है. लेट्स से if you have 100 rupees, you can spend 80 rupees. But if you have 50 rupees, how can you spend 80 rupees? Same context, the blood available in left ventricle is less. So blood going out of the left ventricle will also be less. That means cardiac output is less. So hypovolemic shock may see there's decrease in cardiac output. If the blood going into the aorta is less, the pressure in the aorta drops. How do you measure the pressure in the aorta? It is systolic blood pressure. Systolic blood pressure drops. If the systolic blood pressure drops, I told you baroreceptor says, ayyo, there is low pressure, they get activated. And when they get activated, they secrete catecholamines, epinephrine, norepinephrine. They go into the heart, they say more blood. And that more blood is by causing rapid contraction, that is increase in heart rate. So the heart rate also increases in your hypovolemic shock. Now the amount of blood available in the circulation is less. Obviously, vital organs are more important for the body. Body बोलती है कि जो भी blood बचा है उसको vital में खींचो. कैसे करोगे? अब vital cannot suck, no. But what they can do is they can cause the blood vessels of the non-vital organs to become even more smaller. ठीक है? अगर blood vessel in your non-vital organs becomes even more smaller, the flow will become even more difficult, and that is what we call as resistance. So PVR increases in the non-vital organs so that the blood flow into the vital organs can increase. So peripheral vascular resistance increases. So blood flow to the vital organs can be maintained. So what will happen to the blood flow in non-vital organs? If the vessels of the non-vital become smaller, the blood flow into non-vital will become even more smaller or kam ho jayega. Skin is an example of non-vital organs, and blood is responsible for calorigenesis. No blood flow into the skin temperature drops. Hence, because blood is responsible for calorigenesis, no blood in skin, no heat in skin, it feels cold peripheries. Okay? So blood flow into the skin or non-vital organ decreases, hence resulting in drop in skin temperature. Is that clear? Did you all understand? कोई सवाल, कोई शक? Did you all understand? ठीक है? Now, if you have gotten hypovolemic shock, we'll go with cardiogenic shock. ठीक है? Same concept. In the cardiogenic shock, the heart is not able to contract effectively. ठीक है? हार्ट बंद नहीं हुआ. ठीक है? हार्ट बंद हो जाएगा तो इंसान मर जाएगा. ठीक है? इंसान जिंदा है. Here, the patient is alive. The only place where the heart stops when the in the contextual manner, अगर मैं आपको बोलूं, एक ही ऐसी जगह है जहां पे दिल रुक जाता है लेकिन इंसान जिंदा रहता है. That is after your heart breakup. ठीक है? फिजियोलॉजिकली ये पॉसिबल नहीं है, लेकिन मेंटली ये पॉसिबल है. ठीक है? हर उस आशिक से पूछना जिसका दिल रुक गया लेकिन वो अभी भी जिंदा है, ही विल टेल यू अबाउट इट. लेट्स कॉन्सेंट्रेट ऑन कार्डियोजेनिक शॉक फॉर नाउ. ठीक है? तो कार्डियोजेनिक शॉक में हार्ट बोलता है कि मैं नहीं पंप कर रहा इफेक्टिवली. हार्ट बोलता है कि मैं आराम से पंप करूंगा, मैं इफेक्टिवली पंप नहीं करूंगा. नाउ विद दैट लॉजिक, इफ द हार्ट इज नॉट एबल टू पंप इफेक्टिवली, द ब्लड कैन नॉट गो आउट ऑफ द हार्ट. ठीक है? इफ द ब्लड इज नॉट एबल टू गो आउट ऑफ द हार्ट, द वॉल्यूम ऑफ ब्लड एजेक्टिंग द हार्ट इनटू द आयोटा इज लेस. इसका मतलब क्या है कि कार्डियक आउटपुट इन कार्डियोजेनिक शॉक विल ड्रॉप. दैट इज व्हाट इज हैपनिंग. कार्डियक आउटपुट इन कार्डियोजेनिक शॉक ड्रॉप्स. ठीक है? नाउ इफ द वॉल्यूम ऑफ ब्लड coming out of the heart into the aorta is less, the aortic pressure will drop. Aortic pressure is measured by systolic blood pressure. Systolic blood pressure drops in cardiogenic shock. अब देखो, बारोरेसेप्टर को थोड़ी ना पता है कि हार्ट आशिकी में टूटा है कि फिजियोलॉजिकली टूटा है. उसको इतना पता है कि ब्लड कमिंग इनटू द aorta is less. So aortic pressure is less. Whenever the aortic pressure is less, they activate the baroreceptors. Baroreceptors are catecholamines, sympathetic pathway, epinephrine, norepinephrine. अब वो हार्ट को बोलते हैं और काम कर. ठीक है? ये तो वही बात होगी ना कि अभी हार्ट का ब्रेकअप हुआ, and then you see a beautiful girl walking through it. Now you are more confused. ठीक है? Should I learn from my previous breakup or should I concentrate on my future? Same thing with the heart also. अब baroreceptors catecholamine बना रहे, catecholamine they're going to send more epinephrine, norepinephrine. They twitch, they cause the heart to contract more faster. So what is happening? The contractility is increasing but not the effectivity. So heart rate in cardiogenic shock also picks up. ठीक है? अच्छा, the amount of blood in the circulation is less. Obviously blood ejecting out is less, blood coming to the circulation is less. Same phenomena, more amount of blood should go to vital. Non-vital बोलता है ठीक है मैं sacrifice कर लेता हूं, मैं और छोटा हो जाता हूं, so that more amount of blood can go to vital. So here what is going to happen? Peripheral vascular resistance in your cardiogenic shock increases. If PVR increases, blood flow to non-vital organ, that is skin, decreases, so hence skin temperature will fall. ठीक है, until यहाँ तक fine. Blood coming out of the heart is less, blood going into the vital non-vital is less, blood coming to the vascular pool is less, but if the blood coming to the vascular pool is less, the blood going back to the right atria is also less. So you might be thinking that right atrial pressure will drop. It will not drop. Why? Because heart is not pumping. No. So पूरा जो blood था वो अभी भी heart में भरा हुआ है. Heart is not able to evacuate. It is already having so much amount of blood, and then you're giving some more amount of blood. So what is happening? The all four chambers get pressurized. Right atria already has some amount of blood. It is not able to eject out. You pour more amount of blood. Right atrial pressure increases. Hence JVP and pulmonary capillary wedge pressure increases. It's a very very simple concept. कि heart बोलता है मैं पूरा खाना मतलब the blood is not being ejected out, and you're giving again some amount of blood. So obviously pressure in the heart will mount, and that is the reason for cardiogenic shock. ठीक है? Clear? Sorted. Did you all understand about cardiogenic shock? आई बात समझ में? Clear. Guys, shock is very important. शॉक सुन के आप शॉक में मत चले जाना. मेरा काम आपको है कि शॉक समझाना और आप शॉक में ना जाना. Can you move on? ठीक है. Can you move on? चलो. नेक्स्ट इज गोइंग टू बी सेप्टिक शॉक. ठीक है, तो सेप्टिक शॉक में प्रॉब्लम क्या है? सेप्टिक शॉक में प्रॉब्लम यह है कि आपका नॉन वाइटल ऑर्गन बोलता है कि हर बार मेरा ही बैंड बजा दो तुम, अब मैं नहीं बात मानूंगा. ठीक है, इन सेप्टिक शॉक पेरिफेरल वैस्कुलर रेसिस्टेंस इज लॉस्ट. ठीक है, now what do you basically means by loss of peripheral vascular resistance? It basically means there is universal vasodilation throughout the body. So the size of the blood vessel in vital and non-vital organs becomes same. The aorta also becomes dilated. ठीक है, तो aorta is dilated, the vessels in the vital and non-vital organs is also dilated. यही problem है. ठीक है, now imagine it this way. Forget about everything that is going to happen. If there is loss of peripheral vascular resistance, ठीक है, the blood going into vitals and non-vital organs will become same. So I've given you a small example. Normally when the 100 ml of blood comes, 80 goes to vital, 20 goes to non-vital. When there is loss of peripheral vascular resistance, equal amount of blood goes to both vital and non-vital. So vital gets 50, non-vital also gets 50. Now here is the point. Vital requires 80, you're giving 50. So vital organs requirement is more and the supply is less. So they are hypoxic, hence the status of shock. Non-vital requirement is 20, you're giving more, 50. So what is going to happen? More amount of blood is going to go into non-vital organs. Example like skin. When more blood is reaching, what will happen? Blood is responsible for calorigenesis. More heat will be produced. ठीक है, skin will get more hot. It will get more, और गर्म हो जाएगा. And that is how you will say warm peripheries in your septic shock. ठीक है, why? Because more amount of blood goes into skin and the calorigenesis in the skin increases and the patient will become warm. ठीक है, यहाँ तक ठीक है. Ultimately, when you look at it, 100 ml was coming, 50 goes there, 50 goes there. When they come back to the vascular pool, the amount of blood remains same. Even without septic shock also, 80, 20, 100 was coming, 100 was here, 100 was here. So in either ways, the blood coming back to the vascular pool remains same. That means the blood going back to the right atria will also remain same. That means the right atrial pressure will remain same. That is your JVP will remain same. That is why in septic shock, you say JVP is initially normal. If the amount of blood coming in the right atria is normal, the amount of blood going to the right ventricle will also remain the same. Hence, the blood coming back to the left atria also remains same. Left atrial pressure will also remain same. That is unchanged or normal. That is why pulmonary capillary wedge pressure will also remain normal in septic shock. If the blood in the left atria is same as before, that means the blood in the left ventricle will also be same as before. Okay? That means the blood going out of the left ventricle into the aorta will also be same as before. Okay? That means what? The Stokes volume remains same. But there's a problem. The Stokes volume is same, but the aorta is dilated. Initial aorta was like this. Now the aorta has become bigger. The volume of blood coming into the aorta is same, but the size of the aorta is dilated. So what will happen to the pressure in the aorta? It will fall. How do you measure the pressure in the aorta? Systolic blood pressure. So you see systolic blood pressure is going to drop in septic shock. If there's decrease in systolic blood pressure, what is going to happen? Baroreceptors, catecholamine, epinephrine, norepinephrine, what will happen to heart rate? So heart rate in septic shock is going to increase, right? How do you measure cardiac output? Cardiac output is stroke volume into heart rate. Stroke volume remains same, heart rate increases. So what will happen to cardiac output? The cardiac output is going to increase. As simple as that. Okay? In septic shock, the cardiac output increases. How do you measure cardiac output? It is stroke volume into heart rate. Stroke volume is same, heart rate increases, hence cardiac output increases. Why is there a loss of PVR? It is because of bacterial endotoxins. The bacterial endotoxins basically decrease. Lot of these have to do with vagal tone also, right? When the vagal stimulation will occur, it causes relaxation basically. Clear? So this is how you interpret all three different types of shock: hypovolemic, cardiogenic and septic shock. ठीक है? आज के बाद से कभी confuse नहीं होने का. Clear? So here ना cardiac output, stroke volume into heart rate. Septic shock में stroke volume remains same, heart rate increases, hence cardiac output increases. I've given you a note point. Remember, in neurogenic shock or spinal shock, baroreceptors are compromised. So this is the only shock where you have bradycardia with hypotension. हर जगह पे क्या है? Tachycardia with hypotension होता है. यहाँ पे brady with hypo मिलेगा. Is that clear? Sorted. ठीक है. Why JVP and pulmonary capillary wedge pressure increases in cardiogenic shock? ठीक है. Cardiogenic shock में problem क्या है? If I have to give you in a pictorial form, ये आपका नॉर्मल हार्ट है, ठीक है. These are the four chambers of the heart, ठीक है. This is your right atria, this is your right ventricle, this is your left atria, this is your left ventricle, ठीक है. So there is aorta which is ejecting the blood out, and there is IVC and SVC which is bringing the blood here, ठीक है. So basically ये inlets है into the heart and there is only one outlet, ठीक है. यहाँ तक सबको पता है. What is going to happen is, you will see the blood which is going to be here, it will come into the right atria. From the right atria, it will go into the right ventricle. From the right ventricle, it will come into the left atria. From the left atria, it will go into the left ventricle. And from the left ventricle, you will see the blood is going to eject out. Okay? Usually, after the contraction, once the cardiac cycle is finished, at any given point, at the end of the cycle, I will expect the chambers to be empty. ठीक है. तो आप देखोगे राइट एट्रिया में ब्लड नहीं है, राइट वेंट्रिकल में ब्लड नहीं है, लेफ्ट एट्रिया और लेफ्ट वेंट्रिकल में भी ब्लड नहीं है. इमेजिन इन अ साइमल्टेनियस मैनर. ठीक है. सो दिस इज हाउ अ नॉर्मल हार्ट वुड फंक्शन. ठीक है. In a cardiogenic shock, what is happening is the heart is not able to pump effectively. If they are not able to pump effectively, you see the blood is not able to eject out. If the blood is not able to eject out, what will happen? The blood will start pooling here. If the blood is pooling here, obviously because heart is not contracting effectively all four chambers, because right atrial will give to right ventricle, left atrial will give to left ventricle, it will only happen when the heart contracts properly. If the heart is not able to contract properly, obviously all four chambers will have some amount of blood. Problem is not that. Problem is, even though this amount of blood, you are still pouring the blood because the body does not know. No, it is still bringing the blood into right atria. ठीक है. Already थोड़ा blood है और ज़्यादा blood यहाँ पे आ गया. So what will happen? The volume of blood in the right atria will increase. ठीक है. Now this volume will transfer into right ventricle. From there it will transfer into left atria as well. So you see all four chambers already some amount of blood and you pour a little bit of more. So the pressure in these will continue to increase. तो ये empty हो ही नहीं पा रहा ना, इसीलिए pressure बढ़ रहा है. Is that clear? Clear? हाँ बेटा, neurogenic everything is down. How much time will you take to complete surgery? I don't know. I will teach until I finish the surgery. I think by night, आज के रात के 12-1-2 बजे तक खत्म हो जाना चाहिए. By tonight, 2-3 we should be able to finish. What do you say? ठीक है. Can we go on? Chalo. Now, how do you monitor shock? These are your previous exam questions. Okay? Indices to monitor shock. I've already dealt with the cannula color code and all, so we're not going to revise it. Now, we have something called a shock index, which is heart rate upon systolic blood pressure. Problem is you're not taking diastolic into consideration, so hence we came up with modified shock index. Modified shock index is heart rate upon mean arterial pressure. This is the best method to monitor shock. Then you have CVP, that is central venous pressure. The normal CVP is 8 to 12 millimeters of mercury. Mixed venous saturation is more than or equal to 65%, and urine output is the best clinical method to monitor shock. Okay? When do you stop resuscitation? Now, these are the various components, right? Systemic circulation. So, starting resuscitation is very easy. Patient with hypertension, tachycardia, मुझे पता है patient shock में, मैंने fluid चालू कर दिया. बंद कब करोगे? You measure mixed venous saturation. अगर वो more than 65 है, you can stop it. For muscle perfusion to know whether it's adequate or not, you can do a near infrared spectroscopy. For brain, same. For gut perfusion, you can do a near infrared or also do a gut mucosal pH. Now, these are your previous year questions which are repeatedly asked. ठीक है, बार बार इसी में आपको पकड़ के निचोड़ के ऐसे 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 खेलते रहते हैं, आप भी अब इग्नोर कर देते हो and then you are like जाने दो. तो मैं आया हूं आपको ये सब रिवाइज कराना. ठीक है, all these are important trick questions of your shock. फर्स्ट इज सर्स. आज के डेट पे एग्जिस्ट नहीं करता, बट एग्जाम के लिए इंपॉर्टेंट. सिस्टमिक इन्फ्लुएंट रिस्पॉन्स सिंड्रोम. सर्स का क्राइटेरिया टेंपरेचर लेस देन 36 और मोर देन 38, WBC लेस देन 4000 और मोर देन 12000, RR मोर देन 20, दैट इज रेस्पिरेटरी रेट, एंड हार्ट रेट मोर देन 90. Any two is positive, we say SIRS is positive. Now, what is sepsis? Sepsis is SIRS with known foci infection. What is septic shock? It is sepsis with hypotension not responding to IV fluids. What is MODS? When more than or equal to 2 organs fail at the same time. Now, we have moved away from your SIRS. Now we are into Q-SOFA score or SOFA. Q-SOFA stands for it is sequential organ failure assessment. Q is quick. ठीक है, तो क्विक में क्या क्या कंपोनेंट है? सिस्टोलिक ब्लड प्रेशर, GCS एंड RR. ठीक है. Now what you have to remember is in your SIRS we had RR, here also you had RR respiratory rate. SIRS में respiratory rate should be more than 20, in Q-SOFA it should be more than 22 cycles per minute, and that is what your takeaway message is. If any two is positive, it is associated with poor outcome. Surviving sepsis guidelines is your exam question. Within first 6 hours you should achieve this. CVP should be 8 to 12, MAP should be more than 65, that is mean arterial pressure. Urine output should be more than or equal to 0.5 ml per kg per hour, and mixed venous saturation should be more than or equal to 65%. You know this, you know your answer. As simple as that. Clear है? ठीक है, sorted. This is with respect to surviving sepsis guidelines. Sorted. So this is all in all with respect to shock. Nobody can ask you beyond this with respect to shock. ठीक है, चलो. Continuing on trauma, we now go into abdominal trauma. Abdominal trauma may be something called as FAST. What is FAST? It is focused assessment with sonography in trauma. They'll ask you what are the components that you assess in FAST. We have perihepatic, pericardial, perisplenic and pelvic. Minimum fluid required for FAST to be positive is 100 cc. Now there's something called as E-FAST, extended FAST. You look for both the thorax. What are you looking in thorax? You're looking for pneumothorax. What are the USG findings of pneumothorax? The USG finding for pneumothorax: absence of seashore sign, presence of barcode sign, presence of stratosphere sign. I mentioned here, that is with respect to FAST. Now, with respect to your abdominal trauma, what is the most common organ injury overall? That is going to be liver. Blunt trauma में spleen है, penetrating में liver है, seat belt के साथ mesenteric tear है, blast injury में small bowel है. Is that clear? I have specified each and every single point that they exist. फिर आपसे बार बार पूछा जाता है कि यार solid organ injury में splenic trauma कैसे manage करोगे? ठीक है? Now, there are different ways to understand and remember it. I've put in a simplified manner. In splenic trauma, the grading is done on the basis of the hematoma occupying the surface area, that is subcapsular hematoma, and the depth of laceration. Okay? Grade 1, hematoma less than 10%, laceration less than 1 centimeter in depth. Grade 2, if the hematoma occupies 10 to 50% of the total surface area, laceration is 1 to 3 centimeters. Grade 3 is more than 50%, more than 3 centimeters in depth. Grade 4, intraparenchymal hemorrhage, more than 25% of the spleen is devascularized. Grade 5, completely shattered spleen, broken into smaller pieces, as simple as that. Grade 1 to is conservative. Grade 4, that is grade 4 and grade 5 is going to be emergency splenectomy. Grade 3, agar patient stable, a conservative patient. If is unstable, take the patient for splenography, that is spleen preserving surgery. Grade 1, grade 2, stable, grade 3, all of them has to have a repeat CT after 24 hours. If there is increase in grade, Then you are going to do a contrast CT. In that you will see that a CT angio should be done. You look for a contrast blush. If there's presence of contrast blush, you attempt an angioembolization. If it fails, go with splenography. This is the whole objective that they exist for. Okay. Now, post emergency splenectomy, you need spleen protects us from capsulated organism. Okay. So when a spleen is going to protect you from a capsulated organism, you have to give vaccination for it. Now, post-splenectomy vaccination can be elective or emergency. Elective mein kya hai? You have to give 2 weeks before the surgery, pneumococcal, meningococcal, H influenza B. In emergency setting, because I cannot give 2 weeks prior, what vaccine will you give? Immediate post-op. Immediate post-op, I'll give pneumococcal. Okay. Now, if I have to put in the perspective, immediate post-op mein when you give pneumococcal, what pneumococcal vaccine will you give in child less than 2 years, and which pneumococcal vaccine will you give above 2 years? Below 2 years will give P7 valent, and above 2 years will give PPV 23. Okay? That is what you have to remember with respect to post splenectomy vaccinations. Okay? So this is all in all with respect to that of trauma. Clear hai? Sorted. Trauma में कोई सवाल, कोई शक, anything that you want to ask? How many of you are feeling tired? Clear? How many of you are feeling tired? कितने लोग को लग रहा है कि थक गए हैं? Okay, if you're feeling tired, I mean, I cannot say anything, but then you're not supposed to feel tired. ठीक है? Tell your brain that your body is fine. As simple as that. ठीक है? दिल से ज्यादा दिमाग को बुद्धू बना के रखने का. ठीक है? क्योंकि दिल बहला फुसला के वापस आ भी जाता है, लेकिन दिमाग नहीं मानता. तो दिमाग को हमेशा ढक के रखने का कि सब ठीक है, all good. ठीक है? Now, if you just want a little bit of motivation, I started my day today morning at 7 o'clock. ठीक है? I went to the hospital, did my rounds, did my OT. I had an OPD at 2 o'clock, finished my OPD at 4:30. I wanted to start the class at 5. There was some internet issue which was there in my home studio. So then we started to resolve it. Couldn't happen. Started my car, drove for 1.5 hours to get to the studio of PW. I came down here. I reached here at 7:25. Started the class at 7:30. Now we are at 10:30. ठीक है? तो just in case अगर आपको लग रहा है कि आप tired हो, बेटा मैं आपसे ज़्यादा tired हूँ. But I am motivated enough so that I can justify today's session for a better cause for your tomorrow. ठीक है? So let's keep motivating each other, because I draw all my energy from your involvement and appreciation. Same reciprocates from my end as well. ठीक है? चलो. तो देखो, there is, if I have to put very simple context, no, देखो, हारना is not an option. ठीक है? ये अंडरडॉग वाली स्टोरी, बहुत मेहनत की है, फिर भी at the end you were not able to achieve it, all these are nonsense. People, society, you per se and everybody around you only care about your winning. फोटो हमेशा जीतने वाले के साथ ली जाती है, हारने वाले के साथ नहीं. चाहे हारने वाले ने कितनी भी मेहनत की हो, उसका लक बैड लक जो भी रहा हो. ठीक है? So stop assuming that your effort is all that it matters. No. Crossing the line is the most important thing. Nobody is going to tell you this, but honestly यही सत्य है. फैक्ट ये है कि अगर आप लाइन के उस पार नहीं हो तो फर्क ही नहीं पड़ता है. लाइन के इस पार बहुत लोग हैं. ठीक है? उसमें से एफर्ट लगाने वाले भी हैं, ऐसे ही नॉर्मल वाले भी हैं. पीपल हु डोंट केयर ऑल्सो एग्जिस्ट. But how do you differentiate yourself? So crossing that line matters most, because when you have put that effort, that should not go in vain. अगर इतनी मेहनत लगा ही रहे हो तो यार पार करो यार वो लाइन. don't stay down there. ठीक है? So losing is not an option. It is not. ठीक है? You cannot afford to lose. So yes, there's a lot of motivation required and we'll do so. ठीक है? Now, with that, let's pick it up with GIT. ठीक है? So यहाँ से I think you will have more inputs to give. because GIT is something that everybody likes it. So we'll keep it very simple. So मैं start करूँगा ना esophagus से. Esophagus का, if I have to ask you, give me one telltale symptom of esophagus. I know most of you will give me it is going to be dysphagia. Correct? Okay. Dysphagia is difficulty in swallowing. Now there are a lot of questions that are going to be asked with respect to dysphagia. How do you solve it? तो मैं बोलता हूँ कि जब भी पेशेंट डिस्फेजिया के साथ आते हैं ना, you ask the patient three important questions. We call it as the standard questionnaire. The question number one is dysphagia for solids, is dysphagia for liquids, or is dysphagia for both solids and liquids? Question number two, you'll ask whether it is a progressive dysphagia or whether it is a non-progressive dysphagia. Question number three is, if the patient says, is dysphagia for both solids and liquids, then you will say dysphagia is more for. Is it more for solids or is it more for liquids? Okay? These are the three standard questions that you would actually ask your patient every single time he comes to your clinic. Okay? Now, let's say if I have a patient who says dysphagia is for both solids and liquids. Okay? And I'm saying it is a progressive dysphagia. A patient who is having dysphagia for both solids and liquids, progressive in nature, and presenting symptom is heartburn. What is your diagnosis? The minute you see heartburn, you jump into GRD. The answer is not GRD. It's a medical disorder called as progressive systemic sclerosis. On the other hand, if dysphagia is for both solids and liquids, progressive dysphagia more for liquids when compared to solids with pulmonary symptom, the answer is achalasia cardia. Okay? Obviously, pulmonary symptoms is because of aspiration causing lung abscess. Okay? Now, same. Dysphagia, solids, liquids, non-progressive. Patient presents to you with severe chest pain. What is the answer? Diffuse esophageal spasm. Come back to the other side. Dysphagia only for solids, progressive in nature, presenting symptom is weight loss. If presenting symptom is weight loss, then it is going to be esophageal cancer. And if the presenting symptom is heartburn, it's peptic stricture. Dysphagia only for solids, non-progressive in nature. No matter what the presenting symptoms is, this is going to be a lower esophageal web, which is called as Schatzki's ring. Schatzki's ring is your post-GERD complication. There will be inflammation of mucosa, and when the inflamed surfaces come in contact, they form synicae, and these synicae are what we call it as bands, and these bands will result in lower esophageal web, which is called as Schatzki's ring. Upper esophageal web is called as, where would you see upper esophageal web? Quick feedback. Where would you find upper esophageal web? Upper esophageal web is seen in Plummer-Vinson syndrome, also called as Patterson-Kelly syndrome. Also called as Patterson-Kelly syndrome. Clear? Clear? Okay. Okay, got it. Chalo. Now, so what I have designed this time is, rather than trying to give you topic, info, images later or differently, I'm going to give you spotters and all their important points. Okay? Now, the first spotter that you have, this is about a neonate with a coiled nasogastric tube. Coiling of nasogastric tube, everybody knows it is seen in esophageal atresia. Okay? Now, how would a patient of tracheoesophageal atresia and fistula will present to you? The usual present is day 0, day 1. Okay? How does the baby present to you? With recurrent episodes of regurgitation of all feeds, continuous drooling of saliva. Obviously there's saliva drooling, so you want to aspirate it, suction it out by putting a nasogastric tube, get an X-ray done, and there you will see coiling of nasogastric tube. Investigation of choice is going to be contrast imaging. What is the contrast of choice? It is iohexol. Why iohexol? It is an iodinated contrast. It is water soluble. It does not cause harm. Hence, it is going to be taken for the baby. Diagnosis is made on the basis of your contrast imaging. Most common type is going to be type C variety. You see other congenital disorders associated with tracheoesophageal fistula and atresia is Vactral. What is Vactral? V is vertebral body defect. A is anal atresia. C is your cardiovascular abnormality, that is your patent ductus arteriosus and ventricular septal defect. Your T stands for tracheoesophageal fistula. R is going to be renal abnormalities associated renal agenesis and horseshoe kidney. L is your limb abnormality, which is called radial hypoplasia. All these are associated with your tracheoesophageal fistula. What is the long distance atresia? If the distance between two atresial segments is more than 2 vertebral body distance. What is the wait period of long distance atresia? It is more than 6 months. What will you do? If they grow, anastomose. If don't, transposition. What is the most common loop used for transposition? The answer is jejunum. What is ideal? It is going to be colon. Most common in adult use for transposition. The answer is stomach. Okay? Stomach, because in adults we are going to do it for esophageal cancers. Is that clear? Is every single point that I said about this topic? I have revised the entire tracheoesophageal fistula for you. Every single point that exists is important. We've already discussed it. Sorted? Quick feedback. Type C, beta. Type C, type C. We don't number it as 1, 2, 3, it is ABC. Okay. Chalo. The next one that you can see here, you can see there is narrowing on the upper. This is the cervical esophagus. If you ever have a doubt, you see there's the cervical vertebra. This is the skull bone that you have, and you can see there's a dilatation. There is thinning on bilateral surface. This is what we call as upper esophageal web. The upper esophageal web. It is seen in Plummer-Vinson syndrome that we just spoke about it. Components of Plummer-Vinson syndrome: iron deficiency anemia, also called as sideropenic anemia. Then you have upper esophageal web, koinonchia, atrophic glossitis, and visceromegaly. Okay. Lower esophageal ring will look like this. This is called a Schatzki's ring. We already spoke about it. Now you have a barium swallow like this. In a barium swallow, if it is presenting to you like this, this is basically an apple core sign, also called as rat tail sign, and this is what we call a shouldering sign. Okay. Now, when you talk about the esophageal cancers, what is the most common type? It is squamous cell cancer. Most common site is middle 1/3. It is seen in elderly patients. Presenting feature will be dysphagia. More for solids when compared to liquids. It will be progressive dysphagia with weight loss. This is your esophageal cancer. Diagnosis is esophageal cancer. Investigation of choice is upper GI endoscopy with biopsy. Investigation choice for T staging is endo, ultrasound. Surgery, the 3 surgeries to be remembered. This is going to be Ivor-Lewis, McKeown, Oringers. The most common is going to be Oringers. Oringers is going to be transhiatal. There are Ivor-Lewis is 2 incision, McKeown's is 3 incision, Oringers is 2 incision. What are the 2 incision of Oringers? Left cervical and laparotomy. Left cervical and laparotomy. And this is the best preferred one because Ivor-Lewis and McKeown's are going to have thoracotomy incisions which are going to be painful. Okay? Sorted. Chalo. So this is with respect to esophageal cancers. The same way you can have a spotter like this. This is a barium swallow. You can see this is the skull bone. These are the cervical vertebra. This is anterior. This is posterior. There is an outpouching on the posterior surface of the cervical esophagus. This is a classical component of your Zenker's diverticulum. Now, anywhere in the body to create a diverticulum, there are 3 important prerequisites. What are 3 prerequisites for development of Zenker's diverticulum? Number 1, the age of the patient should be high. Number 2, there should be anatomical weakness. Number 3, there has to be a trigger factor that increases intraluminal pressure. Okay? So all patients with Zenker's diverticulum are seen after the age of 50 to 60 years. Okay? Elderly patients. Second is anatomical weakness. The anatomical weakness in Zenker's is your Killian's dehiscence. Where do you see Killian's dehiscence? So this is your upper esophageal sphincter. Okay? Hyoid bone, thyroid cartilage, cricoid cartilage. This muscle is your thyropharyngeus. This muscle is cricopharyngeus. Between the thyropharyngeus and cricopharyngeus, there is one triangular area of the esophagus which is not guarded by muscle, and this area. So imagine if these two contract, this will cause more pressure, and that pressure will cause outpouching, and that outpouching will result in Zenker's diverticulum. So with that logic, if they ask you where do you see the Zenker's diverticulum? Okay? Now the Zenker's diverticulum is seen in the cervical esophagus, obviously here on the posterior surface, usually on the left side. As simple as that. Okay? Now usually the question asked is what type of a diverticulum it is, pulsion or tractional? Pulsion is pushing, tractional is pulling. It is a pushing, it's a pulsion diverticulum. True or false? It's a false diverticulum. Okay? Now where do you see it? It's in cervical esophagus. Most common on the left sided posterior side, right? Investigation of barium swallow. Management for Zenker's diverticulum less than 3 centimeters is diverticulectomy, more than 3 centimeters is we can say endostapler, we can do it, endostapler Dolman surgery, or also called as endoscopic Dolman surgery. Okay? Where you are going to split the septa between the diverticulum and the esophageal lumen. Okay? Now, another condition that you can see in a child is going to be this, where you get a massive air bubble in the left hemithorax and the cardia or the heart is pushed on the other side. Okay? This is a classical case of Bosch-Thallick hernia, which is a congenital diaphragmatic hernia. Now, the triad for Bosch-Thallick hernia is RDS, respiratory distress, extracardiac, scaphoid abdomen. This is the classical triad that you have. The most common site of defect is left-sided posterolateral. The most common organ to herniate is stomach. It is associated with left pulmonary hypoplasia. The most common cause of death in this patient is respiratory distress because of pulmonary hypoplasia, followed by pulmonary hypertension. Okay? Bag and mask ventilation is contraindicated in Bosch-Thallick hernia because it overinflates the stomach, worsening this particular condition. As simple as that. इसी का converse बता दो. If you have a right-sided anteromedial defect, the most common type of congenital diaphragmatic hernia is Bosch-Thallick hernia. 90% of your congenital diaphragmatic hernias are Bosch-Thallick. What are the other 10%? 90% तो Bosch-Thallick हो गया ना. बाकी 10% क्या है? Morgagni hernia. ठीक है, the Morgagni hernia, it is right-sided anteromedial defect. The most common organ to herniate is going to be your transverse colon. As simple as that. Sorted? चलो, ठीक है, so far so good. Now, another spotter that you have is this. This is what we call it as a patient who had a history of GRD, underwent an upper GI endoscopy, and this is the image. This is because of long-standing untreated GRD, where you have a red velvety mucosa, and this red velvety mucosa is characteristic of Barrett's esophagus. What is Barrett's esophagus? It is a metaplasia. Okay, what is happening? The squamous epithelium is converting into columnar with presence of goblet cells. Goblet cells produce mucin, and they are the characteristic of small intestinal mucosa. Hence, it is called as intestinal type of metaplasia. It increases the risk for adenocarcinoma of the esophagus. The investigational choice is upper GI endoscopy with biopsy to rule out malignancy. Treat GRD is the management. Okay. Now, there is something called as classical Barrett's, where the length of this metaplasia is more than 3 centimeters. Less than 3 centimeters is called as short Barrett's, and there is something called as dysplastic lesions. Okay. Metaplasia, you can manage it conservatively. If there's a dysplasia in Barrett's esophagus, then you have to do something called as EMR, called as endoscopic mucosal resection. Do not forget about it. Okay. Okay, this table is going to be again an eye-opening table for you. Neonatal vomiting has been asked multiple times. Your pediatrics morning Sharad sir would have discussed it in detail about it. I will give you an easy take to remember it. Okay. Any baby with recurrent episodes of vomiting, how would you approach that question? Okay. First, look at the age of presentation. Is it in the 4th week? Is it in the day 0, day 1? Okay. If the baby is present on the 4th week, and if it's a male child, and if it's a non-bilious vomiting, projectile in nature, it is a congenital hypertrophic pyloric stenosis. As simple as that. In CHPS, you have olive lump, visible peristalsis with electrolyte imbalance. What is electrolyte imbalance? Now, rather than trying to remember the electrolyte imbalance of CHPS, I'll tell you the easiest way to understand it. Now, every time the baby is going to vomit, baby will lose gastric content, which is rich in hydrochloric acid. Okay? Now, loss of hydrochloric acid, when you look at it, it is protons, that is HCl is protons with chloride. If I have to put it in this way, every time the baby vomits, the gastric content is rich in hydrochloric acid as well as water. Wherever water goes, sodium follows. As simple as that. Water, I'm least bothered about it, but when you split this, it comes into protons as well as chloride as well as sodium. Okay? Loss of protons will cause metabolic alkylosis. Clear? Loss of chloride will cause hypochloremia. So these two are justified. Sodium is the most cherished element of the body. Body says, I cannot lose sodium. I have to preserve sodium. Okay. In order to preserve sodium, body says, I will activate a renin angiotensin aldosterone system. Now, the basic function of RAS system can be remembered as A, B, C, D, E. A is absorption of sodium and water, and that is what is required because you're losing sodium and water. I want somebody to come and save sodium and water. How do you save it? By activating RAS system. They are going to, aldosterone is responsible for blood pressure maintenance. They work on the collecting duct and the distal convoluted tubule of the nephron, and they cause excretion of potassium, so potassium is lost. So in order to save sodium, you're losing potassium, so hypokalemia. Now, every time you want to save sodium, you will lose one proton from the collecting duct. The loss of proton, normally kya, already you're losing proton, body should save proton, no. But rather than that, in order to save sodium, ki प्यार में इतना अंधा हो गया सोडियम के कि ऑलरेडी ये बर्बाद है प्रोटॉन पे, फिर भी बोलता है कि मुझे सोडियम तो बचाना और प्रोटॉन लूज कर रहा है. Body says you should have conserved it, you're still losing it. So hence the word paradox, which should not happen, is happening. So paradoxical aciduria is going to occur, right? So it is metabolic alkalosis, hypokalemia, hypochloremia, paradoxical aciduria. Late presentation में hyponatremia भी देखने को मिलेगा. ठीक है? That is the most important thing. How do you manage your, what is the investigational choice for CHPS? It is ultrasound. What is the characteristic finding? I will show you in the forward also. The characteristic finding you will see is going to be antral nipple sign and the cervix sign. ठीक है? अगर आप एक्सरे कराओगे single bubble sign देखने को मिलेगा. As simple as that. ठीक है? Now once you have the diagnosis, the first line of management is electrolyte collection. Then you go with surgery. The surgery of choices, Ramsay's pyloromyotomy. As simple as that. ठीक है? अब आती है कि day 0, day 1 वाला जो baby है, if they come to you with vomiting. ठीक है? Now let's try to understand and analyze how it goes. Now, On day 0, day 1, if the baby presents to you with bilious vomiting, non-projectile in nature, on X-ray you see double bubble sign. The condition can be duodenal atresia or annular pancreas. To confirm it, do a CECT abdomen. For both the condition, management is duodenal. Same thing, everything same, but now you have triple bubble sign. That is jejunal atresia. Do a CECT to confirm, do a jejunal. End of discussion. You will never go wrong up here. Okay, when you understand this table, every single component is same. So if I have a baby who is a male child, age of presentation is 4 weeks, non-bilious vomiting, projectile in nature, olive lump, visible peristalsis, electrode imbalance, CHPS. Day 0, day 1, patient is having bilious vomiting. On X-ray, we saw double bubble. The answer could be duodenal atresia or annular pancreas. So differentiate, do a CECT. Either way, do a duodenal. On the other hand, right, if you have a baby, same presentation with triple bubble, it is jejunal atresia. Okay, do a jejunal. End of discussion. Is that clear? Okay, sorted. From now on, never make mistakes in these questions. CHPS का जो electrode imbalance है, that is very, very important. ठीक है? Clear? So far, so good. So far, so good. So, now we talk about peptic ulcer disease. Okay? Now, in the peptic ulcer disease, I'll be discussing about two important components. You have the duodenal ulcer and you have the gastric ulcer. Okay? Now, when you talk about the duodenal ulcers and the gastric ulcers, we have a comparative data. What is the site? In duodenal ulcers, the most common is going to be D1. Okay? Make you laugh, we will send you the PDF. But a PDF will be sent as early as possible. The minute I finish the class, I will send you the PDF. Okay? It will be sent on the Medit Telegram channel. It will be sent on my Telegram channel, The Surgery Guy. It will be sent on my Instagram, that is The Surgery Guy. I will give you soon after the class. ये आपके लिए ही है. It is my, let's say, my blessings, my prayers, my hard work, my dedication, everything put into one PDF for you to crack the exam. And once you do so, do let me know. Okay? Chalo. Chalo. I'm quite there because all of you are there. It is night already, 11 baj rahe, but you still have the same amount of energy and enthusiasm. It is like crazy, amazing. Great going. Let's continue. Okay? Now, duodenal ulcer और gastric ulcers के बीच का फर्क, I'll give you a very, very basic concept. ठीक है? अब ये जो peptic ulcer disease है, the word peptic is a misnomer. ठीक है? It's actually derived from pepsin, but pepsin and peptic ulcer disease has no relation. Initially, it was thought because of pepsin, so तब से नाम लगा हुआ है. Remember, it is usually because of H. pylori, and H. pylori can only grow in gastric type of mucosa. Duodenum does not have gastric type of mucosa. But what happens is when H. pylori goes into antrum, antrum is the most common site where the H. pylori is going to go. Now, once it comes into the antrum, it irritates the antrum, and as it irritates the, how does H. pylori irritate the antrum? Again, a very beautiful story. H. pylori is a urease producing bacteria. It converts urea into ammonia. Ammonia irritates the G cells which produce more amount of gastrin. Gastrin stimulates the parietal cells, they produce more amount of hydrochloric acid. As the hydrochloric acid secretion increases, the concentration of hydrochloric acid from the stomach into the duodenum increases. Now, duodenocytes are not capable of handling such high intensity of acid. Same way, when there's a reflux, no, esophagus is not able to handle it. So how did esophagus come across? Esophagus ने कहा कि भाई मुझसे इतना एसिड झेला नहीं जा रहा, तो मैं स्क्वामस को कॉलमनर बना लेता हूँ, मेटाप्लेसिया कर लेता हूँ. तो उस मेटाप्लेसिया के चक्कर में बैरेट्स हो गया esophagus में. Same thing when the acid starts going more into duodenum, duodenocytes बोलती है कि यार वो esophagus ने कुछ तो किया था जिससे वो बच गया था. उसने मेटाप्लेसिया कर लिया. बोलता duodenum में बोलता मैं भी मेटाप्लेसिया कर लेता हूँ. So what duodenum does is, now the duodenocytes transform into gastric type of mucosa. And once they transform into gastric type of mucosa, the H. pylori can come and now proliferate in that mucosa, resulting in ulceration. तो duodenum में जो ulcer है, वो start gastric component से होता है. ठीक है? But the ulceration occurs more easily on duodenum because it's a more friable mucosa. इतना ही concept है. Is that clear? ठीक है? इससे प्यार से मैं आपको पेप्टिक अल्सर डिजीज नहीं समझा सकता. I want an active feedback on this कि did you all understand कि भाई ये H. pylori predominantly है तो stomach में, but it causes problem in both duodenum and stomach. Is that clear? ठीक है? Now, अगर आपको ये बात समझ में आ गई तो नाउ द कंपैरिजन इज वेरी सिंपल. द यूजुअल साइट ऑफ द duodenal ulcers is going to be D1. The usual site of the gastric ulcer is going to be antrum of the stomach, specifically on the angularis incisura, which is present on the lesser curvature of the stomach. The ulcer's environment, ठीक है, duodenal ulcers are usually formed when the acid secretion in the duodenum is increased. So hyperacidic हो गया, अभी तो समझाया था मैंने आपको. Gastric ulcers are usually formed in same, that is normoacidic, या फिर if there's damage in gastric mucosa, it will cause less acid secretion, so it will be hypoacidic but never hyperacidic. Now, how is the pain? The pain will be present in both duodenal as well as gastric ulcer, but there's a concept here. The food that you start to eat from the mouth, it goes into stomach, there's a rapid transit. Now, as it comes, the food will go and directly hit onto the stomach, and as it goes, so the transit time from the oral cavity to stomach is negligible. It goes directly, lands into stomach, and food is also hard. It erodes the ulcer. It causes a lot of pain. So pain in gastric ulcers is much more higher when compared to duodenal ulcer. Why? Because the stomach में जो food है वो पूरा mash up होके एकदम पतला होके फिर धीरे से duodenum में जाता है. So the erosive capability of the food when it comes to the duodenum is much lesser. So the pain is much lesser. ठीक है. Now you have to understand the pain in duodenal ulcer will come after 2 to 3 hours. Why? Because the gastric emptying time is 2 to 3 hours. And because the food is already mashed up, the intensity of pain is also less. Whereas when in gastric ulcers, rapid transit of food, the patient will experience pain as soon as he eats, right? So hence it is going to be food pain. Okay, now you can say pain in duodenal ulcer is going to be after 2 to 3 hours, whereas pain in gastric ulcer is going to be immediate. Obviously, when there is more pain, you don't want to eat. So the appetite in gastric ulcers decreases. In duodenal ulcers, patient misinterpreted this as, misinterprets what? They misinterpreted this as hunger pain. So appetite increases. Right? Now, obviously, in duodenal ulcer, appetite increase, so weight gain ho jayega, gastric ulcer weight loss ho jayega. Risk of hemorrhage is present in both. But remember, gastric ulcer bleeds, duodenal ulcer perforates. That is the magic point to be remembered. Remember, out of these two, which is pre-malignant? Gastric. Duodenal ulcers are never pre-malignant. Hence, the investigational choice for gastric ulcers is upper GI endoscopy with biopsy. Duodenal ulcers only upper GI endoscopy. Now, with respect to H. pylori, this is your data. Investigation of choice for H. pylori is going to be urease assay test, which is called as a CLO test. CLO is what? Campylobacter-like organism test. It is your Campylobacter-like organism test. Just give me 1 second, guys. It is your Campylobacter-like organism test. ठीक है? पेशेंट को एक साथ दोनों अल्सर हो सकते हैं? एब्सोल्युटली हो सकते हैं. पॉसिबल है, वेरी पॉसिबल. ठीक है. Now, the investigation of choice is going to be your urease assay test, which is also called a CLO. CLO का मतलब होता है Campylobacter-like organism test. But if I say what is the best investigation for H. pylori, for any bacteria, best is going to be culture. How do you know the treatment that you're giving is working or not? Which is called as the assessment for treatment response, and that is done by urease breath test. The most cost effective or सबसे सस्ता जो है, that is going to be a stool antigen test. ठीक है? To remember, this is important. ठीक है? Now, remember, whenever you're trying to do an H. pylori assessment, there are two important points. PPI must be stopped 2 weeks prior, and antibiotics must be stopped 4 weeks prior. Somebody saying, sir, why don't we do biopsy in duodenal ulcer? As you said, it is metaplasia. Beta, dysplastic lesions are prone for malignancies, not metaplastic lesions. Okay? Barrett's is a different story where it is found to have transformation into malignancy. Duodenal ulcer is never transformed into malignancy. ठीक है. पंकज, क्या कंफ्यूज बेटा? आई डिडंट गेट योर क्वेश्चन. कहूं कि ना कहूं? कहो. देखो, मोस्ट ऑफ द पेशेंट्स हु हैव पेप्टिक अल्सर डिजीज, वो ऑलरेडी या तो कहीं ना कहीं से पीपीआई खा रहे होते हैं या फिर कहीं ना कहीं से एंटीबायोटिक ले चुके होते हैं. तो व्हेन दे आर ऑन एक्टिव ट्रीटमेंट, यू कैन नॉट डू अ यूरेज एसे टेस्ट. ठीक है? तो हम बोलते हैं कि भाई पीपीआई 2 हफ्ते बंद कर दो, एंटीबायोटिक 4 हफ्ते बंद करो, फिर आओ, हम आपके एंडोस्कोपी करेंगे, देन यू डू अ सीएलओ टेस्ट. ठीक है? क्लियर? Patient will be confused with food he should eat or not. हाँ ठीक है. For treatment response, what is the investigation? For treatment response, you do breath urease test. You analyze the quantity of the urease in the breath. Treatment के बाद urease level should come down. ठीक है, चलो. So management is triple or quadruple therapy. Triple therapy में क्या है? Once you have diagnosed it, you do a PPI, give 2 antibiotics, clarithromycin with amoxicillin, metronidazole. Quadruple therapy is now the current treatment of choice because triple therapy में we do not have anything which is ulcer protective. ठीक है. So in order to have an ulcer protective, we have added bismuth. एक और ulcer protective drug जो आप बोल सकते हो, that is going to be your sucralfate. ठीक है. So that is in terms of this. If there is failure of management, you go to surgeries that are not important. ठीक है. Clear? Urease breath test is for remission. That is response to treatment only. Remission हो रहा है तो मतलब you want to see whether there is a failure of treatment, and failure of treatment is again done with breath urease test. But those who have not done surgery well until this point, trust me, if you stick with our lecture today and all the topics that I'm revising with you, it is more than enough to go and give your exam in a very decent manner. Okay? You have to be true to it. You have to understand. You have to revise it. You have to memorize it and then go give the exam. This is possible. The entire material that I'm going to give it to you, trust me, if you sit with it, you will be able to revise it in 3 to 4 hours. That is for sure. Okay? Chalo. Now going into gastric carcinoma. Okay? Now, there are various risk factors, but most important risk factor for the gastric carcinoma. One second. The most important risk factor for the gastric carcinoma is going to be H. pylori. Okay? So, how do you get H. pylori? The environmental risk factors, your poor food preparation, lack of refrigerator, poor drinking water. All these are the components that you have. Okay? Medical, these are important. All your prior gastric surgeries, your H. pylori, Epstein-Barr virus infections, your prior radiation history, atrophic gastroenteritis, both type A and type B, adenomatous polyps. In general, it is more common in male as well as low socio-economic status. Okay? Chalo. Everybody will tell you about the various clinical features, but what you have to understand is your extra GI manifestations or atypical presentation of your CA stomach, right? Quickly going through it. In an atypical presentation, you can have an enlarged left supraclavicular group of lymph nodes called as your Virchow lymph node. An enlarged Virchow lymph node is called as Strozier sign. So what is Trossiu sign? What is Trossiu syndrome? What is Strozier sign? Very important. Trossiu sign is carpopedal spasm in your hypocalcemia. Trossiu syndrome is migratory superficial thrombophlebitis, which you see in CA stomach, cancer head of pancreas, as well as Buerger's disease, that is thromboangiitis obliterans. Trozier sign is your enlarged left supraclavicular group of lymph nodes. It is your enlarged left supraclavicular group of lymph nodes. It is your enlarged left supraclavicular group of lymph nodes. Okay? Then you have Irish group of lymph nodes. What is your Irish group of lymph nodes? It is an enlarged left axillary group of lymph nodes. What is systematic group of lymph nodes? It's an enlarged periumbilical group of lymph nodes. What is your Krukenberg's tumor? When the gastric cancer becomes invasive, it crosses the serosal barrier. There is a transcoelomic spread causing drop metastasis. In females, when it drops onto the ovary and it regerminates, and that drop metastasis on the ovary is what we call as Krukenberg's tumor. Blummer's shelf, when there is a drop metastasis into your rectovesical pouch, there you will see pelvic metastasis, and that will present to you as Blummer's shelf on digital rectal examination. All these are going to be important. On the skin, these two findings on the CA stomach are reversible after the surgery. Lesser Trilite sign is nothing but multiple seborrheic keratosis. Tripalm sign is nothing but hyperkeratotic palm. Investigation choice for diagnosis is upper GI endoscopy with biopsy. For T staging, it is endo ultrasound. For locoregional spread, it is going to be CT. PET is for staging. And to look for peritoneal seeding, you do a staging laparoscopy. Gastric cancers management, I've given you in more detail later on, but for now, you remember the margin of resection is 5 centimeters, and post-operative chemo is going to be ECF, that is the epirubicin cisplatin 5-fluorouracil. Don't forget about it. Okay? Sorry. Now, coming back to the upper GI bleed. Now, in the upper GI bleed, the first thing usually they'll ask you is about their clinical presentation and their diagnosis. Mallory V stare, important thing to remember, it is seen in patients of recurrent episodes of vomiting. Causes for recurrent episodes of vomiting is hyperemesis gravidarum. Beta, for distant metastasis, it is PET-CT. Okay? Achha, come back here. Now, when you talk about the Mallory V stare, it is because of repeated episodes of vomiting. It is usually because of hyperemesis gravidarum. It can be cisplatin-induced vomiting. It can be anorexia nervosa, anything. When these patients have repeated episodes of vomiting, there will be longitudinal tear. Okay? The question that they ask you is, what is the most common site? The answer is cardia. What is the orientation? It's a longitudinal tear. What is the depth? It is submucosa. The patient will present to you with blood in vomitus. Do an upper GI endoscopy. If it's a Mallory V stare, it's self-limiting condition. If there's an active bleed, do an electrocoagulation. This is what given. Another thing for upper GI bleed will be because of gastric antral vascular ectasia. On an upper GI endoscopy, this is the image which is called as watermelon stomach. Do an electrocoagulation. As simple as this. Okay? This is all in all that is going to be with respect to upper GI manifestations. Clear? ठीक है, चलो now on the intestine, this is what we were talking about. So two conditions. I'll start with the obstruction first. That is going to be intersusception and volvulus. Intersusception का basic concept क्या है? If one loop of bowel telescopes into another, volvulus, if a loop of intestine rotates around its own axis. In intersusception, it is usually the proximal end of the bowel will go into the distal end. As simple as that. In volvulus, the rotation can be clockwise or anti-clockwise. Most commonly, it is anti-clockwise. The most common type of intersusception in children is ileocolic. In adults, it is colocolic. The most common site for volvulus, it is going to be sigmoid colon, which is going to be anti-clockwise. The most common site for clockwise rotation is ileocecocolic volvulus. Okay? Chalo. Now, these are the findings that you will see. Both of them in comparison. Intersusception, patient will present to you with dynamic obstruction. Right? It is usually associated with lead point. Remember, the most common lead point in age less than 10 months age baby is going to be hypertrophic Peyer's patches. In children, it is Meckel's diabetilum. In adults, it is polyp. In children, which tumor causes lead point, it is small intestinal lymphoma. Okay? Don't forget about it. On the other hand, when you look at the large bowel, that is going to be volvulus, where you have dynamic obstruction features with massive abdominal distension because large bowel is involved. Both of them, initial contrast imaging or imaging can be done. When you do a barium enema in your intersusception, you will see claw sign. Whereas in X-ray for your volvulus, you'll have coffee bean sign. If the coffee bean is pointing towards the right upper abdomen, it is sigmoid volvulus. If it is pointing towards left upper abdomen, it is going to be a cecal volvulus. These are two important differentiating points that you should be able to remember. Okay. Now, another very important point, in age less than 10 months old baby, they will also have red currant jelly stools indicating resolution of intersusception. Investigation of choice for intersusception in children is going to be ultrasound. Ultrasound में क्या-क्या मिलेगा? Target sign, pseudo kidney sign, as well as empty right iliac fossa sign, also called as Dan sign. Okay. On the other hand, when you look at the barium enema, which is going to be for your volvulus, you will see bird of prey sign as if the bird is waiting to catch its prey. As simple as that. Okay. Management, initially for child it is enema followed by surgery. Volvulus, it's a surgical emergency. Do a detorsion, re-rotate it. If the bowel is viable, good. Do a diversion colostomy. If not, if the bowel is non-viable, then you have to do resection and do a Hartmann's procedure. Okay? How to differentiate Boerhaave and Mallory V stare? Beta, kitni baar to ye sawal पूछ रखा है. ठीक है? Now, remember, Boerhaave is a through and through perforation. Mallory V is just a tear. Boerhaave syndrome, you will have macular striate. What is a macular striate? Patient will have retching. Retching का मतलब होता है feeling of vomitus but not able to vomit. Followed by there will be vomiting. As soon as there is vomiting, there will be severe pain. Mallory V will not have pain. Boerhaave will have severe pain, which is retrosternal. Okay? And then because the esophagus is perforated, the air will also rise up going into this neck, that is called as cervical subcutaneous emphysema. There will be no emphysema which will be present in your Mallory V stare. तो Mallory V में pain नहीं होगा, emphysema नहीं होगा. ठीक है? The only thing which is common in both of them is vomitus. यहाँ पे retching के बाद vomitings होगा. Mallory V will never have retching. It will have history of recurrent vomitings. That is what remember. ठीक है? Pankaj, surgery is indicated after the third attempt of enema. क्लियर है? चलो, so this is with respect to intestinal obstruction. ठीक है, both interception as well as volvulus. चलो, let's do it here. We'll take another 15-minute short break. ठीक है, we'll resume back at 11:15. ठीक है, take a short break here. We'll resume back at 11:15. All right, guys, I'm back. Can you all see me? Can you all hear me? Can you all see me? Can you all hear me? Can we start? Can we start? Okay. 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 Yeah, let's go. Let's go. Just give me 1 second. I just need to adjust with the studio guy. 1 second. AC नहीं है और वो डिस्प्ले सेट कर देना थोड़ा. यूट्यूब का स्क्रीन आना चाहिए वो. All right. Just okay. Whenever you guys are ready, let's kick it off. Okay, chalo, let's go. So the next topic that we'll be talking about is your inflammatory bowel disease. IBD, you would have seen in pathology, you would have seen in medicine. Now I'll do a little bit of recap in the surgery. So we'll have two common disorders in IBD. So sabko pata hai. One is going to be your Crohn's disease. Another one, it is going to be your ulcerative colitis. Now the concept that you would remember, the difference between the Crohn's and the ulcerative colitis is Crohn's is a transmural involvement. ठीक है? So if I have to give you a magic portion to remember, ठीक है? Now we take this as a representation of the bowel wall. Okay. So I'll just give you the difference between the Crohn's and the ulcerative colitis. If this is the bowel wall in the Crohn's and this is the bowel wall in the ulcerative colitis. Okay. You look at this, the innermost is going to be mucosa. So this is the mucosal layer that you have. So in both the conditions, you see innermost is going to be mucosa that is present. Under the mucosa, you have submucosa. Here also under the mucosa, you have the submucosa. Then followed by that, you have the circular muscle, longitudinal muscle. This is the muscular wall that you have, right? This is the muscular wall and the outermost is going to be serosa. I'm not interested. Okay? Now you will be like, sir, आप क्यों interested नहीं हो? बेटा interested हम इसलिए नहीं है क्योंकि serosa is basically a fancy word to tell you that it is your visceral peritoneum. ठीक है? So this is the outermost layer that is going to be serosa. ठीक है? The outermost layer that you see here, it is going to be your serosa. The difference between your Crohn's and ulcerative colitis is Crohn's, when the disease is going to start. Okay? In the Crohn's, disease will start from the mucosa, it will go into submucosa, it will involve the muscular wall, it will breach the serosa. Okay? It's a transmural involvement, whereas in ulcerative colitis, it is limited to mucosa and submucosa. If you know this much, your IBD is sorted. Okay, don't worry about it. Are you going to cover full surgery? Absolutely yes, beta. I am going to cover full surgery today. आज रात को चाहे 2 बजे, 3 बजे, 4, कल सुबह 5, कल सुबह 6, I don't give a damn. but we will finish our general surgeries discussion tonight. It is going to happen. We will complete it. ठीक है? Now, let's go. So as I told you, the difference between the Crohn's and the ulcerative colitis is, in the Crohn's, there is a transmural involvement. In the ulcerative colitis, the disease is limited to mucosa and submucosa. What is the objective or the concept behind it? Any disease which is going to involve the entire thickness of the bowel wall. Okay? Obviously, it is going to cause inflammation. Now, when the inflammation is going to occur, it is going to cause involvement of the entire thickness of the wall. And if the entire thickness of the wall gets inflamed, they get fibrous, they get more narrowed down. If they become more narrowed, they'll become stricture. Okay? Now, if there's a through and through involvement, if the bowel which is lying adjacent to it will also get interacted, so it will be enterofistulas. ठीक है, so bowel to bowel fistula बनेगा, आपके when it gets fibrous there will be stricture, and because of that what is going to happen, the outer surface is getting eroded, so you will see the mesenteric fat is also going to creep on top of it. ठीक है, so the whole problem in the Crohn's disease is basically because of this transmural involvement. Ulcerative colitis, on the other hand, it is going to involve mucosa, submucosa. There will be inflammation of mucosa, and inflammation of mucosa will cause edematous of the bowel wall. It will cause distension of the bowel wall. It will cause diarrhea. All that will happen, but will not cause stricture, will not cause obstruction. It will not cause enterofistulas. So all that is saved in your ulcerative colitis. ये basic objective है. ठीक है? Now, on a comparative scale, both of them will be present as a bimodal age of presentation. The first one is between 20 to 30 years. The next one is above 50 years. Females are more commonly affected in Crohn's, whereas ulcerative colitis is more associated with males. When you talk about what are the risk factors for Crohn's, smoking is a risk factor, but smoking is protective for ulcerative colitis. Ulcerative colitis is usually an autoimmune disorder. What is the genes irresponsible? So I'll just, to be clear, this is the section for your Crohn's disease. This is going to be for ulcerative colitis. Okay? Now, Crohn's may, remember two genes, NOD2, CARD15. There are no specific genes which are going to be involved in your ulcerative colitis. The most common site involved in Crohn's is terminal ileum. For your ulcerative colitis, it is rectum. Normally, we say rectal sparing is seen in Crohn's disease, but it can also involve it. Crohn's is a disease which is going to involve from the oral cavity all the way to anal canal. Least involved is rectum. Most involved is terminal ileum. Ulcerative colitis is predominantly seen in large bowel, and the most common site is rectum. Okay? That is the two differential statement that you need to remember. Okay? Now, the radiographs to be importantly remembered in your Crohn's disease. You see the string sign of Cantor because of stricture. This image is very, very important. That is a gross imaging. Cobblestone mucosa, bear claw sign, mesenteric fat creeping, and your stricture. The reasons for all of this I have just given you in the first statement. If you go back and see, मैंने आपको बताया था ये transmural involvement है, इसी की वजह से stricture है, इसी की वजह से mesenteric fat creeping है, इसी की वजह से cobblestone mucosa है, और इसी की वजह से bear claw sign is seen. All these are predominantly because of this. On the other hand, where you have an ulcerative colitis, only the mucosa and submucosa is involved, so it gets flattened out. As it gets flattened out, because repeated inflammation cause fibrosis, no. So it will cause flattening of the mucosa, submucosa. Flattening of submucosa and submucosa will make sure the normal hostrations are present in large bowel, no. That hostration will get eroded. They become flattened. और जो flat हो जाएगा तो एकदम pipe ऐसे खिसा हुआ pipe. That is called lead pipe appearance. ठीक है? So the lead pipe appearance is because of loss of hostrations or colonic hostrations that are seen because of eroded, or I can say repeated inflammation of mucosa and submucosa. ठीक है? Now you'll see pseudo polyps are seen in your ulcerative colitis. Nothing spectacular about it. Extraintestinal manifestation: erythema nodosum, pyoderma gangrenosum, sacroiliitis, arthritis, and primary sclerosing cholangitis and ulcerative colitis. Crohn's, predominantly medical management. Ulcerative colitis, we start with medical management. If it fails surgery, the surgery of choice is total proctal colectomy with ilioanal J pouch anastomosis. ठीक है? But a bear claw sign ना, it looks as if the bear has taken the claw and scraped it. ठीक है? तो ऐसा लग रहा है cobblestone mucosa का ही दूसरा नाम है. इसको अगर आप ऐसे देखोगे तो cobblestone mucosa है, ऐसे देखोगे तो bear claw है. This is also cobblestone mucosa if it is in a one section, but it looks like as if somebody has taken, a bear has taken the claw and completely scraped it. So hence it is called as bear claw sign. ठीक है? Hartmann's procedure नहीं है बेटा. Hartmann's is temporary colostomy. Here ilioanal J pouch anastomosis. आप ileum से J pouch बनाओगे जो reservoir है. ठीक है? Those who are not able to understand what is Ilio-anal J pouch anastomosis, उनके लिए क्विक रिकैप बेटा. Anastomosis very very important. मान लो कि ये आपका esophagus है, this happens to be your stomach, then it continues into duodenum, then goes into jejunum, follows into ileum, ileum goes into terminal ileum. From here you have appendix, you have cecum, from here you have ascending colon, transverse colon, descending colon, sigmoid colon, here you have rectum, and then the anal canal. Now when you say total proctal colectomy with ilio-anal J pouch anastomosis, I am going to resect it from here all the way to the terminal ileum. When you remove this entire part, you are now left out with the esophagus and the stomach and the duodenum and the jejunum, and this is what the ileum is there. And this is where you have your only anal canal. Okay? You are only left out with your anal canal. Okay? You have removed the rectum also, so the line has to be here. So you are removing this rectum also with entire large ball. Okay? So total proctal colectomy. You will remove the appendix also with ilio-anal J pouch. So now if I go and connect the ileum directly to the anal canal, all that succus centricus, which is the collection inside the small bowel, will come to anal canal. There is no reservoir. Patient has to go to washroom every 10 minutes. Patient बोलेगा हर एक घंटे में खाया गया तो difficult. I have to create a reservoir. So what I'm going to do is I'm going to take this part of the ileum. I'll take this part of the ileum and then I will turn this ileum on itself. Okay? I'm going to turn the ileum on itself, right? Like a J pouch. ठीक है? J बना दिया J. अब मैं क्या करूंगा, आई एम गोइंग टू ओपन दीज टू एंड्स. ठीक है, तो मैंने साइड टू साइड ऐसे खोल दिया, ऐसे कट कट कचक मारा. ठीक है, इस वाले पार्ट को मैंने ऊपर से सिल दिया. ठीक है, सिल दिया से ये क्लोज हो गया. ठीक है, अब इन दोनों को मैंने जोड़ दिया तो आई मेड द एनास्टोमोसिस और तो अब ये एक पाउच बन गया. अब मैंने क्या किया, इसको यहां से खोला. ठीक है, नीचे से ओपन कर दिया. नाउ देयर इज एन ओपनिंग हियर, देयर इज एन ओपनिंग हियर. अब मैंने क्या किया, एनल कैनाल और इसको जोड़ दिया. ठीक है, now what is going to happen is because of this anastomosis I have now created a reservoir. So every time the stools are going to come, every time the stool is going to come from here, it is going. When it comes here, it now gets filled up here. It's like a reservoir. Okay, the stool is going to be here as a reservoir, and then once there is an urge, the patient will defecate. Now this acts as a reservoir. This is what we call it as ilio-anal J pouch anastomosis. ठीक है, total proctal colectomy with ilio-anal J pouch. So eventually when the J pouch is formed, this is the closed, this is the J pouch, this is the opening that you have anastomosed, and this is how it is going to look like. ठीक है, so this is your ilio-anal J pouch anastomosis. Sorted है? Did you all understand? Quick feedback. आई बात समझ में? Is that clear? Is that clear? चलो, ठीक है. Another important topic is going to be a hereditary cancer syndrome. In the hereditary cancer syndrome, you have FAP, Gardner syndrome, Turcot syndrome, and Peutz-Jeghers syndrome. FAP mein, when you look at the pattern of hair inheritance, in all four conditions is autosomal dominant. The gene responsible for FAP, Gardner, Turcot is APC gene, whereas Peutz-Jeghers is STK11. Chromosome for FAP, Gardner, Turcot is going to be 5q. Peutz-Jeghers is 19p. The criteria for FAP is there should be a minimum of 100 polyps. The surgery of choice for FAP is going to be same as your ulcerative colitis, total proctal colectomy with ilio-anal J pouch anastomosis. ठीक है? It's an ilio-anal J pouch anastomosis. Gardner syndrome में, to remember the component, you can remember this for-fed. Right? What is for-fed is F is FAP, O is osteoma, R is retinal pigmented epithelium, F is fibroma, E is epidermal cyst, and D is a desmoid tumor. ठीक है? Turcot is FAP with brain tumors. Peutz-Jeghers syndrome, remember PJH, polyps with pigmentation. What type of polyps? Hamartomas polyps. What is the most common site for polyp? It is jejunum. See, where do you see the pigmentation? It is mucocutaneous pigmentation. इतना ही याद रखना है, nothing more than that. ठीक है? Now, because रात के 12 बजने को आए हैं, I know you all are a little bit sleepy, थोड़ा बहुत tired लग रहा होगा, तो एक काम करते हैं, एक छोटा सा rapid fire round खेलते हैं. ठीक है? Rapid fire में क्या है? I'll give you list. ठीक है? तो we have कितना list है? List 1, list 2, list 3, list 4, list 5, and ठीक है, 5 लिस्ट है. I've given you the table. Before I give you the answer, I want the chat box to buzz. I want you to give me answer every single thing. मैंने disorder लिखा हुआ है, most common site या most common type बताना है, इतना ही game है, ठीक है? Nothing more than that. We'll play to our honest level, ठीक है? Whenever you guys are ready, we're going to kick it off, ठीक है? Are you guys ready? Are you guys ready? Can we start? I want a yes. I want a yes. Come on, guys. करें शुरू? Can we start? Can we start? Let's play the game. ठीक है? Here we go. So the first disorder is tracheoesophageal fistula. What is the most common type? I've already said before also, it is a type C variety. Achalasia cardia का most common site कहाँ पे है? It is going to be lower 1/3 of the esophagus. Zenkus diverticulum का most common site कौन सा है? It is left sided posterolateral. It is left sided posterolateral in cervical esophagus. I'm just going to cervical E, that is a cervical esophagus. Most common site for esophageal cancer, come on, esophageal cancer का most common site क्या है? Middle 1/3. It is going to be middle 1/3. Barrett's esophagus, it is going to be lower 1/3. Weber, that is Plummer-Vinson syndrome में web कहाँ पे बनता है? Plummer-Vinson syndrome में it is upper esophageal web. It is a upper esophageal web. Boerhaave syndrome में what is the most common site of perforation of Boerhaave syndrome? It is lower 1/3. ठीक है? Usually 2 to 10 centimeters above gastroesophageal junction. Mallory Weiss-Stare का most common site, it is the cardia of the stomach. Peptic ulcer disease का most common site, the first part of the duodenum. Gastric ulcer का most common site, it is the antrum. Intersusception अगर children में पूछेगा, it is going to be ileocolic. अगर यही बात उसने अडल्ट में पूछ ली तो अडल्ट में क्या होता है बेटा? इट इज कोलोकोलिक. वॉल्वुलस का मोस्ट कॉमन साइट कौन सा है? सिग्मोइड कोलोन. इट इज सिग्मोइड कोलोन. डायवर्टिकुलोसिस का मोस्ट कॉमन साइट कौन सा है? सिग्मोइड कोलोन. पॉलिप्स का मोस्ट कॉमन साइट कौन सा है? रेक्टम. टीबी का स्ट्रक्चर, टीबी स्ट्रक्चर का मोस्ट कॉमन साइट कौन सा है? टर्मिनल आइलियम. टाइफॉइड परफोरेशन का मोस्ट कॉमन साइट कौन सा है? टर्मिनल आइलियम. अल्सरेटिव कोलाइटिस का मोस्ट कॉमन साइट कौन सा है? रेक्टम. क्रोन्स डिजीज का मोस्ट कॉमन साइट कौन सा है? टर्मिनल आइलियम. हर्शबर्ग डिजीज का मोस्ट कॉमन साइट कौन सा है? रेक्टम. इस्कीमिक कोलाइटिस का मोस्ट कॉमन साइट कौन सा है? इट इज स्प्लेनिक फ्लेक्सर. इट इज योर स्प्लेनिक फ्लेक्सर. एसएमएस सिंड्रोम में मोस्ट कॉमन साइट कौन सा कंप्रेस्ड होता है? दैट इज गोइंग टू बी द थर्ड पार्ट ऑफ द डियोडेनम. रिमेंबर, whenever the takeoff angle is less than 20 degrees, ये आपका सुपीरियर मेसेंट्रिक आर्टरी सिंड्रोम क्रिएट करता है. ठीक है? आई थिंक इस वाले राउंड में मैं जीता, आप हारे. ठीक है? Shall we continue? Very good. SMA syndrome is also called as Wilkie syndrome, also called as spinal cast syndrome, also called as Sika syndrome. Absolutely spot on. ठीक है? Absolutely spot on. Great. कंटिन्यू करते हैं इसमें. Acute mesenteric ischemia. It is because of the most common cause for acute mesenteric ischemia is emboli. अब मुझे बताओ, what is the most common site for this embolic occlusion? The most common site is going to be your middle colic artery. It's a middle colic artery. Large bowel malignancy का most common site क्या है? The overall most common site is going to be rectosigmoid. लेकिन अगर ये ऑप्शन में नहीं है, then it is going to be rectum. अगर rectum ऑप्शन में नहीं है, next it is going to be sigmoid colon. More than 50% of your large bowel cancers are concentrated in rectosigmoid region. Perforation in peptic ulcer disease is going to be first part of the duodenum. Hemorrhage in peptic ulcer disease, it is usually seen in gastric ulcer. Now, perforation is more common on anterior ulcers, whereas bleeding is more common on the posterior ulcers. The most common source of bleeding in the peptic ulcer disease is going to be your gastroduodenal artery. It's a gastroduodenal artery. Fistula nano का most common type जो है, it is going to be your intersphincteric variety. It is the intersphincteric type when you talk about in terms of your Parks classification. Hemorrhoids का most common कौन सा है? It is your internal hemorrhoids. It is your internal hemorrhoids. When you look at in terms of position of the clock, this is more common on 3, 7 and 11 o'clock position, which are called as primary hemorrhoids. Anal cancer का most common site, it is below dentate line. The most common site for anal cancer, it is going to be below the dentate line. It is going to be below the dentate line, right? That concludes your table number 1. ठीक है, तो पहला टेबल मैं जीता, आप हारे. ठीक है, let's see if you can beat me to the second table. This time, let's see if you can give answer faster than I can actually. ठीक है, बेटा फास्टेस्ट फिंगर फर्स्ट है. ठीक है, और जैसे ही आप अगर आप मुझसे लाइक लेट्स से इफ यू आर एबल टू बीट मी एंड यू विन, देन यू विल बी लाइक 5 करोड़ तो नहीं, 5 पॉइंट्स जरूर मिल जाएंगे. ठीक है, चलो. लिस्ट नंबर 2 इज द नेम्ड अल्सर, और उसका साइट बता देना, कुछ नहीं है. आई हैव गिवन यू वेरियस नेम्ड अल्सर्स इन द जीआईटी. वेयर आर द साइट्स दैट यू हैव? ठीक है, सो एप्थस अल्सर का द मोस्ट कॉमन साइट, एप्थस अल्सर इज सेकेंडरी टू क्रोन्स डिजीज. क्रोन्स डिजीज का मोस्ट कॉमन साइट कौन सा हो जाएगा? टर्मिनल आइलियम. कैमरून्स अल्सर, it is seen secondary to rolling hiatal hernia. It is seen in rolling hiatal hernia. The most common site of Cameron's ulcer in rolling hiatal hernia is the fundus of the stomach. It is the fundus of the stomach. Peptic ulcer disease का most common site first part of the duodenum. Gastric ulcers का most common site is antrum. Duodenal ulcers का most common site is first part of the duodenum. TB ulcer का most common site is going to be terminal ileum. Typhoid ulcer का भी most common site is going to be terminal ileum. Belt shaped ulcers are seen in TB, so TB का most common site is going to be terminal ileum. Flash shaped ulcer is seen in Entamoeba histolytica. It is seen in Entamoeba histolytica. The amoebic colitis का most common site is going to be cecum. Serpentine ulcer is seen in necrotizing enterocolitis. It is usually seen in small intestine. Cobblestone mucosa is seen in Crohn's disease. The most common site for Crohn's disease is going to be terminal ileum. Solitary rectal ulcer is seen in rectal prolapse. It is seen in rectal prolapse, usually seen in the ampulla of rectum. Usually seen in the ampulla of rectum. Skip ulcers are seen in Crohn's disease, and the most common site for Crohn's disease is going to be terminal ileum. ठीक है, so this is your list number 2, 10 करोड़ का और 10 पॉइंट्स का. ठीक है, clear? Can we move on to the second list? Third list actually. ठीक है, okay, list number 3. Now you have to tell me, I'll tell you the GI malignancy, you have to tell me its chemo regime. ठीक है, and get set go. For esophageal cancer, it is your ECF. What is ECF? It is epirubicin cisplatin. Epirubicin cisplatin and 5-fluorouracil. For small intestinal adenocarcinoma, it is ECF, that is epirubicin cisplatin 5-fluorouracil. Small intestinal adenocarcinoma, it is FOLFOX. What is FOLFOX? FOL stands for folinic acid. It is a folinic acid. Another F stands for 5-fluorouracil. OX stands for oxaliplatin. Large intestinal adenocarcinoma, you can go ahead with FOLFOX. Another one is FOLFOVIRI. So here it is same folinic acid with 5-fluorouracil with irinotecan. It's a irinotecan. For rectal cancer, it is same. For rectal cancer, it is going to be same. इसी का extension is a misprint, so we'll go here. For anal cancer, it is squamous cell cancer of the anal canal. For squamous cell cancer of the anal canal, we'll give something called as Negro's regimen. Negro's regimen is going to be 5-fluorouracil with metamycin C with radiotherapy, that is a chemoradiation. For GIST, it is going to be imatinib. If there is resistance to imatinib, then I will go ahead with sunitinib. For imatinib resistant GIST, it is going to be sunitinib. For HCC, it is sorafenib. For gallbladder adenocarcinoma, it is going to be cisplatin with gemcitabine. It is cisplatin with gemcitabine. Cholangiocarcinoma is same. Pancreatic ductal adenocarcinoma, it is basically gemcitabine based chemotherapy. Okay? So this is going to be your chemo drugs. Okay? This is going to be your chemo drugs. Sorted? Chalo. Now going into list number 4. Now list number 4 is about the margin of resection in your GI malignancies. Okay? So we have the proximal and distal margin. We'll quickly go ahead. Again, 1, 2, 3 and go. So esophageal cancer, the proximal margin is going to be 10 centimeter, distal is going to be 5 centimeter. For stomach, proximal 5, distal 5. So small intestinal adenocarcinoma, proximal 5, distal 5. For large intestinal adenocarcinoma, proximal 5, distal 5. For rectal cancer, proximal 5 and distal 2 centimeters. So there are only two things which are going to be different. Number one, it is going to be your proximal esophageal and distal rectal. Rest everything is 5 centimeters. The only thing that you have to remember is this. Rectum में distal 2 centimeter margin है, esophagus में proximal 10 centimeter margin है. That is it. Nothing less, nothing more. If you are good with this, you're good with this. Absolutely spot on. ठीक है? चलो. List number 5. Let's see if you're able to beat me on this. ठीक है? तो list number 5 का बड़ा simple सा game है. We have the disorders. We'll talk about only the surgical management. ठीक है? So here I am only talking about the surgeries, nothing more. ठीक है? Okay, something we have. Ruskin Bond says, sir, a lady in CECT abdomen, some insinuating mass 5 centimeter posterior to IVC pushing the right adrenal gland. It says lymphatic malformation. Please tell what's the diagnosis. Beta, I need a little bit of more info. ठीक है? Okay, let's go. Ecclesia cardia के लिए, what is the surgery of choice? Okay, good. We have the Heller's cardiomyotomy. It is the Heller's cardiomyotomy. Okay. The latest one that you have is what we call it as POEM. Somebody is saying it correct. It is per oral endoscopic myotomy. But remember, if they still ask you what is the surgery of choice, the surgery of choice is still Heller's cardiomyotomy. Okay. For diffuse esophageal spasm, it is your long esophageal myotomy. It is your long esophageal myotomy. Achha, for ecclesia cardia and diffuse esophageal spasm, for ecclesia cardia and the diffuse esophageal spasm, if I have to be very specific, we will measure something, no, just for the sake of understanding. Okay? So if I say how much should be the IRP for ecclesia cardia and how much should be your DCI for your diffuse esophageal spasm. For your diffuse esophageal spasm, let's have a quick recap on this. IRP of ecclesia cardia should be more than or equal to 15 millimeters of mercury. It has to be 15 millimeters of mercury. How much should be your distal contractile integral? Quick feedback. How much should be your DCI for your diffuse esophageal spasm? Waiting for a feedback, guys. How much should be your DCI? How much should be your DCI for a diffuse esophageal spasm? कितना होना चाहिए distal contractile integral? How much should be your DCI? Very good. DCI of more than 450 millimeters of mercury. More than 8,000 is what we call it as, क्या हो जाएगा? Nutcracker esophagus. ठीक है? Nutcracker esophagus. ठीक है? More than 8,000 nutcracker esophagus. Zenker's diverticulum के लिए, if it is more than 3 centimeters, what is the surgery of choice? That is going to be endoscopic Dolman surgery. It is an endoscopic Dolman surgery. For esophageal cancer, what is the surgery of choice? The surgery of choice is going to be your Oringer's transhiatal esophagectomy. Oringer's transhiatal esophagectomy. It is Oringer's transhiatal esophagectomy. For congenital hypertrophic pyloric stenosis, it is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. For perforation and peptic ulcer disease, it is your Graham's omental patching. It is your Graham's omental patching. For peptic ulcer disease. For peptic ulcer disease, if you talk about, there is no surgical management as such. So here either you can go with triple or quadruple therapy. So quadruple therapy is preferred over triple therapy. For GRD, if you talk about surgery, the surgery of choice for GRD is going to be your Nissen's fundoplication. It is your Nissen's fundoplication. Now, when I talk about Nissen's fundoplication, this Nissen's fundoplication, it is your anterior or posterior. Remember, Nissen's fundoplication is going to be your posterior complete fundoplication. It is your posterior complete fundoplication. But I've been telling you, I am going to share this PDF soon after the class. It will be available to you on the Telegram group. It will be there on my Telegram group. It will be there on the PW's Telegram group. My Telegram group is The Surgery Guy. It is by Dr. Sandeep Reddy. Nissen's fundoplication is a 360 degrees. That is a complete fundoplication. For a D1 stricture, you have two surgeries. The preferred one is your Heineken muclids. It is the Heineken muclids. It is Heineken muclids pyloroplasty. Another one is Jabulois pyloroplasty. For duodenal atresia, it is duodenostomy. For jejunal atresia, it is jejunostomy. It is jejunostomy. For ulcerative colitis, total proctal colectomy with ileoanal J pouch. For diverticulosis, it is elective sigmoid resection. It is your elective sigmoid resection. For FAP, it is same. Total proctal colectomy with ileoanal J pouch anastomosis. For rectal prolapse, you have Thierch wiring. Then you have Rebstein surgery. Then you have Altamier's surgery. Then you have Freichmann-Goldberg. You have Freichmann-Goldberg surgery. For Hirschsprung disease, you have pull-through surgeries. You have the pull-through surgeries. What are the pull-through surgeries? You have Duhamel, you have Swenson, and you have Sowas. Hemorrhoids, you have stapler hemorrhoidopexy, but before stapler hemorrhoidopexy, what are the other components that you have, right? You have Milligan-Morgan. We have Milligan-Morgan. We have Ferguson. And you have circular stapler. You have the circular stapler. Okay? So, for adenocarcinoma of the anal canal, you do an APR, that is your abdominoperineal resection. It is the abdominoperineal resection. Okay? APR is your abdominoperineal resection. Clear? APR is your abdominoperineal resection. Right? So, this concludes your list number 5. Okay? Clear? Tired? थक गया क्या? As I told you, thakna is not an option. Clear? Okay, let's go. Ruskin, if you want to discuss a case, I have a group that is called as the Surgery Guy on the Telegram group. Kindly put up there. This is currently for your NEET PG prep. So let's not deviate from that course. Chalo. So finish the GIT. Now going into HPB. ठीक है, hollow viscous and perforation peritonitis. Beta, hollow viscous perforation will lead to perforation peritonitis. No, simple, clear, sorted. Chalo. So we'll talk about liver resection terminology, again very important. Now, in order to understand liver resection, I'll quickly give you the Brisbane's terminology. How do you understand that? Now, according to the Brisbane's terminology, the liver is considered to be like a cheesecake. Okay? So this is how the liver is going to be depicted. If I give you a three-dimensional image, if I give you a three-dimensional image, this is how a three-dimensional image of the liver would actually look like. Okay? Now, what is interesting about this? What is interesting about this is when you look at the liver, dead in the center, you have a groove, right? That groove which is dead in the center is what we call it as Cantel's line, right? We all know that the liver is divided into four sections. Now that is divided on the basis of hepatic vein. You have the hepatic vein which is present. There is a left hepatic vein, there is a middle hepatic vein, there is a right hepatic vein. Okay? So the right hepatic vein is here, the middle hepatic vein is going here, and this is your left hepatic vein. And then you have the portal vein which is running all across the liver in this particular fashion. So this is the orientation of your portal vein. So portal vein is going in a transverse manner. So based on this, it has divided liver into various sections. Okay? So you can see this is first section, this is second section, and when you do like this is your third section. I can just say this is your third section and this is your fourth section, right? So there are four sections in the liver that is being divided across. Okay? Then there are segments. What are these segments? This is a segment 2, this is a segment 3, this is a segment 4A, this is a segment 4B. Anterior is 5, posterior is 6, posterior above is 7, anterior is 8. This is how the liver is divided into various segments. Okay? Now each individual, if I just name it, I hope everybody knows it, but just for the sake of understanding, on the left side I can say the segment 1 that you can see here. This is what we call it as left lateral section. The second one is left medial section. Third one which is present here is your right anterior section, and the fourth one which is here is your right posterior section. It is your right posterior section. ठीक है, क्लियर? इससे इजी रिप्रेजेंटेशन मैं आपको नहीं दे सकता हूं. तो लेफ्ट का लैटरल, लेफ्ट का मीडियल, राइट का एंटीरियर, राइट का पोस्टीरियर, इतना ही है. ठीक है, नथिंग मोर देन दैट. Now, if you have understood this, now you will tell me the terminology. If I do a right hepatectomy or right hemi liver or right hepatectomy, right side of the segments has to be removed. So, what are the segments that belong to right side? It is 5, 6, 7 and 8. Correct? ठीक है? It is a 5, 6, 7, 8. Left में क्या आएगा? 2, 3, 4A, 4B. So, left hemi hepatectomy is 2, 3, 4A and 4B. Right anterior section. Right anterior section कौन सा है? You can see here. Right anterior section is 3. 3 is what? 5 and 8. So it is going to be 5 and 8. Right posterior में कौन सा है? 6 and 7. It is going to be 6 and 7. Left lateral में क्या है? 2, 3. So 2 and 3 is going to be left lateral. Left medial क्या है? 4A and 4B. So segment 4A and 4B is removed. Right trisectionectomy. From the right side you remove 3 sections. ठीक है? What are the 3 sections that you can remove from the right side? 1, 2 and the third section is here. One sec, I'm removing third, fourth and then the next I have to remove 2. ठीक है, तो 3 sections right side से निकालोगे तो right side जब 3 sections निकालोगे कौन कौन से sections आएंगे? I'll remove 5, 6, 7, 8 and then I will add 4A and 4B. ठीक है, लेफ्ट से 3 सेक्शन निकालने. लेफ्ट में कौन सा? एक सेक्शन निकाल दिया, 2. तीसरा कौन सा का? इट इज गोइंग टू बी एंटीरियर ओनली. तो ये पूरा कंटिन्यूस एंटीरियर के साथ ही है. तो इट इज गोइंग टू बी योर 2, 3, 4A, 4B and 5 and 8. ठीक है, and 5 and 8. ठीक है, this is how you're going to remember your liver segments. Is that clear? Is that clear? ठीक है? Sorted है? चलो. Next, going into the infectious disorder of the liver. I know you would have seen and heard this in medicine also. You would have seen this in patho, a bit of micro also. So I'll just try to overview the entire component. Okay? Now the overview is something like this. I'll be comparing pyogenic liver abscess, amoebic liver abscess, as well as hydrated cyst. The causative agent for pyogenic liver abscess is going to be a bacteria, the other two are parasites. The most common bacteria for pyogenic liver abscess is E. coli, Klebsiella. For amoebic liver abscess, name में ही है Entamoeba histolytica. For hydrated cyst, Echinococcus granulosus. ठीक है. Now, what is the route of spread? For pyogenic liver abscess, it is usually via bile duct. Amoebic liver abscess as well as your hydrated cyst is via the portal circulation. ठीक है. The age of presentation for pyogenic liver abscess is above 50. Why? Because the risk factor here is diabetes and smoking. Here it is only going to be smoking in the context of amoebic liver abscess. So age above 50, amoebic liver abscess 20 to 30 years, hydrated cyst is going to 40-50. Remember, Entamoeba histolytica enters the body via feco-oral route of contamination, goes into cecum, cause a flash-shaped ulcer. From there, it produces tetranucleate cyst. That tetranucleate cyst is going to go into the portal circulation, then get into the liver and cause amoebic liver abscess. तो liver के लिए portal vein है, लेकिन body में कैसा है? That is feco-oral route of contamination. Everybody knows it. Hydrated cyst का भी same story है. Remember, pyogenic liver abscess is more common in males, amoebic is more common in females, hydrated cyst दोनों मिल बैठ के खाते हैं, इसलिए मेल फीमेल दोनों को इक्वली होता है. जितने भी आपके infected disorders है, all the infected disorders of liver are more common on the right side. Is the right hemi liver is the overall most common side. Remember, bacteria होगा तो multiple होगा, parasites are usually solitary lesions, so again that is there. Bacteria can never be endemic, parasites are endemic, the other two are there. Remember, pyogenic liver abscess, amoebic liver abscess will present to you with features of hepatitis. Specific क्या होगा? Pyogenic liver abscess में आपको jaundice मिलेगा. Amoebic liver abscess में history of colitis. I told you amoeba has to come into the body via feco-oral route of contamination. From there, it is going to cause amoebic colitis. तो colitis तो होगा. Hydrated cyst is usually asymptomatic. If at all it is symptomatic, it presents enlarged liver. That's it. Nothing more than that. Now, in first investigation for all of them is ultrasound. Remember, hydrated cyst में classification इसको बोलते हैं Garbi classification. Type 1 in Garbi is simple cyst. Type 2 is going to be free floating membrane, which is going to present as water lily sign or a water snake. Type 3 is multiseptate, which is called as honeycomb. Type 4 is complex heterogeneous calcification in center, periphery में septic. Type 5 is calcified hydrated cyst. ठीक है, ये आपका Garbi classification हो गया. In order to confirm, see, investigational choice for all of them is going to be CECT, but confirm करने के लिए यहाँ पे culture करोगे bacteria में, parasites cannot be cultured, so hence we will go with ELISA. ठीक है. Now, what is the management for pyogenic liver abscess? USG guided aspiration with antibiotics, as simple as that. When you talk about Entamoeba histolytica, it is high dose metronidazole. For hydrated cyst is PER. PER is percutaneous aspiration and instillation of scolicidal agent and reaspiration. The scolicidal agents that you can use is going to be 10% povidone, hypertonic saline, that is hypertonic saline can be, that's 3% normal saline, 0.5% centrimide, 0.05% chlorhexidine. All these are considered to be your scolicidal agents. ठीक है, चलो. Again, your repeat exam question, the difference and the comparison between a primary HCC and a fibrolamellar variant of HCC. ठीक है, primary HCC, males are more commonly affected, 8:1 ratio, whereas in fibrolamellar variant, males and females are equally affected. Age of presentation for HCC is 55, this is 25. Tumor nature, this is going to be poorly differentiated, invasive. Fibrolamellar is well differentiated, well circumscribed. See, HCC is associated with your liver cirrhosis as well as it is associated with hepatitis B. It is not associated. ठीक है. AFP, there is alpha fetoprotein, which is a tumor marker elevated in HCC. Fibrolamellar variant का tumor marker आपका AFP नहीं है, वो normal मिलेगा. आपको क्या elevated मिलेगा? You will see B12 binding protein and neurotensin will be elevated here. ठीक है, क्लियर. नाउ प्रोग्नोसिस इसका पुअर मिलेगा, इसका आपको गुड मिलेगा, एज सिंपल एज दैट. ठीक है, सो दिस इज द कंपैरिजन बिटवीन अ प्राइमरी एचसीसी एंड द फाइब्रोलैमेलर वेरिएंट ऑफ एचसीसी. ठीक है. नाउ बिलरी सिस्टम विल स्टार्ट. आई हैव थोड़ा सा मिसप्रिंट हो गया, तो बिलरी सिस्टम आपको इसके पीछे मिलेगा. तो विल जस्ट क्विकली गो थ्रू द पैनक्रियाटिक कंपोनेंट फर्स्ट एंड देन वी विल रिविजिट दैट. In the pancreas, now this table is very important. It's a cystic lesion of pancreas. ठीक है. There are 4 common cystic lesion of pancreas that you will come across. ठीक है. What are the 4 common cystic lesion of pancreas that you will come across? pseudocyst of the pancreas, serous adenoma of the pancreas, mucinous adenoma of the pancreas, and IPMN, intraductal papillary mucinous neoplasm. ठीक है? So these are the various components that you have. एक second. ठीक है? Now, if they ask you what is the most common cystic lesion of the pancreas, the answer is pseudocyst of the pancreas. The most common cystic neoplasm of the pancreas, that is a mucinous adenoma. Do not goof up in that. Mucinous adenoma is a neoplastic lesion. Pseudocyst is not a neoplasia. It is just a fibrous wall. Okay? So most common cystic lesion of pancreas is pseudocyst. The most common cystic neoplasm of pancreas, it is going to be mucinous adenoma. Okay? We are clear on that. Now, the usual age of presentation for pseudocyst, all of them are seen relatively higher age because pseudocyst is also seen after chronic pancreatitis. So age is 40 to 60. Serous is going to be 60 to 70 years. Mucinous is going to be 50 to 60. IPMN, that is intraductal papillary mucinous neoplasm, is also 60 to 70. Okay? Pseudocyst is more common in males. Serous is females. Mucinous is again females. IPMN is equally seen in males and females. Okay? Now, what are the characteristic features? Pseudocyst of the pancreas is usually large, measures more than 6 centimeters in diameter, more than 6 millimeter in thickness, and it is filled with pancreatic secretion. So amylase level is going to be high in those. Okay? Serous adenoma, on the other hand, are multiple smaller cysts coalesced together like a honeycomb appearance. Central stellate scar or calcification will be there with internal septation. Mucinous adenoma is thick-walled macrocyst with peripheral axial calcification. IPMN of 3 varieties. If they arise from the main duct, they arise from the branch duct. Combination is mixed. Overall, most common is going to be mixed variety. All this mucin that secretes into the ampulla, it causes widening of the ampullary mouth, and this widening of the ampullary mouth is what we call it as fish mouth ampulla. Characteristic feature of your IPMN. Okay? Ductal communication is seen in pseudocyst and IPMN, not seen here. When you talk about what is the most common site, for pseudocyst it is lesser sac. For your serous adenoma, it is going to be equally distributed throughout the pancreas. Your mucinous adenoma is more common in body and tail, and the IPMN is more common in your head of the pancreas. It is going to be head of the pancreas. Now, mucin stains are present where they secrete mucin. Who are secreting mucin? Your mucinous adenoma as well as IPMN. On the other hand, when you talk about CEA level, CEA is elevated in pre-malignant condition. Your mucinous adenoma and IPMN is your pre-malignant condition, hence CEA is going to be elevated. Amylase is going to be elevated in pseudocyst. IPMN remains normal in these two. Remember, the investigation for all of them is going to be CECT of the abdomen, except for IPMN where you have ERCP. In ERCP, you will see fish mouth ampulla. That's the characteristic presentation. Management for pseudocyst, usually wait for 6 weeks. If it does not resolve in 6 weeks, do a cystogastrostomy, cystogenostomy. For your serous adenoma, you can do enucleation. For your mucinous adenoma, it is distal pancreatectomy. IPMN is near total pancreatectomy. Okay? Will this be posted later till NEET PG, sir? Beta, this will stay in YouTube forever. Don't worry. ठीक है? ऐसे थोड़ा जाने देंगे. Beta, it is not my dedication. It is your interest that is driving me to deliver at midnight. ठीक है? रात के 12 बजे लोग पता नहीं क्या करते, हम तो पढ़ाई कर रहे हैं. ठीक है? तो there is a very famous saying, no? That will like, there are different ways people will interpret it, but एक चीज बहुत common है. ठीक है? What you do in your private, or how much you put effort in your private time, or how much dedication and focus that you have in your private time gets rewarded in public. ठीक है? जो मेहनत आप अकेले में करते हो, उसका जो रेसिप्रोकेशन है, वो आपको पब्लिक में मिलता है. ठीक है? So, all this, see, let the world sleep and you work, and when they get up, they celebrate your success. ठीक है? दुनिया सो रही है और आप काम कर रहे हो, तो जब वो उठेगी ना, तो वो आपको सेलिब्रेट करेगी. And that's what it is all about. Let's work in silence. Let's work and let's work hard. ठीक है? So this is in the context of IPMN. ठीक है? Now these are the triads. इसमें से एक सवाल हमेशा फंसता है. ठीक है? This slide, I hope and I wish कि पूरा स्लाइड ही एग्जाम में आ जाए, लेकिन एक तो आपको गारंटीड आएगा. ठीक है? All the important triads. The first one is a Carney's triad, which is for a multifocal gist. Carney's triad बोलता है multifocal gist एक्स्ट्रा एड्रिनल पैरागैंग्लियोनोमा विथ रिस्पेक्ट टू पल्मनरी कॉन्ट्रोमा, ठीक है। सो मल्टीफोकल जिस्ट है, एक्स्ट्रा एड्रिनल पैरागैंग्लियोनोमा है, पल्मनरी कॉन्ट्रोमा। देन योर मैकुलर स्ट्राट, मैकुलर स्ट्राट इज इन बोरहाफ सिंड्रोम, ऑलरेडी हमने डिस्कस किया हुआ है। रेचिंग फॉलोड बाय वॉमिटिंग, सडन सिवियर ऑनसेट ऑफ रेट्रोस्टर्नल चेस्ट पेन एज वेल एज सर्वाइकल सबक्यूटेनियस एम्फाइसीमा। बोचार्ड स्ट्राट व्हिच इज गोइंग टू बी इन गैस्ट्रिक वॉल्वुलस, रेचिंग है बट नो वॉमिटिंग, whereas in बोरहाफ रेचिंग फॉलोड बाय वॉमिटिंग। गैस्ट्रिक वॉल्वुलस में you have retching but no vomiting, ठीक है। Along with that there will be presence of retrosternal pain, we say abdominal pain which is colicky in nature, colicky abdominal pain, ठीक है। Retching is present, inability to pass nasogastric tube, that is what we call as Bouchard stride. Murphy stride is seen in appendicitis, that is going to be pain, fever as well as vomiting. चारकोट्स में intermittent pain, fever, jaundice मिलेगा। इसमें अगर आप altered sensory sepsis को लोग उसको चारकोट्स पेंटार्ड बोलते हैं, ठीक है, सॉरी रेनॉल्ड्स पेंटार्ड बोलते हैं। क्विंकी स्ट्राइड और आल्सो कॉल्ड एज द सैंडबुलम स्ट्राइड व्हिच इज सीन इन योर hemobilia. Hemobilia is going to be blood in bile. So when the blood comes in bile, it occludes the duct and pain, jaundice as well as melena. Tilloch stride is a previous exam question which is seen in a mesenteric cyst. What is Tilloch stride? There will be mid-abdominal cystic swelling that is going to be only mobile perpendicular to the attachment of the mesentery. Mesentery attached from the left of your second lumbar vertebra to the right iliac fossa. It moves in the perpendicular direction, not along the line of the mesentery, and there is a band of resonance and the cystic swelling is red in the center. Okay? So this is what it concludes in the context of Tilloch stride. So if you know Tilloch stride, you know your components. Okay? Clear? But a regular stride जो है, that is going to be present in your, where do you see regular stride? It is seen in gallstone ileus, ठीक है। आगे है regular stride, ऐसा हो ही नहीं सकता कि हम आपको छोड़ दें, ठीक है। So that is going to be in the context, ठीक है। Let's go. Clear है? All the triads are sorted. Can you move on? Okay. So I'm just going to do a little bit of toe flexing. Regular stride में क्या क्या मिलेगा? Small intestinal obstruction, that is dynamic bowel obstruction is there, associated with pneumobilia and ectopic gallstones. And ectopic gallstones, ठीक है? चलो. Okay. Now, let's do, जैसे हमने सारी GI लिस्ट की थी, list 1, list 2, list 3, list 4, we played a game. Now we'll do with the same, ठीक है? Images पे खेलते हैं. This is an ultrasound image of a 4 weeks old child. What do you see? You see an antral nipple sign, you see a cervix sign. ठीक है, इसका क्राइटेरिया क्या है? This is a diagnosis of CHPS. Criteria: length should be more than or equal to 16 millimeters, width should be more than or equal to 4 millimeters. अगर CHPS वाले बेबी में अगर आप contrast imaging करोगे, double track sign and mushroom sign मिलेगा. That is another component that you have. This is going to be repeatedly asked. You see right gas, free gas under right hemidiaphragm, hollow viscous perforation. That can be because of peptic ulcer disease, typhoid ulcer. It can also be secondary to what? Secondary to what? Secondary to, bolo bolo. It can also be secondary to appendicular perforation. Now, if there's a massive air which is delayed presentation, same hollow viscous perforation mein, you see dome sign, the entire abdomen is filled with air, also called as your football sign. Regular sign is also seen. What is your regular sign? Regular sign is visualization of bowel wall. देखो air नजर आता है, air अंदर है bowel के, लेकिन air बाहर भी present होगा, अंदर बाहर दोनों जगह हवा हवा हवा. When you see air on both sides of the bowel wall, you see air on the bowel, both sides of the bowel wall gets visualized. Visualization of bowel wall on an X-ray is indicative of hollow viscous perforation. एक और साइन मिलता है आपके रेडियोलॉजिस्ट बताएंगे, क्यूपोला साइन. क्यूपोला साइन में क्या है? डायाफ्राम जो ऐसे था वो एकदम सीधा हो जाता है. डायाफ्राम जो ऐसा था एकदम सीधा. दिस इज कॉल्ड एज फ्लैटनिंग ऑफ डायाफ्राम, कॉन्टिन्यूअस डायाफ्राम. इट इज कॉल्ड एज क्यूपोला साइन. ठीक है, कॉन्टिन्यूअस डायाफ्राम साइन इज सीन इन, कॉन्टिन्यूअस डायाफ्राम साइन कहां मिलेगा? नीमोमीडियास्टिनम में मिलेगा. नीमोमीडियास्टिनम में एक और बताओ कौन सी ऑस्कल्टेटरी फाइंडिंग मिलती है? उसको बोलते हैं हेमन क्रंच साइन. व्हाट इज हेमन क्रंच साइन? इट इज अ मैन वॉकिंग ऑन अ स्नो विद स्नो बूट्स ऑन. दैट इज हेमन क्रंच साइन. अच्छा, ये आपका रेगुलर स्टार्ट. अभी जो आप लोग बोल रहे थे गॉलस्टोन प्रेजेंट है, ऑब्स्ट्रक्शन प्रेजेंट, नीमोबिलिया प्रेजेंट है, ऑल दैट आई हैव गिवन यू इन अ सीटी फॉर्म. ठीक है, डबल बबल साइन ऑलरेडी स्पोकन अबाउट इट. डिओडिनरी से एनुलर पैंक्रियास. You have air fluid levels which are in a step ladder pattern and they are more than 3, significant of small bowel dynamic obstruction. This is your hairball. That is nothing but your trichobezier. Trichobezier is also called as Rapunzel syndrome. The management for trichobezier is going to be total gastrectomy. Thumbprint sign seen in ischemic colitis, most common seen on the splenic flexure. Accordion sign which is seen in pseudomembranous colitis. Bosch लेखन ने already बात कर लिया. Left hemidaphragm, also left hemithorax में you will see presence of air bubbles. Apple core sign on colon is going to be in colon cancer. Claw sign is seen on interception. Technetium 99 mein you will see presence of an ectopic foci is seen in Meckel's diverticulum. Why? Meckel's diverticulum has an ectopic gastric mucosa. Technetium 99 has got very high affinity for your gastric type of mucosa. Meckel's diverticulum, a rule of 2 at 2% population. That is what is the most common congenital anomaly of the small bowel. It is 2 inches in size, 2 feet proximal to IC junction, which is 60 centimeters, and 2 different mucosa. Remember this, very, very important. Coffee bean sign pointing towards the right upper abdomen, then it is going to be your sigmoid volvulus. Left upper abdomen is going to be your cecal volvulus. Barium enema karoge, what will you see in volvulus? Bird of prey sign. If you see something like this where you have sawtooth appearance, it is a classical for diverticulosis. Diverticulitis में आप CT करोगे, उसमें classification है. What is the classification used for diverticulitis? CT classification for diverticulitis. Come on. What is the CT classification for diverticulitis? फटाफट. Very good. It's your Hinchey's classification. Okay? Hinchey's classification. Now, imaging on hepatobiliary pancreas. If you see air fluid level on the right hemidiaphragm, on the right subcostal space, it is going to be emphysematous gallbladder. If you have free floating membranes on a CT, that is on a liver, it is going to be hydrated cyst. If you see this dotted lines around the gallbladder, this is diverticulosis of the gallbladder. Central stellate scar on CT is indicative of, remember, focal nodular hyperplasia. It can also be seen in serous adenoma pancreas, fibrolamellar variant of HCC, and renal oncocytoma. Pneumobilia is seen in, abhi bataya tha, regular striad. ठीक है. Now, if you have an ultrasound of the gallbladder, there are two images, one on the left, one on the right, A and B. Now, A में आप lesion देखोगे, there is no post-echogenic shadow. B में post-echogenic shadow is present. So, this is going to be stone. This is going to be gallbladder polyp. Gallbladder polyp में आपको, you will not see post-echogenic shadow. Gallbladder stone में you will see post-echogenic shadow, and that is how you pick it up. Strawberry gallbladder is your cholecystitis. This is your cometal appearance on an ultrasound. It is seen in adenomyomatosis. ठीक है. Pancreas में, if you see double bubble sign, annulus pancreas, I've given you a CT image for the same. Acute pancreatitis में कौन-कौन से radiograph देखोगे? You will see sentinel loop sign, you will see colon cutoff sign. If you have an autoimmune pancreatitis, this is the normal waviness of the pancreas. Loss of waviness, it is called as sausage-shaped pancreas. Sausage-shaped pancreas is an indication of autoimmune pancreatitis. The antibody responsible for autoimmune pancreatitis is IgG4 class of antibodies. IgG4 और कहाँ-कहाँ बताया था? Autoimmune pancreatitis में मैंने आपको already बताया IgG4. IgG4 और कहां मिलेगा? IgG4 कहां मिलेगा? It will be seen in hormones. It is also seen in Riedel's thyroiditis. ठीक है? So autoimmune pancreatitis. It is seen in autoimmune pancreatitis, Ormond's disease, and Riedel's thyroiditis. ठीक है? On an ERCP, if you get a chain of lake appearance or you can see string of beads appearance, it is your chronic pancreatitis. Investigational choice for chronic pancreatitis is MRCP with secretin stimulating study. Gold standard, it is going to be ERCP. Don't forget about it. ठीक है? On the other hand, if you find a double duct sign, it is your pancreatic head cancers. It is also seen as an inverted 3 sign. Do not forget about it. Okay? Now, this algorithm is your favorite question from your NEET PG. Abhi tak theek ho sab log? Is everybody on the same page? Are you guys good? BLS NEET PG के बाद start होगा. ठीक है? Can we move on? Can we move on? चलो. So, बार बार आपसे एग्जाम में पोस्ट कोलेसिस्टेक्टमी पेन पे सवाल आता है. Maybe you can sit down for a while standing for so long, sir. But I'm a surgeon, right? And we operate by standing. The reason why we stand and operate, because when you stand, you have the maximum concentration. बैठने पे relaxation आता है. अगर मैं relax करूंगा तो आप relax करोगे, and I can't afford to do that. I want you to be on your toes, so I have to stand. सो आई एम डूइंग दिस फॉर यू, ठीक है, भूलना नहीं। चलो थोड़ा ज्यादा हो गया बट ठीक है, राइट। चलो let me walk you through the post cholecystectomy pain management. Again, a beautiful component to it, ठीक है। Surgery is so conceptual. If you understand it, it is like music. Sir, how to differentiate between periampullary carcinoma and head of the pancreas? Okay, that can only be possible if you're doing a MRCP imaging. ठीक है। What is BLS? Hey Bhagwan. Okay, if you're watching my lecture right now and if you don't know BLS, then I'm absolutely sad. BLS is called as Bailey and Love, learned with Dr. Sandeep. I've started that series a year ago. We are reconstructing the entire Bailey and Love in my style of lectures, and we do one topic a day, and we do Monday, Tuesday, Wednesday, 9 to 10 p.m. That is purely out of love for surgery. I want to replicate entire Bailey's written format into a video lecture format, and that is free on YouTube for every single medical graduate student or any aspiring surgeon just to go through it. ठीक है। Raju, yeah, see, the problem is periampullary carcinomas and pancreatic head cancers, they mimic the same. The reason why it is in that context is periampullary itself is you take ampullary center, draw 2 centimeter radius, and anything that comes around that is periampullary. We have named it as periampullary because it is very difficult to differentiate from the rest of it. ठीक है, तो duodenal cancers or pancreatic head cancers or distal cholangiocarcinomas, if they are present, they all present with same symptoms. Hence, the spectrum is called as the periampullary carcinoma. ठीक है, okay. Let's go back again to our post cholecystectomy pain. Now, imagine you have done a laparoscopic cholecystectomy. On post-operative day 1, patient complains about severe abdominal pain. Now, reason for a severe abdominal pain, normally if it is a post-operative pain, it will subside with analgesia. If a pain fails to subside with analgesia, that should ring a bell कि भाई ये हो क्यों रहा है। तो देखो, post cholecystectomy दर्द क्यों होगा? Either there is a bile leak which is causing biliary peritonitis, or there is obstruction to the common bile duct. That can be because of injury, or during the surgery, the stone from the gallbladder would have fallen into the bile duct, occluding the bile duct, or you have injured some other structure around it. It could be a stomach, it could be a duodenum. ठीक है, तो मेरा काम ये है कि ये पता करना है कि भाई इसको दर्द क्यों हो रहा है। तो जैसे ही पेशेंट बोलेगा बहुत दर्द हो रहा है, तो यू विल कॉल अप योर रेडियोलॉजिस्ट कि सर एक काम करो ना, ये पेशेंट का मैंने कल कोली किया था, आप इसका अल्ट्रासाउंड कर दो, इतने में आप LFT भी भेज दो। तो एनी पेशेंट हु कम्स टू विद पोस्ट कोलेसिस्टेक्टमी पेन, सबसे पहले आप उसका अल्ट्रासाउंड विद LFT कराओगे। अब देखो, रेडियोलॉजिस्ट अल्ट्रासाउंड कर रहा है, अब अल्ट्रासाउंड करते 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 ही विल से अरे देयर इज सब हेपेटिक कलेक्शन। ठीक है, ही विल कॉल यू अप, सर देयर इज सिग्निफिकेंट फ्लूइड कलेक्शन व्हिच इज प्रेजेंट इन सब हेपेटिक स्पेस। तो आप बोलोगे सर वो क्या फ्लूइड है? इट कुड बी क्यों, समटाइम्स यू गिव अ लवाज नॉर्मल सलाइन का, इट कुड बी अ सीरियस कलेक्शन, इट कुड बी अ ब्लड ऑल्सो, इट कुड बी बाइल ऑल्सो। हाउ डू यू कंफर्म इट? यू टेल योर रेडियोलॉजिस्ट कि सर आप जो सिग्निफिकेंट फ्लूइड कलेक्शन बोल रहे हो ना, उसको एस्पिरेट कर लो, पुट अ नीडल एंड पुल इट आउट। नाउ द मिनट ही एस्पिरेट्स, ही विल कॉल यू बैक अगेन, सर ये तो बाइल स्टेन्ड है, अब तो लंका लग गई। ठीक है, क्योंकि अब ये बाइल स्टेन्ड है, मतलब बाइल लीक हो रहा है। अब बाइल कहां से लीक हो सकता है? आई हैव गिवन एन एग्जांपल। एक ये है कि सिस्टिक डक्ट पर आपने स्टंप रखा, अब जो क्लिप रखा था वो क्लिप गिर गया, तो यहां से बाइल लीक हो रहा है। दूसरा, आपने बाइल डक्ट में इंजरी कर दी, पहला वाला तो ठीक है, दूसरे वाले में तो पंगा है। ठीक है, तो आई वांट टू नो वेदर इट इज अ सिस्टिक स्टंप लीक और अ बाइल डक्ट इंजरी। अभी पता कैसे चलेगा? इसको पता करने के लिए आई हैव टू डू ERCP। व्हाई ERCP? क्योंकि ERCP एक तो कंफर्म कर देगा बाइल लीक का, और दूसरा लोकेशन भी बता देगा। एंड इफ देयर इज अ बाइल लीक फ्रॉम द स्टंप, आई कैन पुट अ स्टेंट, तो ये थेरेप्यूटिक भी हो गया। रिमेंबर, ERCP is a therapeutic tool with diagnostic capability. It is predominantly not a diagnostic tool. ठीक है, तो मेरा जैसे बाइल स्टेन आया, मैंने ERCP करा, ERCP अगर मुझे बाइल डक्ट इंजरी पता चली तो CBD स्टेंटिंग करा दी, ये फेल हो गया था, सर्जिकल मैनेजमेंट। ये आपका फर्स्ट स्टेप है। ठीक है, अच्छा, सिनेरियो नंबर 2, पेशेंट इज प्रेजेंटेड विद पोस्ट कोलेसिस्टेक्टमी पेन। आपने अल्ट्रासाउंड कराया LFT के साथ। ठीक है, नाउ योर रेडियोलॉजिस्ट सेज देयर इज नो सबहेपेटिक कलेक्शन। ठीक है, बट आई कैन सी द CBD is dilated. Now that CBD dilatation can be because of a stone which is lodged, or it could be a bile duct stricture which you have caused the injury. अब पता कैसे चलेगा? ठीक है, LFT abnormality भी है, I know the CBD is dilated, I don't know the reason for dilatation of CBD. आपका अल्ट्रासाउंड करते CBD dilated आ गया। The normal CBD's diameter is less than 7 millimeters. If the CBD is more than 7 millimeters, it is dilated. I want to find out. कैसे पता चलेगा? मेरे पास डायग्नोसिस नहीं है ना, तो मैं MRCP करूंगा. ठीक है, MRCP करने के बाद I can say whether there is a bile duct injury or whether there is a CBD stone or there is a remnant gallbladder stone. तीनों में से कोई प्रॉब्लम हो सकती है. अगर बाइल डक्ट इंजरी है, आई विल गो स्ट्रेट अप हियर. ठीक है, मेरे को ऑलरेडी पता है अगर इंजरी तो क्या करेंगे, ईआरसीपी स्टेंटिंग करेंगे, नहीं हुआ तो सर्जरी कर देंगे. ऑन दी अदर हैंड, इफ देयर इज अ सीबीडी स्टोन, एमआरसीपी में बता सीबीडी स्टोन है, स्टोन कैसे निकालोगे? ईआरसीपी करो, बलून स्वीप करो, स्टोन निकालो, स्टेंट डालो, खत्म कहानी. रेमिनेंट गॉल ब्लैडर का स्टोन है तो बाकी जो रेमिनेंट आपने छोड़ा वो उसको वापस निकालो, तो डेफिनेटली सर्जरी कर दो, खत्म कहानी. ठीक है, सो ये आपका सिनेरियो नंबर 2. सिनेरियो नंबर 3 में क्या, योर रेडियोलॉजिस्ट विल टेल यू कि सर नाउ आई एम एबल टू सी सीबीडी स्टोन, जिसके से पेन हो रहा है. जब रेडियोलॉजिस्ट खुद कंफर्म कर रहा है सीबीडी स्टोन है, तो आप कौन हो तो उसको बोलने वाले, जाओ ईआरसीपी करो, स्टोन निकालो, सर नेक्स्ट इज गोइंग टू बी ईआरसीपी. ऑन द अदर हैंड रेडियोलॉजिस्ट बोलता है सर ना ही बाइल कलेक्शन है, ना ही सीबीडी डायलेटेड है, ना ही सीबीडी स्टोन है, तो क्या प्रॉब्लम है? प्रॉब्लम ये हो सकती है कि अब आपने स्टमक या डिओडिनम में पंक्चर कर दिया, उसको पता कैसे करोगे? यू विल डू अ सीईसीटी एब्डोमेन. ठीक है, नाउ वंस यू डू अ सीईसीटी एब्डोमेन यू विल गेट योर रिजल्ट अबाउट इट. ठीक है, तो दिस इज हाउ यू मैनेज योर पोस्ट कोलेसिस्टेक्टमी पेन. ठीक है, क्लियर है? Acute calculus from acute A calculus. Ultrasound. On an ultrasound, if the gallbladder wall is thickened because of edema, which is more than 3 millimeters in thickness, and there's no evidence of stone, it is A calculus. If there's evidence of stone, there is calculus. Simple. ठीक है. So now let's see, if I ask you a question, will you be able to answer me? I want you to type on your chat box. ठीक है. Question number 1 is, I have a patient with post cholecystectomy pain. What is your next immediate step? I have a patient with post cholecystectomy pain. What is your next immediate step? I have a patient with post cholecystectomy pain. What is your next immediate step? Dinu wrong, Raju wrong, Urmila wrong, Make you laugh wrong, बालू रॉन्ग, आदेश रॉन्ग, कोई तो सही जवाब दो यार. उमेश रॉन्ग, उमेश इज करेक्ट, उमेश इज करेक्ट. यू विल डू अल्ट्रासाउंड विथ एलएफटी, यू विल डू ईआरसीपी. अभी स्क्रीन में घुस के मारूंगा मैं. ठीक है, रात के 12:30 बज रहे हैं एंड वी आर ट्राइंग टू कॉन्सेंट्रेट. गलत गंदे जवाब नहीं देने. ईआरसीपी एमआरसीपी. Post cholecystectomy pain, next immediate step, ultrasound with LFT. ठीक है, सब लोग अल्ट्रासाउंड बोल रहे थे. I was expecting ultrasound with LFT करना है. ठीक है, अच्छा, I'll change the question. Question number 2. A patient who underwent cholecystectomy started developing pain. On ultrasound, we found there is significant fluid collection. What is your next immediate step? What is the next immediate step? Come on. पक्का LFT बेटा, सवाल पूछ रहे हो. Dr. PM, you're correct. Contemporary, you're wrong. Raju, you're correct. ठीक है, it is USG guided aspiration. That is how they ask the question and they get you. Post cholecystectomy pain, next immediate step is USG with LFT. Post cholecystectomy pain, on ultrasound there is significant fluid collection. The next step is USG guided aspiration. Post cholecystectomy pain, on USG guided aspiration there is bile stain. Next immediate step is ERCP. On ERCP, cystic stump leak is found. It is going to be stenting. Bile duct injury is present. It is going to be surgical repair. ठीक है. Same thing if I change. Same thing if I change. Post cholecystectomy pain, on ultrasound, CBD is dilated. What is your next immediate step? ये बताओ. Post cholecystectomy pain, on ultrasound, CBD is dilated. What is your next immediate step? Absolutely correct. Ved, it is MRCP. ठीक है. Right. Change the question. Post cholecystectomy pain, on ultrasound, there is CBD stone. What is your next immediate step? Post cholecystectomy pain, on ultrasound, there is CBD stone. There is CBD stone. What is your next immediate step? Absolutely correct. It is going to be ERCP. Now you're pro at managing post-cholecystectomy pain. Is everybody clear with that? ठीक है? ERCP stone extraction is the correct answer. So please tell in burn patient how much total body surface area max we should consider. Vivek, I didn't get your question, beta. ठीक है? Clear? पक्का LFT करना है बेटा, करना है. अल्ट्रासाउंड विद LFT करना है, ऑप्शन ही नहीं है. ठीक है, चलो. नाउ ये आपका लास्ट ईयर का भी एग्जाम क्वेश्चन था. दे हैव आस्क्ड यू कैलेट्स ट्रायंगल की बाउंड्रीज. सो कॉमनली मिस्टेकन हेपाटोसिस्टिक ट्रायंगल और कैलेट्स ट्रायंगल होते हैं. ठीक है, हेपाटोसिस्टिक ट्रायंगल में द इंफीरियर बॉर्डर ऑफ द लिवर, द कॉमन हेपाटिक डक्ट एंड द सिस्टिक डक्ट. Calyx triangle में the common hepatic duct, cystic duct and the cystic artery. What is the content of the Calyx triangle? Lymph node of Lund. What is the content of the hepatocystic triangle? It is your cystic artery. ठीक है? Is that clear? Is that clear? Is that clear? ठीक है, चलो. Now another previous exam question that they've asked you about is going to be about the malformations. ठीक है, in the malformations, one of the most common malformations of the cystic artery, it is going to be your caterpillar stern, also called as Moynihan's hump. The Moynihan's hump is not a cystic artery deviation, it is a right hepatic artery which comes into the calyx area. ठीक है, नॉर्मली कैलेट्स एरिया में आपका सिस्टिक आर्टरी होना चाहिए, लेकिन अगर कैलेट्स एरिया में राइट हेपाटिक आर्टरी विच इज टर्निंग लाइक दिस, लाइक अ नाइस कर्व. ठीक है, इट इज कॉल्ड एज द मोइनहैंस हम्प और आल्सो कॉल्ड एज द कैटरपिलर स्टर्न. ठीक है, एज द कैटरपिलर जब वो आगे चलने की कोशिश करता है तो उठता है फिर बैठता है, उठता है बैठता है, उसके मतलब इट ड्रैग्स इट्स पोस्टीरियर पार्ट लाइक दिस एंड देन इट गोज लाइक दिस, इट गोज लाइक दिस. ठीक है, उसी को बोला है कैटरपिलर हम्प. एक और ये, इफ देयर इज द गॉल ब्लैडर व्हिच फोल्ड्स ऑन इटसेल्फ व्हिच इज कॉल्ड एज द फ्राइजियन कैप. ठीक है, इट्स अ normal anomaly that you will see on a gallbladder. ठीक है, images are important, just look at it. Bile duct injury में they have asked you multiple times. So we have the Strasbourg and the bismuth. ठीक है, Strasbourg is the immediate post-op, bismuth is going to be your stricture. That is the only thing that you need to remember. Nothing more. ठीक है, this session will be absolutely available later on also. It is live as well as recorded, so you will find it on the YouTube only. ठीक है. Now, Strasbourg में type A, it is going to be leak from the stump. Type B injury, if there is going to be a clipping or the obstruction to the right aberrant sectoral duct. Type C में there is leak from the sectoral duct. Type D, there is injury to the extrahepatic bile duct. Bismuth में there is a stricture which is going to be more than 2 cm below the hilum, within 2 cm from the hilum, at the hilum, involving both the right and hepatic, but then the flow of the bile is maintained. In type E5, there is no flow of the bile is maintained across it, complete disruption. Bile duct injury ka management protocol is also very, very important. So I've just put it an algorithm here. Whenever you have a patient with bile duct injury, first you will see that when did you detect it, during the surgery or in the post-op. Post-op के लिए हमको already पता है ना, post cholecystectomy pain वाला protocol that we are going to use it here. ठीक है. On the other hand, if it is intraoperative, you will see whether it's a known duct or an unknown duct. A known duct always repair. Unknown duct to find out where it is leaking from. So intraoperative cholangiogram should be done. In the intraoperative cholangiogram, if you see the contrast is leaking, you will quantify the leak with respect to size of the duct. Less than 3 millimeters है कि more than, less than equal to 3 millimeters तो more than equal to 4 millimeters है. Less than 3 insignificant duct ligate कर दो, more than 4 है, you have to repair it. What is the repair criteria? Is the injury less than half the circumference or more than half the circumference? Less than half circumference, put a T-tube from the same side. More than half the circumference, you will see whether it is completely transacted or still continuous. अगर continuous है, primary side को repair करोगे, T-tube नीचे से डालोगे. लेकिन अगर transacted है, distance between the two transacted end less than 1 centimeter है, then you will repair this, put a T-tube from a different side. More than 1 centimeter distance है, then you do a Roux and Y hepatico-jejunostomy. इसके बियॉन्ड नॉन निगोशिएबल बात है भाई, ठीक है। इज दैट क्लियर? इज इट क्लियर? ठीक है, दिस इज अबाउट योर बाइल डक्ट इंजरीज, ठीक है। मैनेजमेंट ऑफ द सीबीडी स्टोन्स, अगेन सारी ट्रिकी पॉइंट्स जो हैं। क्या हो गया वेद, क्या प्रॉब्लम है बेटा? इतनी सुबह सुबह कोई रोता है क्या? Somebody is asked a question. अच्छा सॉरी, हाँ, बर्न्स में ना मैक्सिमम दैट यू कैन कैलकुलेट फॉर द फ्लूइड इज एट द 50% ऑफ द टोटल बॉडी सरफेस एरिया बर्न, चाहे वो 60, 70, 80 हो, 50% ही लेना है। यू कांट गो एंड कैलकुलेट फॉर 90%, इतना हाई वॉल्यूम हो जाएगा, पेशेंट को पल्मोनरी एडिमा हो जाएगा, ठीक है। इतना वॉल्यूम रिससिटेट नहीं करना है, क्लियर है? क्या हो गया, थक गए? डू यू वांट अ ब्रेक? डू यू वांट अ ब्रेक? चलें चलें चलें, ज्यादा नहीं बचा है। वंस यू आर डन विद दिस, उसके बाद हाँ मैक्सिमम 1-1.5 घंटा। इफ यू वांट वी कैन टेक अ शॉर्ट ब्रेक ऑल्सो, वंस यू फिनिश द बिलरी सिस्टम, उसके बाद ब्रेक ले लेते हैं, ठीक है। बेटा थोड़ा मेरे बारे में भी सोचो ना यार, आई हैव बीन स्पीकिंग नॉन स्टॉप। बेटा नो सर, थोड़ा यस सर भी बोल दो यार। सर 5 मिनट रेस्ट ले लो, वॉइस रेस्ट इंपॉर्टेंट है। इफ यू हैव रियलाइज्ड, आई हैव बीन टॉकिंग नॉन स्टॉप एंड आई हैव बीन स्पीकिंग इन अ टेम्पो एंड आई हैव बीन गिविंग यू द इन्फो, ठीक है, एंड आई हैव टू गिव अ वेरी प्रिसाइज इन्फो बाय नॉट स्क्रूइंग इट अप, ठीक है। ओके बेटा ब्रेक दे दूंगा, उसमें जो करना है कर लो, ठीक है। चलो विल फिनिश दिस एंड देन विल टेक अ 10 मिनट्स ब्रेक, 15 मिनट्स ब्रेक, ठीक है। अच्छा, मैनेजमेंट ऑफ कोलिडोकोलिथियासिस थोड़ा ट्रिकी है, तो एवरी सिंगल टाइम दे हैव आस्क्ड यू, विल ट्राई टू अंडरस्टैंड इट। इफ अ सीबीडी स्टोन इज फॉर्म बिफोर अ कोलेसिस्टेक्टमी, हाउ वुड यू गो? I will go with ERCP, remove the stone and then do a CBD stenting. While I've done that, it should be followed by laparoscopic cholecystectomy. Clear? ठीक है? CBD stent should be removed after 2 weeks once you have put across here. Laparoscopic cholecystectomy should be done in the next 48 hours. ठीक है? अच्छा, अगर CBD stone is detected during the surgery, while performing the surgery, what will you do? You do a laparoscopic cholecystectomy and do a CBD exploration. Remove the stone, put a T-tube, and after 5 to 7 days of putting a T-tube, do a T-tube cholangiogram. On a T-tube cholangiogram, you can see whether the stone is present or absent. If there's no T-tube, if there's no residual stone is there, you can remove the T-tube after 14 days, which I've decided. If the residual stone is present, you do something called Bruhan's technique, that is removal of the stone via the T-tube. We're putting a choledocoscope. Wait for after 2 to 3 weeks and do a repeat T-tube cholangiogram to look for stone is present or not. Last, if CBD stone is detected post-operatively, then do an ERCP stone extraction and CBD stenting. This is what you have to do. Indication of prophylactic cholecystectomy is your repeat exam question. They've asked you again and again. Number 1, any patient is going for any major surgery or transplant per se because they give cyclosporin, which indicates causes stasis of gallbladder resulting in stone formation. निकाल दो. Biliopancreatic diversions निकाल दो. Prolonged TPN निकाल दो. All hemolytic disorders that result in black pigmented stones निकाल दो. टाइफॉइड कैरियर्स रिस्क, इंक्रीज रिस्क फॉर गॉल ब्लैडर कैंसर निकाल दो. ट्रॉमा टू गॉल ब्लैडर बचा के क्या करोगे, सिल के क्या करोगे, निकाल दो. नॉन फंक्शनिंग गॉल ब्लैडर, जो गॉल ब्लैडर का वैसे ही कोई काम नहीं है, उसके बाद ये भी रखा हुआ है, काम ही नहीं कर रहा, निकाल दो. इंसिडेंटली डिटेक्टेड स्टोन ऑफ मोर देन 2.5 सेंटीमीटर्स हैज अ हायर प्रोपेंसिटी टू कॉज ऑब्स्ट्रक्शन ऑफ द सीबीडी, निकाल दो. देखो नॉर्मली ना अ वेरी ब्यूटीफुल कॉन्सेप्ट, ठीक है. व्हेन यू लुक एट द गॉल ब्लैडर, नो, दिस इज द गॉल ब्लैडर. This is the Hartmann's pouch. This is the gallbladder. This is the Hartmann. This is cystic duct. ठीक है. This is going to be your common hepatic duct, and together they combine to form common bile duct. ठीक है. Now, what is interesting here is when you look at the diameter of the cystic duct, it is 3 millimeters, and diameter of the CBD is going to be 7 millimeters. Now, a stone which is present here, if it has to pass through the cystic duct, it should be less than 3 millimeters in diameter. Can a 3 millimeter stone cause an obstruction to the bile duct? The answer is no. But वही stone अगर 2.5 सेंटीमीटर से ज्यादा है, it can obviously cause obstruction, hence causing problem. So, prophylactic cholecystectomy for a stone greater than 2.5 centimeters should be taken. Porcelain gallbladder, which is a non-functional gallbladder, chronic calcified gallbladder, increase the risk for gallbladder cancer, remove it. Okay. Polyps of more than 1 centimeter in size. Beta 2.5 centimeters, beta 2 nahi hai, 2.5. Any adenomatous polyp measuring more than 1 centimeter should be removed. Okay. These are the indications of prophylactic cholecystectomy. आगे चलें. Gallbladder cancer, risk factors, same component. Presentation would be of GB mass, jaundice will be late, and then be weight loss presentation. Investigation is CCT, staging is going to be PET CT. Now, stage-wise management is what is important in gallbladder cancer. They've asked you. T1A is involvement of lamina propria, stays above the level of muscle. Remember, submucosa in gallbladder is absent. Submucosa मिलेगा नहीं आपको, ठीक है? तो T1A है तो simple cholecystectomy. T1B muscular layer is involved. Do a radical cholecystectomy. Radical में क्या gallbladder निकालोगे? Segment 4B and segment 5 of the liver. It is the gallbladder fossa. And the lymph node along the hepatoduodenal ligament will be removed. Cystic stump आप frozen section के लिए भेजोगे. अगर cystic stump में tumor positive है, then you'll go with CBD resection. Then you will do a Roux-en-Y hepatogenostomy. T2A में क्या है? It is beyond serosa on the peritoneal side. T2B is beyond serosa on the hepatic side. T3 is involvement of liver or extrahepatic duct. T4 is adjacent organ. Until T2A, T2B, T3, you do a radical cystectomy followed by chemo, followed by radiotherapy. Chemo is going to be gemcitabine based. Adjacent organ involvement hai, so it is already advanced. Do a gemcitabine based chemotherapy. If the response is good, do a surgery. Response is poor, you are going to go ahead with palliative management. Okay? So this is all in all that you should know across. Sorted hai? Chalo. So it is 12:45. We take a break for 15 minutes. We'll resume back at 1 a.m. and then we will finish our marathon. It is like a true marathon, no? Such में लग रहा है. I feel on my legs also. ठीक है? चलो. Take a break for 15 minutes. We'll resume back. Okay. Ready for the last leg? Ready. Can we start? Chalo. Okay, let's go to the last leg. Right. So we'll be starting with nephrolithiasis. Okay. Now, in the nephrolithiasis, okay, guys, chalo. Let's pick up. Now, when you talk about nephrolithiasis, remember 90% of your nephrolithiasis or renal stones are radiopaque, 10% are radiolucent. Opposite is true for gallbladder. If I change the value to 80%, 20%, that means 80% of the stones are radiopaque, 20% are radiolucent. They are silolithiasis, that is salivary gland stones. Commonly, we have the calcium oxalate stones, the phosphate, uric acid, and cystic stones. The most common nephrolithiasis is calcium oxalate stones. Okay? Right. The most radiopaque is going to be phosphate stones. The most common radiolucent stone, it is going to be uric acid, and the hardest is going to be cystine stones. Okay? Now, the causes I've listed in front of you, nothing spectacular about it. Characteristic features, calcium oxalate, round to oval, sharp projection, dirty white. Because of the sharp projection, they also have hematuria. Okay? Phosphate stones are called as triple stones, true white, stagon stones. They are also called as silent stones. They are the one which is associated with the maximum damage to the kidney and poor prognosis. Okay? Uric acid, they formed in acidic urine. All that you have to do is to make the urine alkaline, and the drug of choice for alkalization of urine is going to be acetazolamide. Cystine stones, they are going to be black, hard, they contain sulfur, hence they are also radiopaque in nature. Now, what they ask you is basically about your urine microscopy. Okay? So you see the envelope shaped crystals which are present in calcium oxalate stones. You will see coffin slit like structures which are going to be in phosphate, multiphased uric acid, hexagon or benzene shaped is going to be in cystine stones. Okay? Now, with respect to investigation, the first investigation is X-ray KUB. Ultrasound is done to look for size, location, hydronephrosis. CT urography, which is NCCT of the kidney, is the investigation of choice. Multiple times asked in our exam. You have radionuclide scans, that's DMSA scan, DTP, and MAC3. DMSA is your dimercaptosuccinic acid, used for morphology, scarring of the kidney and renal anatomy. DTP diethyl triamine pentacetic acid, investigation of choice for renal perfusion. MAC3 is mercaptoacetyl triglycine, which is the gold standard for renal perfusion. Okay. Size less than 5, conservative 6 to 15 is ESWL, more than 15 is PCNL, and if it is going to be stagon, you do an ESWL with PCNL. Another question that you have, what are the contraindications for ESWL? Contraindication for ESWL, number one, if the patient is obese, obviously the shock waves won't reach. If there are distal ureteric strictures, patient has bleeding disorders, if there is multiple stones, which are called as Steenstrasse, in German called as road of stones, those are the contraindications. Stones that cannot be broken down by ESWL, A, B, C, D. Hydroxyapatite stone, bruchite stone, then you have calcium oxalate monohydrate, and then you have cystine stones. These are the one which are going to be, yes, in pregnancy also ESWL is contraindicated because shock waves are contraindicated in pregnancy as well. Now, genitourinary tuberculosis में important components क्या है? For kidney, you will see presence of cement kidney, putty kidney, autonephrectomy. Bladder, gallful ureter and thimble bladder. Another reason for thimble bladder is going to be schistosomiasis. Prostate, hard indurated prostate. Vas deferens is going to be beaded. Scrotum, multiple discharging scrotal sinuses. BPH, important components. The basic concept is increase in dihydroxy testosterone, where because of 5-alpha reductase enzyme, which is the most potent stimulator of your prostate gland. BPH may currently the important aspect is to differentiate between voiding and storage symptoms. Any symptom that is occurred during the voiding or during the maturation is voiding. Apart from that, it is going to be storage. Two images that can be seen in BPH complications where you have bladder wall thickening is called as bladder trabeculation or a bladder diverticula. Right now, when we talk about the component here, the first investigation that you will do is going to be a digital rectal examination. 1 second, guys. There's a small flickering occurring. 1 second, reconnect it. Hold on for a second. Okay. 1 second. Just give me 10 seconds. Now, the first examination is going to be digital rectal examination to look for the size of the prostate gland, which is enlarged. Also look for the surface of the mucosa, and is the rectal mucosa sliding over the prostate or not. If it is not sliding, it can be malignancy also. Ultrasound is to evaluate the size of the prostate gland. Uroflowmetry is the investigation of choice, where if it is more than 15 ml per second, it is normal. 10 to 15 is equivocal, less than 10 is considered to be obstruction. PSA is done normally for all patients of enlarged prostate gland. The normal prostate specific antigen is less than 4. When it is malignant, if it is more than 20, metastatic is more than 35. When do you have an elevated PSA between 5 to 19? ABCD is acute bacterial prostatitis, B for BPH, C for catheterization, D for distal rectal examination. Now, for all patients of your BPH, the drug of choice is alpha 1A blocker, that is tamsulosin. Surgery of choice is going to be TURP. The irrigating fluid of choice is going to be 1.5% glycine. Contraindication to TURP are hip disorders, bleeding disorder, size more than 100 cc or more than 90 minutes for surgery. Those who cannot get TURP done, we have an open surgery. Remember, this names and the approaches are important. Frays is transversical, Millens is retropubic, Young's is perineal. FTV, Frays is transversical, MRP, Millens is retropubic, Young's is perineal route of approach. Okay? Now, the new one is holmium laser induced prostatectomy called as HOLUP, that is for prostatectomy. Congenital disorders in testes, important between undescendant and ectopic testes. Remember, undescendant will be found in its normal embryonic path. Ectopic testes will be away from its normal embryonic path. Okay? Now, the most common site for undescendant testes is inguinal canal. Ectopic is superficial inguinal pouch. Everything is damaged in undescendant testes. Everything is normal is going to be ectopic testes. Now, usual algorithm is this. How do you manage a patient of undescendant testes? You look for unilateral or bilateral. If it is unilateral, palpable, non-palpable, do an orchidopexy. Non-palpable, do a diagnostic laparoscopy. If it is an abdominal testis, do an orchidopexy. If it is blind ending vessel, diagnosis of monoarchaea is noticed. If it is a bilateral, you need to know whether testes exist or not. Give an injection of beta HCG, see if there is any response, increase in FSH, LH or GH. Then you will do a diagnostic laparoscopy. No response, consider as anorchia. Send it for karyotyping to see whether the baby is male or female. Okay? Now, these are the spotters. The first one is your Fournier's gangrene. You cannot go wrong on this. It is your necrotizing fasciitis of the perineal region. It is a combination of both aerobic and anaerobic infection, usually seen in diabetic and immunocompromised patients, seen in foul smelling and rice watery discharge, and it is testes are usually sped. Management is going to be debridement, as simple as that. Okay? Give me a second. Now, uroradiology, you will see the first one, the flower vase appearance seen in horseshoe kidney. Where do you see the isthmus of horseshoe kidney? Between L3 and L4. And inferior the ascent is prevented by inferior mesenteric artery. But abdominal walls gangrene is what we call as Melanese gangrene. That is usually in post-operative. Okay? Sure. Staghorn calculi, we have already spoken about it. Putty kidney, we have spoken it is seen in tuberculosis. Okay. Fish hook ureter, this is seen in your retrocable IVC. Soap bubble sign in hydronephrosis. Spider leg appearance in your polycystic kidney disease. Okay. Adderhead appearance is going to be in ureterocele. Foley's catheter, we have already discussed it. But remember, Foley's catheter, I have showed you Foley's 3 ways. Ye ek dikhana baki tha. This is going to be a silicon based Foley's catheter. Ek aur hai curved tip aata hai, which is called as the Corday Foley's catheter. Whenever there is BPH or stricture or there is narrowing, Corday is a better one to put across here. Okay. I've already spoken about it. This is the DJ stunt, Dormia basket for stone extraction. This is the urethral injury images that you will see usually. Okay. You will see if prostatic, see, this is penile urethra, bulbar urethra, membranous and prostatic. This loop is bulbar urethra. This loop is bulbar urethra. Now you can see if the leak is in this loop, this is bulbar urethral injury, that is anterior urethral injury. If it is beyond that, this is a posterior urethral injury. The most common site for posterior urethral injury is membranous urethra. Anterior is going to be bulbar urethra. Okay? Chalo. So that is in the context of it. Now, coming back to the hernias, again very, very important. So comparison between indirect and direct inguinal hernia, lot of things would be spoken about it. I will give you a quick recap. ठीक है? देखो indirect और direct में फर्क क्या है? Indirect को indirect इसलिए बोलते हैं कि वो निकलता deep ring से है, start होता है deep ring से, exit superficial ring से होता है. Direct निकलता है आपके Hasselbalch triangle से, posterior से, और निकलता है superficial inguinal ring से. अगर आपको कोई भी doubt है, if you have a doubt in hernia, I would recommend you to watch my video of BLS of inguinal hernia. It is hardly of 1 hour. अगर आप फास्ट फॉरवर्ड कर लोगे, यू विल सी द कॉन्सेप्ट, अ ब्यूटीफुल कॉन्सेप्ट अबाउट योर इंग्वाइनल हर्निया. जस्ट गो वॉच इट, यू विल never go wrong in hernias. ठीक है. Now when you talk about indirect and direct, indirect में एंट्री कहां से? डीप रिंग से. डायरेक्ट में एंट्री कहां से? हैसलबैक ट्रायंगल से. हैसलबैक ट्रायंगल की बाउंड्री क्या है? लैटरली, when you talk about medially it is lateral border of rectus abdominis muscle, inferiorly by inguinal canal, laterally by inferior epigastric artery. ठीक है. अच्छा, दोनों का exit is going to be superficial inguinal ring. The sac of your indirect is formed by peritoneum. The sac of the direct is formed by fascia transversalis. The content can be bowel and peritoneum in both. Relationship of the sac with respect to vas difference. When you see here, ये आपका वास डिफरेंस है, ये सैक है, तो सैक विल ऑलवेज बी लैटरल टू योर वास डिफरेंस और कॉर्ड. यहां पे आप देखोगे इन द डायरेक्ट इंग्वाइनल हर्निया, सैक विल ऑलवेज लाई मीडियल टू दैट. बट व्हेन यू लुक एट विद रिस्पेक्ट टू इंफीरियर एपिगैस्ट्रिक आर्टरी, द एंट्री इज कॉल्ड एज नेक. The neck of your direct inguinal hernia will be medial to inferior epigastric artery. यहां पे आप देखोगे एंट्री यहां से, the neck is going to be lateral to your inferior epigastric artery. That is what relationship of your neck and inferior epigastric artery. Neck lies lateral to inferior epigastric artery. Neck lies medial to inferior epigastric artery. Risk for strangulation is high for indirect, low for your direct inguinal hernia. ठीक है. So you have laparoscopic hernia repairs. I have two triangles or three components to be remembered. I've given you all the important aspects here. तीन ट्राइंगल, तीन रीजन्स, ट्राइंगल ऑफ डूम, ट्राइंगल ऑफ पेन एंड कोरोना मोर्टिस. ठीक है. ट्राइंगल ऑफ डूम की बाउंड्रीज क्या है? एपेक्स में क्या मिलेगा? डीप इंग्वाइनल रिंग, medially vas difference, laterally it is going to be gonadal vessels, external iliac artery, external iliac vein are the content, inferiorly it is by peritoneum. ठीक है. ट्राइंगल ऑफ पेन का क्या मिलेगा? उसके जस्ट लैटरली मिलेगा, दैट इज आइलियोपुबिक ट्रैक्ट, डीप इंग्वाइनल रिंग, medially by gonadal vessels, inferiorly by your peritoneum. There are multiple nerves. The most common nerve injury in laparoscopic inguinal hernia is lateral cutaneous nerve of thigh. Most common nerve injury in open inguinal hernia repair. The most common nerve injury in open inguinal hernia is ilioinguinal. Most common nerve trapped in mesh is iliohypogastric. Most common nerve injured in inguinal hernia repair, that is laparoscopic, is going to be lateral cutaneous nerve of thigh. Corona mortis is also called as crown of death. Why it is called as crown of death? Because injury to this will lead to bleeding extensive, which will lead to death on table. How it is formed? Now this is your aorta, common iliac, internal iliac, external iliac से inferior epigastric artery, internal iliac से obturator artery. There is an abnormal communication between the obturator artery and the inferior epigastric artery. This is called as an aberrant obturator artery running behind the pubic bone. ठीक है. Now when you put the mesh and you tack it, and that tacker can injure this vessel, and that bleeding will, now when it cuts, no, the bleeding will occur from the inferior epigastric artery, from the obturator artery, which are the branches of both external and internal leg. So two arteries are going to bleed at the same time, and when two arteries bleed at the same point or same time, it will cause extensive hemorrhage leading to the death of the patient. As simple as that. Hence it is called as corona mortis. ठीक है. Now mesh के लिए most common is proline. Ideal characteristic is a previous exam question. It should be non-absorbable. It should be lightweight, that is less than 40 grams per meter square. It should be large port so that the tissue can grow into it, and it should be hydrophobic. It should repel water. ठीक है. Ideal overlap, if this is defect, ideal is 5 centimeters, minimum is 2 centimeters, because there is 50% of mesh shrinkage to prevent any mishap or allow, if the defect has not been covered, so minimum overlap should be around 2.2 centimeters, maximum is going to 5 centimeters. Okay? I've given you images of both the meshes, you can just go through it. Now, usually they'll ask you umbilical, spigelian and your lumbar hernias. Nothing spectacular about it. I've given you a comparative table. Umbilical का defect usually 2 to 4 centimeters होता है, spigelian is less than 2 centimeters. Spigelian fascia itself is a very very beautiful concept. ये spigelian fascia क्या है? Lateral abdominal wall muscle है, rectus abdominis wall muscle है, umbilicus के नीचे ना थोड़ा सा गैप है इन दोनों के बीच में, that is lateral abdominal wall muscle और medial abdominal wall muscle rectus के बीच में, ये सिर्फ एक fascia से covered है. The area where there is no muscle, only fascia, is what we call as spigelian fascia. ठीक है. लैटरल एब्डोमिनल वॉल मसल और रेक्टस एब्डोमिनस वॉल मसल के बीच में एक छोटा सा जगह है जहां से फेशिया प्रेजेंट है, एंड दैट इज योर स्पाइजिलियन फेशिया. ठीक है. इसको क्या होगा? ठीक है. On the other hand, when it comes down to your lumbar hernias, there are two triangles. You have the superior lumbar triangle, inferior. Superior को Grindfeld बोलते हैं, inferior को Petit बोलते हैं. Boundaries का superior की, superiorly by 12th rib, medially by paraspinal muscles, laterally by internal oblique muscles. Petit triangle की boundary क्या है? It is going to be inferiorly by iliac crest, laterally by external oblique muscle, medially by your latissimus dorsi. ठीक है. Now, this is the comparative data that you have. Entry for umbilical hernias, umbilicus, exit is umbilicus, spigelian fascia के भी same है, whereas lumbar hernias is going to be superior or inferior lumbar triangle. Sac for all of them is peritoneum. This is retroperitoneum, तो पीछे से आता है, तो no sac here. All of them present the same component. Remember, spigelian hernia के लिए CECT is the choice, investigation choice. as well as for your lumbar hernias. Management for umbilical spigellium is IPOM. This is Daud Ponkas repair. याद रख लेना. This is the most important thing. ठीक है. अगर हर्निया में सवाल पूछना है और थोड़ा ट्रिकी करना है, दे विल आस्क यू अबाउट दिस मेश प्लेसमेंट. ठीक है. तो पहला है आपका आईपॉम. ठीक है, आईपॉम नीचे आएगा. तो पहले इजी से बात कर लेते हैं. You talk about this is all your open mesh repairs. This is going to be laparoscopic mesh repair. But before I go, I just want you to get oriented to this. ठीक है. सबसे बाहर वाला जो लेयर है स्किन है, उसके नीचे सबक्यूटेनियस फैट है, which is divided into campus and scarpus, फिर external oblique muscle, internal oblique transverse abdominis, fascia transversalis, peritoneum. ठीक है. Now, if I put the mesh just under the subcutaneous fat, this is called as onlay. If I am going to put between the two rectus abdominis muscle, it is called as inlay. If I am going to put, ये आपका anterior rectus sheath है, ये posterior rectus sheath है. Rectus abdominis muscle and the posterior rectus sheath. ठीक है. If I am going to put below the posterior rectus sheath, it is called as sublay. If I put between the rectus abdominis muscle and the posterior rectus sheath, it is called as retrorectus. Laparoscopically, if I put above the peritoneum, I am going to pull down the peritoneum, put the mesh. I am now imagine this room is the abdominal cavity. I am inside the room. ठीक है. मेरे ऊपर पेरिटोनियम है. I pull out the peritoneum and then place the mesh and then close the peritoneum. This is called as IPOM, intraperitoneal onlay mesh repair. Onlay का मतलब होता है एक लेयर अबाव. अगर आप ओपन सर्जरी में आ रहे हो, एक लेयर अबाव का मतलब जस्ट अंडर द सबक्यूटेनियस फैट. स्किन सबक्यूटेनियस फैट खोला, मेश डाल दिया. इट इज कॉल्ड एज ऑनले इन ओपन सर्जरी. वही लैप्रोस्कोपिक में करना है तो इट इज इंट्रापेरिटोनियल ऑनले मेश रिपेयर. पेरिटोनियम खींचा, मेश डाला, पेरिटोनियम बंद कर दिया. ठीक है. दिस इज गोइंग टू बी योर मेश प्लेसमेंट्स. ऑनले इज अंडर द सबक्यूटेनियस फैट. ठीक है. इनले इज बिटवीन द टू रेक्टस एब्डोमिनस मसल. ठीक है. रेट्रोरेक्टस इज बिटवीन द रेक्टस एब्डोमिनस मसल एंड पोस्टीरियर रेक्टस शीथ. सबले इज बिलो द पोस्टीरियर रेक्टस शीथ. ठीक है. देन यू हैव आईपॉम व्हिच इज अबाउट द पेरिटोनियम. इतना ही है. इज दैट क्लियर? इज दैट क्लियर? इज दैट क्लियर? ठीक है. Now, omphalocele gastroenteritis we have already dealt. I've shown you the images. Omphalocele में membrane होगा, gastroenteritis में नहीं होगा. Defect in omphalocele is central abdominal wall defect. Gastroenteritis is usually right-sided. Size of the defect in omphalocele is usually more than 4 centimeters. Gastroenteritis is around 4 centimeters. Omphalocele is associated with Beckwith-Wiedemann syndrome, also called as overgrowth syndrome, and also cardiac abnormalities. Here it is only intestinal atresia. ठीक है. Reduce and repair. Here you put it in a silo bag, which is to fill with hot, warm, normal saline. Examine the bowel loops, reduce and then repair the content. ठीक है. This is about this is about your omphalocele. ठीक है. So this was the last topic for your entire revision series, right? This concludes your revision in general surgery from all the small topics that we have put together to stitch into a beautiful component for you to revise it. I'm going to share this material right now. It will be available in the Telegram group of Medit. It will also be available on my Telegram group. Those who don't know me or haven't followed me, you will find this is going to be in the surgery guide. You can find my name. It is going to be Dr. Sandeep Serum Ready. Ready with an eye. If you have any questions, any queries, reach it out. ठीक है. But portal pyemia, the name itself is suggesting no. So usually what happens is whenever there's a bowel infection, especially your appendicular abscess, appendicular perforations, or any bowel infections from where the portal circulation, it goes and then causes liver abscess. That is called as portal pyemia. But a Lichtenstein, okay, so Lichtenstein tension-free mesh repair, you open the inguinal canal. It cannot be onlay, no. Onlay is under the subcutaneous fat. ठीक है. तो Lichtenstein में आप क्या करते हो? The external oblique aponeurosis, which is the anterior surface of the inguinal canal, you open it up, you mobilize the cord and you put the mesh on the floor. ठीक है. So mesh is pushed on the floor. So it cannot be onlay. ठीक है. So thank you so much for joining. I had an amazing session. You guys have been amazing. I've got like tons of students here. We have seen 100+ people watching live. Great to interact with all of you. One small message for the exam. ठीक है, I'll tell you, don't panic, don't do this, don't do that and all that. बात बड़ी simple है. You will not stop until you cross the line. ठीक है, एक बात याद रख लेना, nobody remembers who was second or who was the most hardworking or who is the most intelligent. All that it matters is did you cross the line or not. ठीक है, and I want you to see on the other side of the line. I will be waiting with a victory message for you, and I wish every one of you to excel in your exam. ठीक है. Thank you so much, guys. I mean, like every single word of appreciation is so much love from all of you. That gives me the energy. Like I don't mind if it is night 1:30, 2, 3, whatever it is. If the effort that I've put is translating into your success, that is a victory for me, right? So I try to do my best from my end. I hope you use it to your fullest capabilities and have fun. ठीक है? Don't panic. Don't try to run here and there for more material. Revise, revise and revise. ठीक है? All of you are putting this last minute of effort and they are putting with utmost dedication. It will translate. ठीक है? It will come across, right? Thank you so much, guys. I mean, I can't thank you enough. I mean, that's been an amazing encouragement from your end also. You've been constantly at the chat box. Every single person, I can't name it, but then you guys have been amazing. Thank you so much. Write the exam well. Do write us back and make sure you win. Okay? Thank you so much, guys. All the guys who are writing for FMGE exam, all the best, guys. Just go kill it. You're already a bomb, guys. Like, you know, you want to crack it. So don't worry about it. So I'm not going to waste any further time. I feel like I've forgotten everything 3 days before the exam. That's good. No. ठीक है, the burden from the mind is taken off. Relax. ठीक है, जाओ, खुश रहो, enjoy करो, पढ़ाई करो, और पढ़ाई करो, बहुत पढ़ाई करो. ठीक है. अच्छा, एक और बात. I don't know if somebody is telling you this कि बेटा कि you know no matter what 8 घंटे सोना है, 2 घंटे पर्सनल के लिए रखना है, अच्छा सा रेस्ट लेना है, उसके बाद पढ़ना ही नहीं. All that is nonsense. कॉम्पिटिटिव एग्जाम का एक ही रूल है कि बाजू वाले से बेटर परफॉर्म करना है तो उसको बीट करना है व्हेन ही इज गोइंग टू प्रिपेयर. ठीक है, यू हैव टू पुट 18 आवर्स पर डे. ठीक है, ये मिनिमम है, नॉन निगोशिएबल है. ठीक है, इसके पीछे तो सुई स्टार्ट भी नहीं होती. तो 18 घंटे देने 6 घंटे आपके हैं, उसमें आप सो, नाचो, गाओ, पियो, जो करना है करो, लेकिन 18 घंटे किताबों को देने अंटिल द डे ऑफ एग्जाम. एग्जाम की रात को पहले सो जाना, दैट्स द ओनली थिंग दैट इज रिक्वायर्ड. एग्जाम के बाद जितना मर्जी सोना है सो जाना. ठीक है, कोई दिक्कत नहीं, लेकिन 18 घंटे टिल द एग्जाम यू आर गोइंग टू इन्वेस्ट इट. दैट इज नॉन नेगोशिएबल. ठीक है, राइट. ऑल द बेस्ट, गाइस. थैंक यू so much. Loads of love. Take care. Bye. Good night.